tryst with TB was when my son, who was at that time 12 years old, had pleurisy. Now, we didn't even know what pleurisy was. You see, some of the best educated people can sometimes be very distant from these phrases. And then we were told that's the first stage before TB really takes over. And then the second tryst was when my daughter, a medical doctor, when my son, who was at that time 12 years old, had pleurisy. Now, we didn't even know what pleurisy was. You see, some of the best educated people can sometimes be very distant from these phrases. And then we were told that's the first. Can I go on? Technology at its best. So, and then, yeah. So the second time I came face to face with TB was when my daughter, who is herself a medical doctor, had TB of the glands. And then the third time was when I had these spots on my legs, and I didn't care because you're always thinking that there have to be some symptoms when you're suffering from something. Then one day I said to my daughter, I said, what are these spots there for? They're not painful or anything. Then we just went to a family doctor. So he said to my daughter, don't you know how to diagnose this? This is TB. So then I was on a treatment regimen. So that's how close we are to TB. And it's I think perhaps quite a household name, at least in the region where I come from. But today I have had very close encounters with people who've died of multiple drug resistant TB, and that region I think fares very high in MDR TB. So in fact, today I just went through some literature and found that India has the largest share of MDR in 2021 with 26% of global cases. So I think this is where perhaps we also need to pay some attention to, because in my interface with a lot of people who have had TB and then have regressed, is that they're not very sincere with the treatment regimen. How many people actually want to go on a 6-month treatment? If you look at the lower category of people, many of whom have to buy their own medicines, they feel that 6 months or even 9 months is too long a time to heal an ailment. And personally, I think it is the failure of the system to track and follow up. Now you have a lot of tracking from these Anganwadis and Ashas on pregnant women. I wish we had the same kind of, tracking system for TB. Once a person goes to the hospital, is given a set of treatment regimen, that person doesn't want to return to the PHC or the CHC again and again. I don't know, there is this something in us humans which is very resistant to the idea that we could still be having the germs inside us. So I'm asking for a very tall order, but I'm wondering if there is a way of reducing the quantum of treatment, if it's possible to bring it down to 3 months. If there is a drug regimen as such. I don't know whether we've even started thinking about that, because the longer the treatment, the more chances there are of people dropping out, of patients dropping out. And the problem is also of access to quality healthcare. You have healthcare, but what quality is that healthcare? I'm so glad that Molbio has come to Meghalaya to bring treatment to the people. The idea itself is very exciting, because all this time we had to drag people to the PHCs and the CHCs. Now treatment, or rather diagnostics, are going to the people. So that should help a lot. And today, the focus is on patient-centric care. I think this has a very wide meaning, and we need to digest that and break it down into more understandable form. What is patient-centric care? How do I make something patient-centric when there is a mother who, like somebody, you said that I come from a matrilineal society. The irony is that we have about 42% of homes that are led by women, because abandonment is very high, marriages are very brittle. So these women have to care for their children. Because we are a matrilineal, the children have to live with the mother. And most of the mothers in the rural areas do not have the wherewithal. They just are living a hand-to-mouth existence. Think of the burden then of that mother if she is to have TB. And I also come from a region that's very high on undernutrition, especially of children. You'll bear me out, Dari Bianca. All of the health indicators are very poor in Meghalaya. We're just one shade higher than Bihar. Nothing great to talk about. So taking all this into consideration, we have a huge burden. We already have a lot of MDR related deaths. So how do we go forward? Then there are patients I've spoken to who are very unhappy with the side effects of the medicines. We don't know how to deal with that. At least I don't know. I went through it myself on that 6-month treatment, and I had all kinds of, but I was educated enough to understand that I needed to complete that treatment and also to go for further tests to see that I am cleared of all the germs. It's also a great challenge for caregivers to manage things, because you need to think about what you call isolation. How do you isolate yourself in a 2-roomed house? These are challenges that exacerbate TB, actually. So the key pillars, I would think, are early diagnosis, as has been stated times without number, by the use of higher sensitivity diagnostic tests. And we saw that demonstration yesterday at Molbio. We are so grateful that you all are coming up with state-of-the-art facilities. Also, I'm here as a media person, and I feel that communication in the common person's language is key to helping any kind of outreach into the society. I think what we need to do is communicate not once, and I don't like this idea of once in a year TB day or mental health day and all. It doesn't help. It has to be sustained communication over a long period. I also don't believe in advertisements. They just take up space, and they pay us in the media fraternity, but they don't really reach the common person. Maybe we should even think of pamphleteering, because in the marketplaces, women read a lot. When they don't have customers, they read a lot. So communicating, especially in the local languages, I write for the vernacular papers as well, and I find that people read, they consume that sort of thing. So if we write consistently on one problem, there is a possibility that it will be imbibed. In my newspaper, we have one page dedicated to health. I keep asking doctors to please write for us in the culturally appropriate language, but I'm sorry to say we get very little of that. So most of the times we have to just download from the internet. I wish doctors were more communicative and that they try and write without jargons in the common man's language, because that's the only way to reach the last mile. I think if you have enough time to just script out 700 or 800 words, it's fine. It's fine. At least you are reaching out. And everything begins at the local level. All this top-down approach doesn't work. It's always bottoms up that is the best approach. We may have big promises at the national, at the global level, but how do we interpret things at the local level? That's where we have to work at, and that's where our challenge is. So that, our campaign is both cost effective and also effective uh, for the people who are listening and who will respond and who will sort of change their health-seeking behaviors. I think message testing also helps to uncover what is problematic about the message. We need to do this again and again. We need to revise. If we have given out a message, why is it not working? I think we need to be doing that again and again. And India is too diverse a country to have just one messaging system. We really have to understand what's happening down there at the ground and craft out a message. I think in doing that, you can take the help of media persons in crafting out such message. So we are trying hard, but are we succeeding? While we celebrate what we succeed, let's also accept that we have a long way to go and that we really need to work in solidarity. Thank you very much.
Thank you so much, Patricia. It was great to know. As a radio person, I really believe that communication should be as simple as possible, because the language we use in our even commercials and advertisements, the language is so complicated and it is so technical often that people, and it is meant for whom they simply don't understand. And I was going through this agenda. I was thinking that this should be translated to a better way, so that people for whom it is prepared, when it goes to the people, it should be, because lab has to move to the people and lab has to approach people. So the lab's language should be people centric. So the people who are not much educated, who are often who belong to slum, who are general people, they don't understand the complicated language. So I think that media workshops should be there for doctors and for the technical persons. I think as a media person, I would like to say, thank you so much, Patricia. It was great listening to you. The language was so simple, so that it was really good. Thank you so much for your impressive inaugural address. And now it's time for Nandita. You have already did it. So now I invite Nandita Venkatesan, a special correspondent, Mint, Mumbai, and she would be online.
Yes, on.
I just like to, hi Nandita, this is Ramya. I just like to say thank you for all the work that you've done, particularly taking on a corporate giant like Johnson & Johnson and making the way for, generally not just TB, but for cheaper generics in this country and perhaps around the world. Thank you so much. The floor is yours now.
Welcome, Nandita.
Thanks a lot, Ramya. Am I audible?
Yeah, you are. You are audible.
Okay. Thank you, Ramya. Yeah. So, firstly, thank you so much for organizing this and for bringing all of us together on this platform. And like Ramya pointed out, that I have done a substantial amount of work in the TB space myself. This comes from the fact that I'm a survivor of the disease myself, and I had to undergo this disease twice in my life at a very young age, when I was 17 and 23 years old. And I had developed a very severe form of the disease when right after I had finished my graduation. And sorry, right after I'd finished my post-graduation, I ended up developing a very severe form of the disease. And I took a very long process of treatment. I underwent all of that. And then in the process of taking the medications, I was given an injection that led to my complete loss of hearing. And I ended up losing my hearing completely because of a TB injection. And this happened to me like really overnight, in a matter of 15 minutes, when I woke up from an afternoon sleep, on exactly this month into 10 years back. I had lost my hearing in November 2013. And of course, at that point of time, I had barely had any idea about TB and what was the magnitude of the disease, because because everywhere I would hear, I knew that okay, there's someone who had gone through this disease, but I never really knew what big and what huge a scale it is in India, until I remember reading one day in the newspaper. I had read a front page article in one of the Mumbai tabloids, that the World Bank has offered a certain amount of money to India for investing in TB. And when I read that, that is when I remember thinking that wow, this is not a small thing that I had to undergo. It looks like a problem that is at a very big scale in India. And that is when I decided that even as I work in journalism, I should do my bit to engage in the TB space, to use my voice as someone who has gone through very horrible effects and had to undergo very horrible things related to this disease. And exactly around that is that we often, as this all of the seminars that I attend, and I have been attending a lot over the years, essentially talk a lot around the need for improved drugs. There's also now some conversation happening around post TB care, but the thing about diagnostics is often something that gets lost. And that is something, that is why I think that it is very important that we are all talking on this particular topic around how diagnosis is so very important in for TB, or for actually every disease. If you don't diagnose, then you're not going to find out what is the nature of your problem. And this is more so in TB, because we are seeing really worrying forms of the disease, such as the multi-drug resistant TB, XDR TB, pre-XDR TB. And it is like I said, that even today, I remember that a couple of days back, I had helped a colleague in my workplace. He had reached out to me saying that I think he's suspecting one of his family members to have TB, and if I can be of any help. And the first thing I asked him was that, can you tell me what are the tests you underwent? And I asked him, has anyone told you that you have to get a gene expert test done? And he said, no, we don't know what is this test you're talking about. So I wrote to him and I told him, look, this is the name of the test, CB, NAT, or gene expert. Please go and ask your doctor if this is the test that should be done, or did they even mention the name of this test anywhere to you? And yes, he was having his family member was having lung TB. And I realized that he had not done this test, whereas it was so much in dissonance to every conference that I attend on TB, on health, where every doctor I speak, every doctor who comes up on stage, say the first thing he says, or he or she says, is that you have to do upfront expert testing. And that is the word that is used. You have to do upfront gene expert testing. But when I see what is happening right behind me at my workplace, when people have reached out to me, I see that gene expert is still yet to become common, at least as a first line of diagnosis. And let me tell you why and how this is very important. of course, when I underwent the treatment myself, it, I was diagnosed personally at least 3 or 4 months late, which remember I had intestinal tuberculosis in 2007. And it was it was not something that was very common in India back then, when extrapulmonary forms of the TB were not very widely spoken about. And then I was, like I said, I was tested for every disease except for TB. And then it was only 4 months later that I was told that I was having tuberculosis in the intestine. But if I have to say frankly that even though things have moved, and I must admit here that that work done by me, work done by so many other so many other people have helped move the needle. But 3 months, I would say that I was fortunate enough that I actually got diagnosed in 4 months, and I only had a 4 month delay, because I know of people who have had 9 months and even close to a year of delay in finding out exactly, even if they are diagnosed with TB. Often what happens is that the gene expert test is not done, then they are put on the wrong set of medications, and then finally your disease progresses after that. And then when the test is finally done, they realize that, okay, they are already gotten resistant to a number of medications before that. And the doctor will immediately tell you, or this is what I have seen has happened, is that you are told that, okay, why did you not get this test done before? This is what has generally happened, and this is what happens even today. So I think I was very lucky that I actually faced only a 4 month delay, whereas I know people have had to face much larger amount of delays, even when better diagnostic testing is available. And particularly in TB, it is very important because, like I said, that we are having this drug-resistant forms of the disease. And if you don't diagnose it properly, then your disease ends up progressing to far higher levels. And there you involve much more toxic medications, which is what ended up packing up my kidneys at one point of time. I lost my hearing completely. All of this had to happen, and all of this is completely preventable if you follow the standard treatment pathway of providing better diagnostics, better drugs, and post TB care. That is all. This is the pathway that is needed, but somewhere in the pathway we tend to slip up, or we tend to lapse, and then things go downhill for several patients. So I really hope that, like I said, that I'm glad we are talking about diagnosis, because drugs and diagnosis go hand in hand. Each one it is interdependent on each other. If you get the diagnostics correct, then you will be put on the correct drugs. And thankfully there are, like I said, much better drugs available in the form, especially for multi-drug resistant TB, such as bedaquiline, delamanid, um, things for which a lot of us have stuck our neck out and fought for it, knowing that we didn't want others to go through what we went through, or what we had to undergo. And I'm glad that I know that there are TB survivors I know who are in the audience right now. And I really hope that this is a collective effort on everyone's part, from the media, from the survivors, from, I can see, from the doctors, everyone, to really push the needle for TB. And I hope we do something, and I hope something constructive comes out of this 2-day engagement that we are having. Thank you.
Thank you.
Thank you so much, Nandita. And friends, this is all from the inaugural session today. Thank you so much. Thank you, everyone.
Thank you, chairs, for being there. I now request Dr. Padma Priyadarsini, Director, National Institute for Research in Tuberculosis, Chennai, to please chair the next session.
Good morning. And first of all, thank you for organizing such a good session, away from medicine, away from doctors. It's nice to meet all you friends. I won't take much of it time. I know Dr. Soumya is online. Is she coming online? So a brief intro about Dr. Soumya Swaminathan, who needs actually no introduction to this audience. I think she's one of the favorites of the world of media, right? So I'm very happy to say she's been my tutor and mentor from the time I joined ICMR. Is she coming up online? She's recently retired from the WHO Chief Scientist post. Earlier, she was as a DDG or Deputy Director General of Programs. But more than that, I would like to say she had joined the National Institute for Research in Tuberculosis, earlier called as TB Research Center. She was with us for more than 10 years before she went on to become the Director General of ICMR and Secretary DHR. And then she moved on to WHO. Hi, ma'am. Good morning.
Good morning. Can you hear me?
Yeah, we can hear you, ma'am. So here she is, and over to you, ma'am. Oh, I did have 2 long pages of her introduction, but I think
Don't need it.
she's there on. Yeah, she doesn't need it. Yeah, there she is.
Thank you very much, Padma, and thank you to Shobha and the organizers for asking me to say a few words. And again, apologies for not being with you all today in person. I was in Goa a few days ago, actually, and was very happy to note that Goa is probably the first state that has 100% coverage of molecular diagnostics for people suspected to have TB, which is what the WHO standard is. And I think many people before me this morning have already spoken about why it's important to make an early diagnosis of TB. Now, looking at the world from the perspective of being the chief scientist at the WHO, especially during the pandemic years, what was very exciting was the innovation that was happening and the amount of science that actually there was the acceleration that happened in scientific discoveries related to COVID. The fact that scientists working on all sorts of problems around the world dropped what they were doing, whether they were physicists or they were modelers or they were epidemiologists or they were lab immunologists or virologists. And the result is that the amount of knowledge that got generated on the SARS-CoV-2 virus and its impact on humans within a matter of 3 years is unprecedented. We've lived with so many pathogens for so many years. Human beings have co-evolved with the viruses, with bacteria, with fungi in the environment, but never before. And a disease like flu, for example, for which probably it's the one virus on which there has been maximum efforts to study it because of the previous flu pandemics that we've had. And of course, the SARS-CoV-2 was the first non-influenza pandemic that impacted the whole world and therefore brought this unprecedented level of scientific inputs and new development of technologies. But actually, if you look at TB, it is a pandemic. HIV is a pandemic. These are all pandemics that have existed. And in 1993, the WHO did actually call TB as a public health emergency, but it does not find its place in the list of public health emergencies of international concern, what is called the fake announcements, which actually trigger a lot of action. So you have a disease like polio that's been there for a very long time. You, of course, have Ebola, you had Zika at some point of time, you had SARS, you have 1 and then SARS-2. Now the WHO is looking at actually modifying the international health regulations and also discussing a pandemic treaty. Why I mention it is that I think the discussions around the pandemic treaty are quite, you can link them in many ways, and TB could be a pathfinder. And this is what I've been saying wherever I speak, whether it's at G20 or other events, is why do we need to wait for the next pandemic in order to see whether we respond better or not. We actually have a disease, a pandemic that we need to address. That is tuberculosis. And of course, India is one of the most badly affected countries, but there are many, many countries around the world that, in fact, every country has TB. Of course, the low and middle income countries, they suffer more in terms of the burden. And why is it that this is not considered an urgent enough need or problem for the world to say, well, we can solve this problem? We did an amazing job with COVID. Can you imagine if a vaccine had not been developed within 12 months, how many more lives would have been lost? And it's estimated, that at least 2 to 3 million lives were saved just in the year of 2021 alone because of the vaccine rollout. Many more would have been saved if the vaccine had been rolled out equitably around the world. So we did see, while on the one hand, we saw absolutely stupendous scientific achievements, on the other hand, we saw the worst forms of inequity playing out. Unfortunately, in TB, we have experienced that for a very long period, where the resources that the Stop TB Partnership actually, monitors, the resources, whether it is for TB program implementation or whether it is for TB R&D, have always fallen far short. And they've been very modest. A requirement of 13, 14 billion in global aid over a year is nothing much. Most of it going to implementation, and I think the ask for TB R&D was 5 billion or something like that. The COVID vaccine alone saw a collective investment of more than 100 billion, and that too just over a period of 1 year. Only 5% of that investment went to low middle income countries. 95% was in high income countries. But anyhow, that did result in the development of dozens of COVID vaccines. Whereas you look at progress with TB vaccines, it's extremely slow. And while there are candidates at different stages of development, it takes years and years for those candidates to actually move from one phase to the next phase to the next phase. And the one candidate that we have, M72, which showed very promising results in the phase 2B study that we've known about since 2018. The results were published then. We're in 2023 today, and we still don't have a phase 3 trial of that vaccine because there were unanswered questions that needed a phase 3 trial. Of course, I think you could make the case for TB, MDR TB, that it is a problem that needs, innovative ways, also the regulatory pathway. Just like for COVID vaccines, we had regulatory pathways that were became more innovative, became more collaborative. Regulators of the world came together and discussed how to promote innovation without compromising on safety. And we did see this happening to a large extent. Of course, there were some hiccups in some places, particularly with the drugs initially. I think there were problems where drugs like hydroxychloroquine were being promoted in many countries without any evidence of efficacy. But sooner or later, I think that evidence-based decision-making and what we call the living guidelines in WHO, where we actually developed that methodology, and then it has been adopted by other departments in WHO. The living guideline is nothing but a continuous upgradation of your guidelines, updating of guidelines based on the latest available data from clinical trials, rather than the past, where one would wait several years, let a lot of new knowledge accumulate, then update your systematic reviews, then update your guidelines. And so if you look at TB in the past, how it was done and how the guidelines today, WHO is extremely, I think, has come such a long way from taking years and years to update their guidelines till now, on a very regular basis, having updated guidelines on diagnostics, on treatment. Unfortunately, on vaccines, there's been nothing really to update, but hopefully that will change. And so the whole approach of living guidelines, I think has, and that I must tell you, was driven by, in the case of TB, by TB activists from around the world. It was them who came, actually. I was DDG for programs in WHO at that time. It was the activists who came and spoke about the need to change the way that WHO was doing its TB guidelines, the need to include more TB affected people in the committees and the need to move much faster. That message was heard loud and clear by the Director General, and we implemented it very, very rapidly, despite some initial internal opposition to doing that. You know, there's always, when you want to change something, there's always a status quo, and that's some inertia on changing that. But it was overcome because came from the top, and it was very quickly implemented. And I give that as an example of how civil society can make a very big difference. We've seen that in HIV, and in fact, the parallels between HIV and TB are sad, because in HIV, the community fought and had so much of a voice, you know, and when you read about, you know, the initial early activists in the US, of course, these were all very highly educated, highly articulate gay men who had HIV, and then they were really able to, you know, pressure the system into, including the NIH. And Tony Fauci has talked about that experience of his, where as a scientist, he was not used to actually dealing with the community, but then when he actually, and they used to come and protest outside the NIH, etc., and there was a lot of clash between them. But then they became partners in the whole research enterprise. And they also made a lot of pressure on the regulators, and FDA also changed, you know, the way that speed at which they were approving HIV drugs. So I think that partnership in HIV and the funding that went to organizations of people affected with HIV and civil society organizations actually had a very different trajectory to how HIV, you know, has been handled, managed, and on the R&D side also, it's had a very huge effect. We haven't seen that in the TB community. There are many reasons, of course, for that. One being that majority of TB patients globally live in LMICs, poor countries, and they are also among the poorest within the countries. So we know also from our own data that, you know, there are certain states where there is a high prevalence of TB, and if you look at across all of the tribal areas of India, we know that the prevalence of TB is, you know, 2 to 3-fold higher. And in the Saharias, for example, in Madhya Pradesh, it is something like 8 to 10 times higher than what it is in the rest of the country. So I think we have to also look from the vulnerability point of view, but again, with a point from the viewpoint of actually doing something by addressing those vulnerabilities. So in terms of what needs to be done now, I think the good thing again is that in the recent few years, we have seen, even though TB is very slow compared to, let's say, the SARS-CoV-2, we've still seen a good amount of movement on the science side. We've learned a lot. We've got a lot more molecular diagnostics than we had before. We've got a lot more experience with genome sequencing. Again, thanks to COVID, the capacity for genome sequencing has expanded considerably. And we have the INSACOG, but we also have a lot of labs in the private and public sector that are now good at gene sequencing. How do we use that capacity to help with TB? During COVID, we were doing millions of molecular tests every day. Why we're not able to capture that capacity which exists, again, spread across private and public sector. The good thing is, again, we have a lot of research going into the point of care tests, the tongue swab based tests, which are showing good progress. They will not be as good as a sputum test. The sensitivity is likely to be lower, but that's okay because it will make up for the kind of population coverage that one will be able to do with a rapid test, which you can do, the person can do themselves or the health worker can do even at the person's home. So that will be a game changer if you just go with a rapid test and within a few minutes you're able to identify people with TB. And even if it has a lower sensitivity, you'll still identify a lot, because what we've seen from the TB prevalence survey findings in India, but this reflects prevalence survey findings around the world. So it's not a unique finding in India that over 50%, about 60-65% of people who have culture positive TB, they're infectious, do not know or have not sought care, either have not very severe symptoms or they have symptoms which they thought was due to something else. But whatever reason it is, 65% of people with TB who are roaming around in the community are not on treatment, have not sought care, and potentially infecting lots of other people. So there is also the spectrum we haven't fully understood of subclinical TB. And there's a lot of work going on in South Africa looking at this transmission. You know, we did a lot of work on SARS-CoV-2 transmission, on how actually an airborne pathogen spreads. TB is airborne. And therefore, what they're finding in Cape Town is that a lot of people walking around quite healthy, quite happy, actually are infectious. So what is happening? What is the dynamic that is happening in the community? Is it going to be different in South Africa compared to India? Within India, is it going to be different if you're living in a very highly overcrowded neighborhood compared to somebody, you know, who's living in your own house, etc.? So I think that research on transmission dynamics has been very minimal, and we really don't understand the spectrum of TB disease. We talk about latent and active, but actually it's not latent and active. It is a whole spectrum of TB disease, and some people are moving in through that. Some people are getting self-healed. Some people are dying without diagnosis, and some may carry on for a long time, you know, in that state where they're infectious but not sick, so they're not seeking care. So we need a lot more epidemiological, community-based research in different settings to understand that spectrum of TB, and accordingly our strategies and policies will have to change. We do talk about active case finding, but what do we use for active case finding is the big question. If you're using a symptom screen, you're going to miss all of these people because they don't think that they have symptoms and they're not sick. Should we be using mass X-ray screening? And that again is coming back in a big way. It was done, you know, in the 1950s, and then it was given up as being not cost effective. But today, understanding more about TB, should we really be building in X-ray as a first screening tool till we get like a, you know, a swab test or something? Read it through artificial intelligence. We have many algorithms, many companies now that have validated algorithms, and the ICMR has actually put in place a system for further validation of AI-based tools. We're talking about AI-based X-ray reading here. There are people working on AI for cough, just by listening to the cough pattern, etc. We're still not there in terms of diagnosing TB. I think it will be difficult. But there could be other AI-based solutions that come. But for now, we have AI-based X-ray reading. We have handheld X-rays. It's quite feasible to think about going into the community now, screening people, at least the high-risk groups, following it up with a molecular test, and which includes the resistance profile, and starting people within a few days on appropriate treatment. There's also work going on blood-based and urine-based. There's a LAM assay. There are other assays which are under development, but I think the most promising in the diagnostics are these two, the tongue swab-based assays and the X-ray with the AI reading, and these need to be scaled quickly so that we achieve the goals of 100% molecular test, at least for those who are coming into the system with symptoms, and then much larger screening of people with X-rays. Of course, that will also help picking up other lung lesions apart from TB, and we may then be in a position to diagnose more cancers early, and, you know, also other things that today we don't really detect. On the treatment side, again, there have been advances in clinical trials. We know now that we have 6-month regimen for MDR and XDR TB, which is highly effective, 4-month regimens for drug-sensitive TB, and a 1-month regimen for preventive therapy. So again, the recommendations are there. It's a question of implementing them, scaling them. And of course, in a large country like India, it is complex to completely change the regimen because of, you know, all the issues of drug procurement, supply chain, training of workers, and so on. And then on the vaccine side, I think we heard the TB vaccine accelerator that was announced by the WHO, which again, I was working on when I was there, because I think we all felt that we needed to accelerate it. But again, India could take a much bigger role, a lead. We showed our capacity during COVID. Huge number of vaccines were produced in the country in terms of volume, but also the variety of platforms we used: RNA, DNA, subunit protein, inactivated, viral vector. All the platforms actually were produced by different companies in India. And we know that they have the capacity to do it and also to scale it and to make it very affordable. So a TB vaccine made in India will be for the world, not just for India. And as I mentioned earlier, we have several leads around the world, but those need to be accelerated. We need more partnerships, global. We need government and private sector partnership. We need more funding, and we need to really identify those leads and support those groups to move forward quickly through a stage-gated process, where at every stage you can assess whether it's good to go forward or you stop it. So if you have a very large number of early leads, hopefully one or two of them will go through. But TB vaccine development is not going to be like, it's not easy, and we can't replicate COVID and think that we'll have a vaccine in a year. But even if it takes 5 years, ultimately, I think no infectious disease has ever been eliminated in the world without a vaccine. It's only when we talk about diseases like polio or measles, tetanus, etc., the only reason we can dream about elimination, or we've achieved it, is because we've had excellent vaccines with long-lasting protective immunity. So a lot more research on understanding immunity. As I said, this whole spectrum of subclinical TB, on developing new diagnostics, as well as on developing better vaccines. And finally, I would say that, I talked about the community involvement and people affected with TB, etc. The importance really of hearing their voices. What are their priorities? We heard Nandita speak just before this, and really want to congratulate Nandita and a lot of young people around the world who've really, after having suffered through TB, have made their voices heard and have made, substantive changes, including fighting, big pharma and things like that. So, kudos and more power to survivors. But the majority of survivors, I think, just get back to their lives. They have to get back to earning a living and looking after their families. Now, the rations trial in Jharkhand, which I'm sure that everyone is aware of, did show the importance of nutrition, both in preventing TB as well as in being a part of the clinical management of TB. And clinical management of TB, I think we all know for a long time that nutrition is important. The government does have some programs to support the Nikshay Poshan, which is more of a voluntary program, but also the DBT, which has been in there for a while, which is supposed to help people with their nutrition. So to support patients, yes, but the new finding really, and it showed that there's a 60% reduction in TB mortality compared to historical controls. It was not a randomized trial because it's unethical to withhold that from TB patients, but it did show that a 60% drop in mortality was possible by supporting initial TB patients with a nutrition basket. But I think what was the new finding, and globally for the first time, the trial showed that by giving a food basket to the households of TB patients, and these were all very poor tribal patients in Jharkhand with very low BMI, so undernourished, that you could actually reduce the incidence of TB, new cases, by 40%, and by 50% if you only took confirmed TB as the endpoint. That's a massive reduction. We don't have a vaccine that does that. So nutrition is available to us as a vaccine. We just need to target the right group. So I think if you see the central belt of India that is mostly tribal, that's mostly undernourished, implementing this program, at least in those areas, or in, let's say, in all the aspirational blocks of the country, take some indicator where there is more of poverty and undernutrition, then I think this type of nutritional support can bring down the TB incidence and can do it quite quickly as well. And so we may start seeing impacts because it's related to immunity. Once your immunity is low, you are prone to get reactivation of TB. If you build immunity, then like most of us who are living in India, why are we not all getting TB? we do have some, natural immunity. So, and it's very much, we know, is linked with nutritional status. So I think that is another important finding that's been highlighted. The UNHLM, which took place in September, obviously took stock and said that, we're not on track. In fact, the COVID set us back globally. And but again, coming back to what I was saying on pandemic preparedness and the fact that the whole world today is prioritizing pandemic preparedness and universal health coverage, which goes hand in hand. TB can be a pathfinder for pandemic preparedness. Are your surveillance systems working well? Are your labs well equipped? Do you have people on the ground to collect samples and transport them and get the results back? Your data systems working well? Are your supply chains working well? How's your R&D mechanism going? Every element of pandemic preparedness would be actually assessed against a benchmark of TB, and also the global collaboration I talked about. We need all the best scientists in the world to work on diagnostics, point of care, as well as on new vaccines, and of course, better treatments as well. So it is extremely important, I think, to continue to invest in TB R&D. And I mentioned earlier, India should and can be the leader here, bringing others together to address this problem. We will, of course, stand to gain the most and help to achieve the Prime Minister's target of TB elimination. But we can also help many other countries, in that process. So I think I will stop there, Padma, if that's okay, and hand it back to you.
Thank you, ma'am. Thank you. And it was very nice to give a bird's eye view of entire TB scenario. Now, traditionally, keynote address does not have a Q&A session, but I know people here want to have 1 or 2 questions. So you have time for that?
Yeah, I have another 5 to 7 minutes. I can stay on. Yeah.
Yeah. To the audience, there's Dr. Soumya.
Hi, ma'am. Anuradha here from Indian Express. So, I just want to ask about the TB vaccine.
I can't hear.
Actually, you can come here and ask the question. Come.
Hi, ma'am. So just wanted to ask you about the TB vaccine. You said, of course, COVID vaccine, you can't replicate. I mean, we can't replicate it in a year like how we did for the COVID vaccine. But, what really is the way forward? I mean, since everybody has been now, used to taking this vaccine and also, do you think the TB vaccine would really work? And how soon?
So, we're still waiting for the results of the trial that are going on with the recombinant BCG that's made by the Serum Institute of India, the German developed vaccine. And ICMR and the Serum Institute of India are doing multiple trials. One is to prevent the recurrence of TB in people who were treated already with TB. There's another trial going on among household contacts to see whether this vaccine can reduce incidence among household, because household contacts are at very high risk of getting TB. And the third trial they're doing, I think, is among healthcare workers to see if you can actually prevent infection. As you know, when nurses and doctors enter medical school or nursing school, that is a time at which they actually get the infection very rapidly. And if you do the test, you can see that every year more and more of them get infected with TB. Not necessarily disease, but they get infection. So I think those 3 studies that are going on will tell us whether that particular vaccine is better than regular BCG, because we know regular BCG is not very effective. There's also now, I think, being discussed is a launch of a BCG revaccination strategy by the government of India to see whether a BCG given to adults, adolescents and adults, could actually boost their immunity against getting TB reactivation or new infection. And so that, once it's rolled out and it's studied, will also tell us whether a BCG revaccination. So far, there's not been much great evidence of BCG revaccination really proving effective. But this is one more attempt at looking at that. Then there's another MTB Biovac from the Biovac that I think that Bharat Biotech has entered into a partnership. So they are going to be launching the trials very soon in India. But hopefully we can also push for an mRNA vaccine for TB, for example. Perhaps a DNA platform can be used. We need a consultation on this. There are academics around the country that have some leads from early research work on the discovery side. We have to see now how to translate those. And the reason I said it takes time is because, you know, the TB clinical trials, TB is a long disease. It has a very long latent period, and, you know, not everybody breaks down with, even if you take the high risk vulnerable groups, your incidence rates are, you know, 1 per 1,000, etc. So that's why it takes time, it takes effort, it takes a lot of resources. You need large sample sizes to be able to test the efficacy and the safety. So I think we need to work in parallel on all of these, including the regulatory pathway. There's also modeling work going on, and the modeling clearly shows that if you have an effective vaccine, even 50% effective, you will have a big reduction in TB incidence. So that modeling work also needs to be refined more based on the efficacy of the vaccine, what will be the cost effectiveness to introduce a vaccine, because we're talking about a huge population at risk in India. And therefore, and at what ages should it be introduced? So there's a huge amount of work, you know, to be done, not just in the lab on developing new vaccines, but on all these other aspects, so that we are ready with a policy when we actually have an effective vaccine.
Soumya, Ishwar here. Hello.
Hello.
I have one question. I know that you are no more in government, but you feel lot of pressure on government. There is a rifampicin INH combination, which is called 3HP, which is made in India, supply all over the world for last 2 years. One of the batch has already expired. Honorable Prime Minister made a commitment at the Global TB Summit on 24th of March in Varanasi, almost 8 months back, that we have this kind of molecule. But till today, it is not available in India. And just now, Patricia also said that we need to shorten the course. Now, rather than 180 tablets of isoniazid, one can take only 12 tablets of rifampicin isoniazid at a weekly interval. Yes. But that is made in India for rest of the world, not available in India. A lot of very senior journalists are here. They will pick up the issue. But I think you being ex-DG, ICMR, IHR Secretary, WHO, if you do something, I think it will be done in no time. Medicine is available in India, but is not part of the program.
Yes, thank you, Dr. Gilada. I think you've raised obviously an important issue. And while the recommendation, I think, is accepted in India, basically it needs to see the implementation. And there must be issues with, I suppose, with procurement and supply, which is why it has been delayed. But yes, the 1/4/6/24, you know, call that was put out by TAG and others last year, that includes this either a 1-month regimen for preventive therapy or this 12-week rifampicin isoniazid course. But, you know, again, I think we need more research. I'm not convinced that this type of approach of preventive therapy, which we will be giving, we're supposed to give to children under 5, but we're also supposed to give to household contacts, other high-risk groups. You know, for HIV, it has been successful because you have people with HIV coming to a particular place to collect their ART. They are very well aware of what is needed. It is easy to implement. And that is why if you look at global targets, the only target that was met was preventive therapy among HIV. Now, here we're talking about anybody who's susceptible to TB should, you know, be taking this. And when you're living in a highly endemic situation where there is TB all around, how long is this course of preventive therapy going to protect you? You see, preventive therapy protected people when they did the trials in the high-income countries in Alaska and all. You had latent infection, you took this, that infection got cleared. But subsequently, if you're going to be continue to be exposed, if you're living in Dharavi with 10 other people in a single room without any windows, and you take the preventive therapy for 6 weeks, are you going to be protected for a long time after that? I'm not sure. So this is why I kept mentioning that we have not really understood the transmission dynamics of TB. We are following certain wisdom which has come to us traditionally. But have we gone into the details of really understanding how transmission is happening? And Dharavi would be a very good place to study this, which will then inform our strategies. So while, yes, at the moment, the standard of care is to give preventive therapy, we should be doing it. But we should not think that that's going to solve the problem of TB in the country. I think we need many more tools and much better understanding, and see whether, different lengths of treatment are going to be needed. Whether for active TB also, we know that some people can be treated in 2 months, some need 6, some need 8 months. One standard thing is probably not going to. So if you implement 3-month or 4-month regimens, you'll probably get more people reactivating later, recurrent TB. So it's a question of trade-off. You want more people to complete the treatment. When you shorten it, you're willing to accept a slightly higher recurrence. Similarly, if you do a point of care test on the tongue swab, you will pick up maybe 60-70%. Maybe you're going to miss a chunk. However, these people you're picking them up very quickly, very early. Similarly, I think for preventive therapy, we need to really discuss going into the science of how these regimens are working and on whom and for how long, because these are all cost a lot of money actually to scale it up. So what I'm saying is, yes, let's use existing tools and roll them out. Definitely, for sure. Let's implement them. But can we have much more investment going into really digging into this disease, which we don't know? And I mentioned at the beginning, we learned so much about COVID in these 3 years. I think there's so many gaps in understanding of TB, which we have not even scratched the surface.
With Dr. Soumya. So with this, I take this opportunity to thank you once again, Dr. Soumya, as well as the organizer. And thank you, ma'am. And back to
Thank you. Thank you very much. All the best for the rest of the
I am online. May I please take a question? I'm online. I'm coming in from Mysore. I'm Bharti. I just had a very quick question for Dr. Soumya. May I please ask this question? With the permission of the chair?
Yes, please go ahead.
Good morning, Soumya. It's lovely to see you again. So I just had a very quick question. As a layperson, it seems somewhat unfair to me that simply because COVID had that sense of urgency, it killed very rapidly. It just killed people. So there didn't seem to be an option. You had to do things, and the same urgency, because it's not there with TB. Is that one of the reasons that, we sort of say, okay, this is, it's not an overnight killer. It's taking time. So is there a way to bring that same sense of urgency into finding vaccines for TB as well, given all the limitations that you spoke about? It just, to the layperson, it seems very, very unfair. So I think this is a point that we in the media need to also write about a lot more.
Yes. You're right that people were so scared with COVID, right? Because it was affecting everybody. It was killing people. And we had no tools against it at the beginning. And therefore it galvanized. And that, I think you can understand that reaction. TB kills because, as we know, it's #1 killer in the world. Before COVID also, it was the #1 infectious disease killer. And now again, from 2022, it's become. So only for 2 years, COVID overtook. So it's not like TB doesn't kill people, but it's killing very poor people and in places, and these people are not visible. They're They are in some in high-income countries, but the majority of them are not in high-income countries. And therefore, it's the usual problem of investments being much lower when the problem is basically being faced by LMICs compared to some problem like HIV or like COVID that was affecting everybody, including the high-income countries. So this is historical. We've seen it. It is not very surprising or shocking, even though it's very tragic, if you ask me. And when there is so much of lip service being paid to equity in global health, it's clearly a disease and an example of where there is neglect, despite all of the lip service and all of the promises and all of the high-level meetings that have taken place. So it is an example of global inequity, I think, in terms of allocation of resources. If you look at the Global Fund, for example, TB gets a much smaller proportion, only 18% compared to HIV or malaria. And there were massive calls last time around for increasing that funding for TB, at least from the Global Fund. But that did not happen. It still stuck to 18%.
Thank you very much. Thank you, Bharti, and thank you, Dr. Soumya. Thank you for being with us today.
Thank you, Shubha.
I now invite Daksha Patel. You are familiar with her. She's been introduced earlier. And Selena Menezes from Global Alliance of Human Rights to please chair the next session.
Good morning, everyone. My name is Selena. I'm from Goa. Welcome you all to Goa. It's my hometown, and I'm born and brought up here. It's very interesting topic for me, especially because TB. I have lost my husband, who was undiagnosed TB in 1996, and I had myself TB in 2007. It was Glenn's TB, and I took TB treatment twice because first diagnosing was a challenge for me. I was in Delhi during that time, and it was diagnosed in AIMS hospital, but I had to go for the diagnosis. First time it was negative. And after 3 months, again, I had to go for diagnosis because I had one big gland in my underarm, as well as I had one more gland here. So it was not pulmonary TB, but the gland's TB. But then for a person, it is very important what a person is going through when you get TB. It was like I am very good at Google searching and pressure and depression during that time, because I thought it was like Google said it was non-Hodgkin stage 2 lymphoma cancer, the symptoms which I had, and I was so depressed, and doctor said you have to okay. Google said it was stage 2 cancer. So, and then doctor said, my personal doctor, that was Dr. Dipanjan Roy, and he said, you have to go to the government hospital. If it is cancer, then you have to do all the tests in the government hospital, because you will not afford the chemotherapies. So I was so depressed, and finally it ended up with TB. So I took, I went to the DOT center. DOT center was not able to provide me treatment because I was working and I could not go to the DOT center every day or every week to receive the treatment. And I was working with INP Plus during that time. and I was traveling. So the treatment was, I had myself was difficult. So I had to buy the treatment to get the treatment. After the 6 months, so then the doctor prescribed me antibiotics. And along with the treatment. So I during the TB treatment, I also had vision loss, wearing very heavy glasses. When it comes to TB treatment, TB, we really need patient-centric treatment. When a person is coming to the TB treatment, TB center, why we want lab to the people is like we have to make sure that person is not losing job. We have to make sure the timing for the treatment, the person can come and take the treatment. We need to make sure that we trust the patients. Patient says, I can trust one friend of mine who can administer treatment. I don't have to come to your center because there may be discrimination, or there may be status disclosure problem. So we need to understand what the patient wants. So listening to the patient's stories, I feel that it is very important. And then the treatment at the moment we have I know it is MDR treatment. We have to go through 1.5 year of treatment, which is 33,500 pills, along with 85 to 130 injections. And then you have side effects of hearing loss and kidney failures and all that. And then DRTB, it is 6 months, 360 pills. And that also is having nerve damage side effects, and then vision loss. MDR-TB has hearing loss. And then the IPT, which we have, is 6 months, and it is like along with HIV, for example, if we are taking, it is two treatments at the same time. It is very toxic, and many people are not able to tolerate the treatment. So 1 month treatment, which is which is not accessible for us, and it is just 1 month, once weekly pills, and it is just 36 pills total. So that would be very easy for us, and people-centered with experiences. And if we can get the diagnostics and treatment on time, it will be very easy. So I just keep it here because I have lots of things to say, which is when we come, and we'll have to go along. Thank you.
Thank you, Selina. And there is a true story, like she lost her husband, I saved my husband's life. क्योंकि जब 2007 में जब मैं भी bedridden थी because of my HIV medicine side effect, and my husband had a very severe some symptoms, but he doesn't know that what is going on with him. So who will care for each other? That was the biggest challenge. And diagnosis, it was another challenge. So I was in hospital during that time. I asked my doctor, Dr. Harsh Toshniwal, sir, you know that. So I asked my doctor that I am inpatient and I'm worried for him because I'm in mental trauma, that what's going with him. And he diagnosed during when I was in hospital, and he found TB positive. So that was long story, as Selina told, but thanks God that he is still with me, and we both are taking care of both of us. So yes, exactly. The topic is very interesting and very life-touching personally to us because we are handling two diseases in our body. One is HIV, and always worried for TB because we are always focusing on to manage our immune system. So at least with HIV, we are treatment adherence fully focused, and we ensure our nutrition, our health care, everything will be in place. So we will minimize chances to get TB, और वो TB के वायरस को जागरूक करने के लिए हम उसके लिए थोड़ा केयर ज्यादा ही फोकस करते हैं. एंड ऑफ कोर्स जो अभी अप्रोच हम कम्युनिटी सेंट्रिक अप्रोच की जब हम बात कर रहे हैं, तो दिस अप्रोच विल रियली हेल्पफुल, क्योंकि मेडिसिन रिसर्च always work, and but with medicine, with medicalized system, care is very important. Until unless जो भी major trauma, after shock, या जो भी challenges, because TB is not only like one disease, but it is like complex issue. We all discussed a lot from in within half day. So true client approach, like prioritize the needs of client and preference, क्योंकि जैसे सलीना ने बताया कि कब मेडिसिन में लेने जा सकती हूँ, किस सिस्टम में मैं जा सकती हूँ, which is very accessible from my hometown or home, so which center is more feasible for me. So this is the thing, and rights of individuals. This all are very important to ensuring comprehensive and patient focused care, because until unless we can't find all TB to stop TB. So now I'm requesting to Vijeta Kumari to share her life experience, because already two experiences are here, but we are very happy to hear about your life and learn from your life story.
Namaste everyone. My name is Vijeta and I'm MDR TB survivor as well as a TB champion. So I have suffered with TB for almost 5 years. So you must be wondering कि ट्रीटमेंट तो 6 महीने का होता है, ज्यादा से ज्यादा 24 महीने का होता है, तो ये 5 साल कैसे हो गया? तो इसका आंसर है मिसडायग्नोज, लैक ऑफ अवेयरनेस एज वेल एज नेग्लिजेंस. जब मुझे सिम्टम्स आना स्टार्ट हुए थे, तो डॉक्टर ने एक्सरे किया एंड माइक्रोस्कोपी टेस्ट के लिए मुझे सजेस्ट किया. तो उसके बेसिस पे ही उन्होंने मेरा फर्स्ट लाइन ऑफ ड्रग्स जो है वो स्टार्ट कर दिया था इन 2013. आफ्टर दैट 6 मंथ्स के ट्रीटमेंट के बाद जो है मेरा टीबी जो है रिलैप्स हुआ. देन दे स्टार्टेड सेकंड लाइन ऑफ ड्रग्स. तब भी नहीं उन्होंने जो है कोई भी मतलब मॉलिक्यूलर टेस्ट किया जैसे जीन एक्सपर्ट. Then 2014 में second line of drugs मैंने लिया and I have dropped my college. I was doing MBA at that time. उसके बाद 9 महीने का ट्रीटमेंट लेने के बाद again in 2015 October blood vomit हुआ. Then I was diagnosed with at this time with MDR TB. उस टाइम जब मैं पीजीआई चंडीगढ़ में थी, उन्होंने मुझे सजेस्ट किया कि आपको जीन एक्सपर्ट टेस्ट करवाना चाहिए. तो ये स्टोरी थी जो कि 6 महीने या स्टार्टिंग से ही मे बी इट वाज MDR, तो मेरा कितना टाइम बच सकता था. लेकिन ये थी मेरी स्टोरी. लेकिन ये मेरी स्टोरी ही नहीं है, बहुत सारे लोगों की स्टोरी है. नंदिता दी, जिनसे मैं काफी टाइम से उनको जानती हूँ, अपने ट्रीटमेंट के टाइम से उनको जानती हूँ, उन्होंने मुझे बहुत गाइड किया था उस टाइम भी. सो अगर मेरा डायग्नोज हो जाता तो मे बी मैं इतना सफर नहीं करती, और जो बाकी लोग हैं मे बी वो भी इतना सफर नहीं करते. बहुत सारे लोगों के साथ ऐसा होता है. सो व्हाट वी कैन डू नाउ, मेरी कहानी तो हो गई, बट आगे किसी के साथ ये चीज ना हो, व्हाट वी कैन डू नाउ. सो मेन चीज जो है डायग्नोज. अगर जैसे एग्जांपल लेते हैं कि अगर हम एंट्री गेट ही बंद कर देंगे किसी चीज का, तो उस चीज वो अंदर ही नहीं आ सकती. सो फाइंड ऑल टीबी टू स्टॉप टीबी. सो फर्स्ट चीज जो है वो डायग्नोज है. उसके बाद बहुत सारे फैक्टर्स जो है वो आते हैं. तो हमारा जो मिशन है कि 2025 तक हमें टीबी एंड करना, एंड टीबी एक मिशन चला हुआ है. तो डू यू थिंक वी कैन डू इट? बिकॉज 26 मंथ जो है रह चुके हैं एंड टीबी केसेस आ रहे हैं, और भी बहुत सारी चीजें चल रही हैं. लेकिन अभी तो हम डायग्नोसिस के बारे में ही बात करेंगे. तो उस चीज के लिए हम क्या कर सकते हैं? तो फर्स्ट है अर्ली डायग्नोसिस. अगर हम लैब को ही लोगों तक ले जाएं, क्योंकि लोग तो नहीं आने से उनके ऊपर छोड़ दिया तो वो नहीं आएंगे, बिकॉज ऑफ lack of awareness as well as stigma associated है. So what we can do, we have to bring lab to the people. We have to make it people centric approach. हम क्या कर सकते हैं, जैसे मेरी एक सर है, गुलशन सर है, डॉट सेंटर ऊना में, आई हैव टॉक टू हिम. तो बहुत खुशी की बात है कि वहाँ पे 5 हेल्थ केयर सेंटर्स हैं एंड उनमें से 4 हेल्थ केयर सेंटर में TrueNet मशीन है ऑलरेडी, और 2 CBNet मशीन जो मेन जो सेंटर है उसमें है. वी आर प्रोग्रेसिंग. लेकिन अभी मैं पीछे एक प्रोग्राम में गई थी, ट्रेनिंग प्रोग्राम में गई थी रीच में, वहां से बहुत सारे स्टेट से जो है सर्वाइवर आए होते, तो उनसे पता चला कि बहुत सारे ब्लॉक्स में जो है वो मशीन अवेलेबल नहीं है. तो हमें जो है लोकल कम्युनिटी के साथ मिलके लोगों को अवेयर भी करना है, और लोगों के जो स्क्रीनिंग, जो हर पर्सन की स्क्रीनिंग होनी चाहिए, क्योंकि पर्सन को अगर सिम्टम्स भी है तो उनको पता नहीं होता है कि ये TB के सिम्टम्स है, और वो घूमते रहते हैं एंड वो बहुत सारे लोगों को इन्फेक्ट कर सकते हैं. और बात की जाए लेटेंट TB की, हमारे बॉडी के अंदर जो है मेन साइड जो होती है TB बैक्टीरिया के, वो लंग्स होते हैं, तो उसमें TB पड़ा रहता है, वो किसी को नहीं पता, सिम्टम्स नहीं है. लेकिन जब पर्सन की इम्यूनिटी वीक होगी तो वो TB जो है एक्टिव हो जाएगा. तो व्हाट वी कैन डू, जो एक्टिव केसेस है उनको तो डायग्नोज करें ही, लेकिन जो लेटेंट है उनको भी हम डायग्नोज करें, प्रिवेंटिव थेरेपी दे के फ्यूचर में होने वाला जो चीज है उसको हम अभी रोक सकते हैं. इसके अलावा वैक्सीन की बात की है, वो अभी इन प्रोग्रेस है, तो जो अभी हम करंट चीजें कर सकते हैं हमें उस पर फोकस करना चाहिए. तो मैं ये क्यों बोलूँ कि माइक्रोस्कोपी टेस्ट को हमें रिप्लेस करना चाहिए मॉलिक्यूलर टेस्ट से. तो फर्स्ट वो जो TrueNet टेस्ट है वो एक क्विक टेस्ट है, आपको 2 घंटे के अंदर रिपोर्ट मिल जाएगा, आपको पता लग जाएगा कि फैम्पिसिन या आइसोनाइट्रिन जो है रेजिस्टेंट है कि नहीं है. इसके बाद क्या हो सकता है, और इसके अलावा जो है हमें जब पता चल जाएगा तो हम इफेक्टिव ट्रीटमेंट पर्सन को दे सकते हैं. इससे जो इससे डिजीज का प्रोग्रेशन रुक सकता है, जो कॉम्प्लिकेशन होने के चांसेस हैं अगेगा ही, और साथ साथ उसकी कॉम्प्लिकेशन भी बढ़ सकती है. थर्ड जो मेन फैक्टर है इसमें जो कम्युनिटी ट्रांसमिशन जो बहुत ज्यादा होता है TB का, ऑब्वियसली मेन चीज वही है, तो वो चीज जो है वो रुक सकती है. तो इसीलिए अर्ली डायग्नोज करना, बहुत अर्ली एज वेल एज राइट डायग्नोज करना बहुत ज्यादा जरूरी है. और ये जो वर्कशॉप है, इसका जो मिशन है फाइंड ऑल TB टू स्टॉप TB, ये जो मॉलिक्यूलर टेस्ट हैं अगर हम अवेलेबल करवा सके हर ब्लॉक में, और ऐसी अप्रोचेस अप्लाई करें कि लोग भी, हम उनके पास जाएं, जैसे बहुत सारे आशा वर्कर्स होते हैं और मतलब बहुत जो लोकल कम्युनिटी के साथ वर्क करते हैं, उनके थ्रू जो है सबकी स्क्रीनिंग की जाए, तभी हम 2025 तक, honestly I don't think it will be done. It's my personal experience, because it's not like early diagnosis, there are other factors also जिसकी वजह से हम 2025 तक नहीं कर सकते, but we can get close to it. कुछ ना करने से कुछ करना is much better. इसके अलावा जो है कुछ और चीजें भी है जिसके डायग्नोसिस इज द मेन फैक्टर. डायग्नोसिस के बाद हम आते हैं ट्रीटमेंट पे. तो ट्रीटमेंट में क्या है, ट्रीटमेंट में अब रोल आता है अवेयरनेस का, पहले भी होता है लेकिन यहाँ पे अवेयरनेस का होता है. लोग नहीं बताते हैं, TB का ट्रीटमेंट कंप्लीट कर लेते हैं, खाते हम भी हेल्प करते हैं, आफ्टर दैट दे आर नॉट एबल टू स्पीक अबाउट TB कि मुझे TB हुआ था. वो प्राउडली नहीं कह सकते कि मैंने ये बैटल जीता हुआ है, नहीं बताते. मेरे पर्सनल एक्सपीरियंस है. सॉरी, आई अर्ज पीपल टू कि अपनी स्टोरी बताइए, क्या पता आपकी और किसी और की स्टोरी सेम हो, किसी को इंस्पिरेशन मिले, किसी को मोटिवेशन मिले. नहीं, हम नहीं बताएंगे ढिंडोरा क्यों पीटना इस चीज का. सो दे आर द थिंग. एंड इसके अलावा जो है TB मेडिसिन स्टॉक आउट शॉर्टेज चल रही है मेडिसिन की. आई वांट टू ब्रिंग अप दिस टॉपिक हियर. सो अगर मेडिसिन ही नहीं मिल रही, हम डायग्नोज भी कर ले, मेडिसिन ही नहीं मिल रही, तो उसका फायदा क्या है. मेडिसिन खाएंगे नहीं लोग, अगर वो 2-3 डोज भी मिस करते हैं तो ट्रीटमेंट की इफेक्टिवनेस जो है वो कम हो जाती है. सो वी हैव टू मेक श्योर कि सबको मेडिसिन ऑन टाइम मिले. एंड देन वी कम टू द हेल्दी लाइफस्टाइल, देयर डाइट. क्योंकि इम्यूनिटी कैसे बनेगी, मेडिसिन तो पर्सन खा रहा है, मेडिसिन इज नॉट अ सिंगल फैक्टर जो TB ट्रीटमेंट को इफेक्टिव बना सकता है. वी हैव टू फोकस ऑन देयर डाइट ऑल्सो. देयर इज अ निक्षय मित्रा योजना where anyone can adopt any TB patient, और उनको थ्रू आउट द ट्रीटमेंट जो वो अब डाइट जो है अपनी जैसे भी होता है वो डाइट उनको प्रोवाइड कर सकता है। एंड दिस जिससे आफ्टर टीबी किसी को डायग्नोज हुआ तो उसके बाद ही वो फॉलो अप ले सके, उसके बाद सॉरी उनका तबीयत कैसा है, कैसे वो रह रहे हैं, ताकि क्योंकि वो रिस्क में होते हैं। जब मेरा ट्रीटमेंट खत्म हुआ था 5 साल बाद, तो 2 साल तक मैं बीमार रही, मतलब बीमार इन द सेंस कि कभी कोल्ड हो जाना, कभी कफ हो जाना, कभी गला खराब। वो बहुत ही डिस्टर्बिंग चीज होती है, क्योंकि आफ्टर जो रियल रिकवरी होती है आफ्टर ट्रीटमेंट ही स्टार्ट होती है। एंड जब आपका ट्रीटमेंट खत्म हो जाता है तो नॉर्मल उसमें आना जो है बहुत डिफिकल्ट होता है, बिकॉज आप बहुत सारे साइड इफेक्ट से गुजरे होते हैं। एंड कुछ साइड इफेक्ट्स होते हैं जो आफ्टर ट्रीटमेंट भी होते हैं आपको, जैसे कि नंतर जी ने बताया था कि हियरिंग लॉस हो गया था। मुझे हियरिंग लॉस नहीं होता, किसी लेवल तक जो मेरी जो सुनने की क्षमता है वो कम हो चुकी है। इसके अलावा बीप साउंड जो है कॉन्टिन्यूस मेरे चली रहती है, समटाइम्स लाइक सो लाउड कि मुझे मतलब साथ वाला कुछ सुनाई देना जो वो बंद हो जाता है। इसके बाद हेयर लॉस, स्किन प्रॉब्लम, और सबसे बड़ा फैक्टर स्किन प्रॉब्लम, स्किन काली हो जाती है, पीली हो जाती, पीली नहीं सॉरी रेड हो जाती है। तो वो बहुत होता है कि हम कैसे जाएंगे, सब तो ये पूछेंगे यार क्या हो गया तुम्हें, तू ऐसी थी वैसी थी, ये वो बहुत। उसके लिए क्या करनी चाहिए, काउंसलिंग। तो काउंसलिंग भी ड्यूरिंग ट्रीटमेंट भी करो, स्टार्टिंग से भी करो, इवन आफ्टर ट्रीटमेंट भी काउंसलिंग वेरी इंपॉर्टेंट है टीबी पेशेंट्स के लिए। सो दिस इज ऑल फ्रॉम माय साइड, थैंक यू सो मच।
थैंक यू सो मच विजेता। ये असल में विजेता है, शी हैज वोन यू नो बैटल अगेंस्ट एमडीआर टीबीज, और इसलिए भी विजेता है क्योंकि शी हैज रिजन टू यू नो spread awareness and make a change. Please keep your pens ready. She is also a social media influencer. Please tell your channel.
So I'm having a YouTube channel also. Its name is MDR Survival Journey. You can search there on Instagram as well as on YouTube channel. Thank you so much.
तो विजेता जो हमने बताया था कि रियली वी लर्न लॉट फ्रॉम योर लाइफ स्टोरी, एंड थैंक यू सो मच कि इतना ओपनली आपने, और नॉट ओनली पेशेंट पर्सपेक्टिव बट मेडिकल थिंग्स आल्सो यू मेंशन्ड वेरी वेल. So thank you again, Vijeta. Now I am requesting to Archana from GCTA. Yeah.
Hi, I'm Archana. I work with GCTA, which is the Global Coalition of TB Advocates. And GCTA is a global platform. We have members, more than 500 from 77 countries. And basically, actually, what we try to do is that we try to make sure that community is involved in all the processes, not just as a mere recipient of services. And I think the speakers before me have done my job, quite there's not much for me to share as well. But coming back to the points of why people-centered TB response, I think I don't need to say it now. I think we all must have realized that people-centered TB response is the urgent need. I mean, we all know that TB is preventable and curable, but we still know that it is the major public health global challenge globally. And also we know that annually it's about 10 million people fell ill with TB every year. And we need this people-centered, rights-based response, because that's the only way that we can address this. We have to make sure that people are involved, not to be, so that they remain in the continuum of care, so that they don't, become the laws to follow up and all. But why is it that it's not happening? I mean, this is something that we all need to, consider. And I think we all must have also, I think we already know the answers. Like if you like the speaker, the Dr. Soumya was talking about the community activism. The community activism when it comes to HIV or when it comes to the drug user. Like I've worked extensively among the drug users and the HIV community. So it's like there was no medicine at the time, but the community was, so empowered that when the medicine came in and when they knew what to do. Whereas in TB, when you look at it, it has been traditionally a medicalized approach. I joined GCTA in 2019, and then we had a global consultations. And what we realized is that, many of the people with TBs, they don't even realize that their rights are being violated. Like they don't even realize that they have a right. So maybe it's because of the fact that, which Dr. Somya said, that it's mainly a disease of the poor. So we have also need to consider the social determinants. Now, when we talk about people-centered rights-based approach, I mean, it is very easy. It's just like, people-centered rights, but it's a very difficult thing. And when you look at the global declarations or any of the or the UNHLM, we say that community has to be involved. But how are we going to meaningfully engage with the community? That is something that we all need to think about. It's not just like we need to start involving the community in the monitoring aspect. We need to start involving the community in the planning aspect. It's not just like you start thinking of, involving the community because that's a parameter or that's an indicator as part of the project. It's not the way, that's not going to work out. Like, for example, if you look at the harm reduction movement in the country, the OST, the opiate substitution therapy, was implemented by community. It was, I was working at SASO at that point of time in 2000. It was implemented in 4 sites. And it was purely, the community members, they mobilized some amount of money and they did a piloting program. And look at where it is now. OST is under the NACO programs. Like you have got OST centers at the CBOs, you have got OST center at the primary healthcare, you have got at the state level hospitals, you have got it at AIMS, you have, everywhere it is being scaled up. And similarly with the HIV movement also, like Subrad and all, we were part of the PFI round 4 project. And so it was like, we were as there, PFI was there as a monitoring aspect, but the program was totally handled by the INP at that point of time. It was decentralized till at the district level. So why is it that we are not repeating the same thing, which has really worked well, earlier in TB? TB is still being taken as a medicalized approach. And we're talking about community, like, we spoke about the TPD treatment now. We did the CLM in a very small sample of studies at Delhi, the past 3-4 months back. And many of our stakeholders, they don't even want to hear the word CLM. It's like, how can the community be monitoring the program? These attitudes won't work well because we're all here to end TB by 2025. So we won't be able to end it because availability is one thing. We have got developments happening in the medicine, we have got developments happening in research and development, but accessibility is also something. You need to empower the community. There has to be a demand from the community itself. There has to be, we have to work in such a way that there has to be a demand from the community. There has to be demand from a household context saying that, hey, listen, my brother is suffering from TB. How do I protect myself? It's not something like we go and find out, you need to do this, do that. So in order to do that, we need to invest in community. We need to make sure that they are empowered so they know what needs to be done. Like Dr. Patricia was telling that, when you write in a local language, then it has to be done in a very consistent manner, not just writing about TB at the time of, World TB Day. I'm very sorry to say this to our media friends, but we get a lot of phone calls during when this thing like World TB Day is going to happen, then office mobile phone will start ringing this. So please, we have all our friends over here. Please make it a point to write consistently because that's the only way that's one of the strongest medium that we can empower the community. And I guess that's it. I'm happy to take any questions or any feedback if there is any. Yeah. Thanks.
In a very simple language. I think yeah.
So, I just wanted to just give my 2 cents on that. So
Yeah.
I think we are doing a little bit more than just writing on World TB Day.
Yeah. Thank you. And another thing which I would like to say is that, in the the CLM study, which we the kind of a small assessment which we did among the household context, it was a very short sample, but the people whom we have interviewed, none of them knew the medicines that they have been taking for. That's a level of awareness in the community now.
So this is not a question to you, but very nicely.
Since we are running short of time, so we'll start talking for the next session also. I think our speakers have said a lot about the experiences, and I would like to close this session with just would like to say that we have our responsibilities as well as rights. Those people who get TB, they have rights and of getting treated on the right time and getting cured also. With this, I would like to say that just would like to pose one question. Are we safe when we talk about people, survivors? But at the same time, are we safe in this? Why can't we have this as an emergency call in getting people tested for TB? Like COVID, we had emergency where at the crowded places, at bus stations, everywhere, those people who are more at risk, because TB is not like HIV. HIV is a behavioral disease. At least people know that how I will get HIV. But when it comes to TB, we don't know how we are going to get it. When we go to crowded places, in the buses, in the waiting rooms, in trains, everywhere, how can we protect others also from TB? Call here we have multiple partners. Media is more of a like getting to reach everyone with the information that everyone could be at risk, and if you have any problems, come and get tested and get treated also. It is curable. It is treatment is free. Thank you so much.
So thank you all. Yeah.
Thank you, chairs. And moving forward, I request Mr. Prabodh Bambal, Executive Director, Union Southeast Asia, and Ms. Banjot Kaur, Senior Correspondent with The Wire, to please chair our next session on innovative new TB diagnostic tools and deploying them innovatively. There will be time for discussions later on, so just hold on for some time.
So, good morning, everyone. I see that is this working fine? I see that, well, we're behind time, and we have a long list of impressive speakers that are going to speak next. But I'd like to just say a few things. First, thank you, Shobha, Bobby, for inviting me here today. A special thanks to Tara for also being part of this group. I joined TB in 2001, and I think I just like to say the difference that I find when I initially came to the Central TB Division in 2001. At that time, we were filled with technical people, and it was mainly doctors that were there in that environment. And I think through the years, the shift that I've seen is when people affected by TB have gotten involved. And I think when they got involved, the whole TB movement or the whole movement towards ending TB has got a lot more momentum. And I think the role that the media has played, we've also seen, has a very, very important role in how we move forward. Second that I'd like to talk about, and again, I've worked at the global level and everything, but I think the maximum impact comes when you work at the community. And currently with GSW Foundation, we are working on a program where we are looking to make 1,000 TB-free villages. So I believe that if you really have, and I think somebody had mentioned before, we need a bottom-up approach if we really want to see TB end. And the third and final thing that I'd say is we've talked about the health inequities. And I think it's going to be very important that we are all able to get the funding to reach the right place. And I think that's where we need to focus our efforts on. So I'm going to pass it on to you, Vancho, to say your opening remarks, and then we can start bringing in the guests.
Okay. Thank you, Shobha, Bobby, for inviting me. It was great to listen to all of you. This session is on innovative TB diagnostics, but the brief somehow that I had received from Shobha was to speak on the Ratios trial, on which Dr. Soumya Swaminathan also spoke. Now that we know about the study, Dr. Swaminathan also spoke about it. And it was not perhaps for the first time that we got to know that food can really help, people who are suffering from TB. We get to know, but then again, the point comes to the implementation part of it. And before implementation, there has to be the acceptance part of it. Inconvenient truths do not suit us. And I would definitely like to talk about the recent global hunger index that we had. 111 among all nations of the world. And yet we are the fastest growing or the second, third, fourth, fifth, whatever largest growing economies. So good that we have studies, good that we have data, but are we ready to accept it? And if you're not ready to accept it in the first place, then how are you going to implement it? Dr. Arnab Bhargav did a great study. I think it took more than 2 years. 2 years was just the field work of 3 years. And then it was a lot before and after that. And I know for sure that he's now trying to, work with ICMR so that the study could be, the results of the study could be implemented. But then we have other realities that we cannot really, afford to ignore. We rejected global hunger index this year. We rejected it last year. Before that also. And then the other thing is, it was not the first report to say so. We have had many other reports. So when we know that 1 out of 5 tuberculosis cases, and this also came out in some study only, are because of undernourishment. And if we have catchy headlines like saying food is the new vaccine. So if something as simple as that is not getting the attention that it needs, then something as complex as technology and something as complex as diagnostics, that even if we have all those diagnostics, how are we going to ensure that they reach the community when we are not able to ensure that food reaches the community? So for me, food is a barometer to all the things to come. Even if they come, the vaccine comes, are they going to reach the community? Great, we had COVID vaccines for each one of us because COVID affected each one of us. To imagine in our heads that if we have a TB vaccine, it would go down to the levels of community in a manner in which COVID vaccines, were accessible. I don't think so that's going to happen. So on the one hand, when we are talking about the new diagnostics, the new technologies, I think also simultaneously, we also need to at least start thinking about whenever we have those technologies, how are we going to ensure that they reach the community? There are many TB survivors who spoke. We had Nandita before. As journalists, we also keep speaking to a lot of TB survivors. I mean, you speak to them, you realize it is one world. And then when you speak in this, listen to the conferences, you realize it's another world, different world altogether. We say that we are going to, or at least we're trying to eliminate TB by 2025. We know we are not going to be there. And it has to be said in this same plain, simple manner. 2030 is what WHO is trying to do to eliminate TB. Whether India would achieve that, you speak to survivors, you speak to experts, they have their doubts about that also. So it's better at least for us to acknowledge where we are rather than saying, oh, we are at point, why when we are maybe not even at point say, P. So that acknowledge and acceptance for me is the first part. And then only after that, the other things can come. I think we can.
Thank you, Manju. Well, we have now Dr. Padma. She's the director of ICMR NIRT. Clearly does not need any introduction, but Padma, it's over to you.
thank you, Chairs, and thank you also. Once again, you have to bear with me for the next 10 minutes, you know. By the time the slides come up, one thing I wanted to say in the previous session, I take the liberty to tell it now. I want to thank all the journalist friends. They are doing their bit much better or much more than what they were doing a couple of years ago. I mean, I can say from my own personal experience, we had a visit of health minister to our institute twice. After he saw our work, he went back and sent us 20 young journalists to our institutes to see what we are doing on TB. I don't know any of you were there in that group. No, 20 of them from various. You were not there. Yeah, but these 20 were all. They all came from the ministry. They're all from Delhi. We actually had a good mix of people from both print media and the electronic media. And the only one, so we gave them in detail whole one day of what we are doing, things in a very simple language without all jargons. And the only one request we had to them was, once you go back, please do not forget TB. Keep writing periodically in small, small bits, so that people don't forget TB is there. I have had people even ask, all professors, TB abhi bhi hai kya? TB hai kya? I mean, that kind of attitude from well-educated, well-learned professors from colleges. So thanks to that team, they are still doing it. So they are still contacting us whenever something new happens, rations, then they want, what is this to the community? They do contact us. And thanks to Hindu, Mr. Prasad has been honoring us back and forth for bits. And we do, thanks to the media people, something is happening there, but we want little more to happen, little more fight, little more things. Having said that, from the community, that is the media, but from our side, from the doctors or the scientists side, like Ms. Patricia said, there should be more communication. We are also afraid to interact with the media. That I have to tell upfront. I know you are not dinosaurs or anything, but doctors are afraid to talk to media. हम लोग कुछ बोलते हैं, आप लोग कुछ समझते हो और कुछ print में आ जाता है. And then, we all get the backlash from starting from my immediate boss to from the ministry. It's a cycle. But now, this I even told in that forum. So what those people do is whatever they write, they send it to us either by WhatsApp or something, kind of get it corrected, the words, what they understood. And as senior as Mr. Prasad also does that, that is something really remarkable. They send it back to us. This is what I understood. Are you okay with this thing we are writing? Sometimes we say, please do not quote me, and we tell some sensitive things. And that is nice. They take it, they do take it, understanding our constraints. So I really want to thank all the journalists for doing what they're doing. We only request a little bit more stronger also. Okay. Please don't quote me on this last sentence.
Ma'am, if I may interrupt you here.
Yeah, sure.
I'm also speaking off the record, like you were speaking. Recently, we all know drug shortage for TB cases. And I want to be upfront about this also. And I'm just presenting this from journalist point of view, not necessarily to you, but from journalist point of view. Many of us wrote stories about it, 1, 2, 3 stories, whatever. There comes the press release from the government, and that was straight up denial. Straight denial saying there is no shortage. And these are the amounts of drugs available. Whether they were available in some stores, okay, but they were actually not reaching the providers. So and there were 2 such denials, not 1, but 2. Usually government issues 1 denial on one thing. There were 2 denials this time. 2 denials, at least for the first time that I have seen. So, I mean, like you were saying earlier, the government A could have chosen to stay silent. B could have said, okay, look, there's a problem and we are trying to work on it. But when this thing happens that you go targeting, the government goes targeting journalists on their reports like this, then it becomes difficult for us also to report. Of course, if we stop doing our job from there, then we are to be held at fault. We should do. But all that I'm trying to say is there should be some amount of at least acceptance of the problem that exists. So that is my limited submission to you. Thank you.
You want me to respond to this? Yeah, I
call.
can. Yeah, we totally agree with that. Even we were surprised to see the Danielle. That is from this side, okay? But from your side also, I did have an interview with one very senior journalist about the same problem, and we did tell them, yes, my own patients are not getting drugs. We are buying drugs from our pockets and Nikshay Mitra and giving it to them because we want our patients to complete treatment. He took down all these notes. The next day I see it in print media. I mean, of course, they don't interview just me, right? They go interview so many other government officials. So the print media says there is no dearth of drugs in the government system.
Absolutely accept that.
Yeah.
There was this, I absolutely accept that, and I take this.
Yeah.
I mean, I'm not responsible for
Yeah,
those
one
reports,
second
but
for me to finish this statement. So the moment I read it, I was furious because he did take 10 minutes of my time, took my views on what's happening to the drugs. But the next day morning, he has taken it other people. I'm not saying he should not take other interviews, but the next day, at least he could have printed both, right? So one person is saying it's available, one person is saying not available. The print media is very silent about not available. They go on and say, yes, it's available. But end of the day, I realized maybe he was also under pressure, He was also pressurized by his boss, not has been cut. Yeah, so I totally understand the other side story also. He or she was told not to write this part, that's totally understandable. But here, what I would put my submission is, please go on writing. Don't stop आपको थोड़ा बुरा लगता है कि I said it didn't happen, but then you go on writing. Maybe government says yes, it's available, but after 1 week again you write the same thing. 2 months later, write the same thing. As long as this problem is solved, you have all kinds of freedom which we do not have. So please continue. We keep on. Yeah. Yeah. So and what now ICMR has done is we have opened a media communication wing. And that keeps training the doctors, the scientists, as well as the media people, educating the media people on the jargons that, just slips out when we talk. And also the doctors and scientists, how to be more friendly with the media, not to go on defensive every time somebody asks very, very difficult questions. So ICMR is trying to bridge, and there is an ICMR nodal communication unit in Delhi. You can please contact them if any help you need. Not only TB, for dengue, for anything else. So yeah, now, sorry, let's go to the next slide. I'm not going to talk about innovation, basically, because I know the speakers after me are all going to talk about innovation. I would only say what I would expect. Which? No. Yeah, you can move it. Yeah, so tuberculosis is the leading infectious killer of mankind, number 1, number 2, number 3, whatever. But if detected early and fully treated with appropriate regimen, it is totally curable. It is a curable, preventable disease even now. Any number of drug resistance you put, it is still curable, preventable if detected early. The key message here I want you all to take it home is, if we cannot find TB, we cannot treat TB. And if we cannot treat TB, we cannot end TB. And this is not my quote. I take the help of all the great minds of TB, Dr. Madhukar Pai, Dr. Puneet Diwan, Dr. Soumya Swaminathan. This is a published quote. And I totally agree with this quote. Next slide, please. What is the journey of diagnostics over the years that we have gone through? So we started, as you all know, TB is 100 years, Shai Rog hai 100 years disease, right? So we started with something as simple as an X-ray. Simple X-ray where patient had to go to a center to have an X-ray done, to what we now have is portable digital chest X-ray. This is the smallest machine that can be taken to the field. This is a point of care machine. Taken to the field, an X-ray can be taken. It comes along with a stand. It comes with a board which brings out the digital X-ray. And now we also have AI tools which can read this X-ray. Earlier, what we used to complain was patients take X-ray, but there is no doctor to read the X-ray. But now we also have AI tools that's coming out which can read the X-ray and tell whether it is normal, abnormal. Some of the tools even say it is TB or non-TB. That is still under question. But then if you know your X-ray is abnormal, then you, of course, go get yourself tested. So we have moved from this to this. And we earlier had MAN2 test. MAN2 test was not a TB diagnostic test, but it was a TB infection saying that, yes, you have been infected with a TB bacteria. That's all. So from the tuberculin skin test, now we have moved on to a blood test, which is an IGRA test, where it tells you specifically whether it is TB or even non-tuberculous bacteria. So you have different kinds of mycobacteria, right? It need not be TB bacteria all the time. So this skin test could not do that, but this blood test is able to tell us whether it is TB infection or it is a non-tuberculous mycobacteria, whatever. But the one other thing which I do not have a picture of is something called PSI-TB, which is again a skin test. Now, IGRA is a blood test. You have to come to a center, draw blood, and have it run through the machine. So it needs specialized centers to run the IGRA test. But we also have a skin test called PSI-TB, which is from our own SSI Pune, which uses the same antigen which is there in IGRA. So that's the PSI-TB test is also very specific for TB, and that is now available, which tells you whether you are infected with TB. That is all. It does not tell you whether it is TB disease. So you cannot treat someone who has got a TB infection with the entire 6 months or whatever course of treatment. It just says you're TB infected. Earlier, we had conventional microscopy where you had to give a sample, take it to the lab, get it tested under the microscope. It may or may not pick up depending on how efficient the laboratory technician was. It moved on to FM, fluorescent microscopy, where it picked up more number of bacilli when the bacilli load was still less. We used to do solid culture. We know TB is more a laboratory diagnosis rather than a clinical diagnosis, right? So solid cultures used to say there is a growth of TB bacteria, and then it will also tell you what drugs it would be effective. It was earlier solid culture. It took almost 2.5 to 3 months for the culture reports to come and then tell me whether my drug will work or not based on the DST. Now we have liquid cultures, which gives you results from 1 to 1.5 months. We have also moved on to something called LPA. This is again molecular-based test. A CBNAT test will tell you the results in 2 hours, whether your drug works or not. First line drugs, H&R. Molecular test LPA, the line probe assay, will also tell you whether your fluoroquinolone works or not, whether you have MDR or XDR TB. All this within a matter of 4 to 8 hours based on which lab it is being done. Unfortunately, these are still in the lab. Only thing, they have moved down from a higher laboratory to a lower laboratory. Earlier, we also used to do this PCR test, conventional PCR, which tells you what are the gene sequencings present in the mycobacteria. Now we have moved on to very non-sputum based tests, like TB LAMs, and also Molbio is coming up with the more test. So these are all various diagnostic. It's not that no active discovery or invention is happening in TB diagnostics, but all this has happened. So where has this taken us? Next slide, please. Oh, sorry. Now, we want diagnostics which is accurate. It is timely, it gives me the result. I don't want to wait for 3 months to get a result and start deciding on what treatment I have to put on. Empirically, I'll start some treatment, but 2 months later, I'll get some other result, then I have to go back, change the treatment. Another 3 months, I get another result. So we don't want all that. We want timely results to impact the clinical decision making. We have to be justified on the need of newer drugs. Patient has to get this drug, patient needs a 6 months treatment or 4 months is sufficient. It has to be quality assured. So every day you have new diagnostics. At least at my institute, we've been approached almost every day with this new kit has come, kindly test us, because I think NIRT is on the list of SEDESCO's lab for testing. But we want quality assured kits and reproducible kits. There are so many international companies that come to us to test the kits. But will those kits be available for our country people? Is it reproducible in our in-house? So these are the 3 points which we look for when we want diagnostic kits. And there are different levels where we would like to place these kits in our health system. One is, of course, the central laboratory, which is the national laboratories. We have 6 TB national reference laboratories. We have supranational reference laboratories in all them in 6 metropolitan cities. Then we have the intermediate laboratories, which is at the district level, regional or district level labs, which we call the intermediate reference laboratories. And then you have the sub-district, the peripheral, the community-based PHCs, where you have these kits. What happens is in the PHC level, you screen the mass population, you find the case, you put them on treatment. For that, something as simple as NAT-based testing. It could be expert, it could be, TrueNAT or TB LAM or urine LAM, any of these tests which can be placed at the periphery level. When you move to the next level, intermediate, I want a little more than what is being done at the periphery. Something happens in periphery, they don't respond, then they're sent to the next level. Here, what I do culture and molecular-based testing, which is not possible in the PHCs, at least as of now. The finally is a central laboratory where you do sequencing to see whether, what happens at the periphery level has failed, and that is why you come here. That is because even now in this country, 80% of TB is drug sensitive TB. We talk so much about drug resistant, but 80% of TB is still drug sensitive, which can be diagnosed and treated in the periphery level, which is your primary health center, CHCs, health and wellness center. We miss here, and then it escalates and comes up here. Then you talk about the 26% or 25% of drug resistant TB. If we catch them early at the drug sensitive stage, treat them, complete the treatment without any default or without any missing doses, then we don't have to even go up this ladder. Now, having said that, what is happening? So these are the two different studies. One is a world study, one is our own country study. Now, this was published in 2019. They used the world WHO TB database. What they wanted to see is how much of TB is there, how much is being diagnosed, how many of them are put on treatment, and how many complete treatment. Just these 4 parameters. So they said if there are 100 cases, only 65% of them get diagnosed. There's a huge gap here, around 35% diagnostic gap. This I'm saying happened. This is the 2016 World TB database taken from 30 high burden countries. Of those diagnosed, it is not everybody, right? I expect all of them diagnosed to go on treatment. No, but only 60% are put on treatment. There is a gap here. Of those started on treatment, everybody should complete treatment. But again, there's a gap. Only 40% go on to complete treatment. This is for the 30 high burden countries, world data. At the same time, at NIRT, group of investigators from my institute, along with people from outside the country, did this analysis for our own country data. Surprisingly, our country data matches very much with the world data. Of the 100 patients, how many reach a diagnostic center? It's only 72% reach a diagnostic center. The huge gap from 100 se leke 72 beech mein kya hua pata nahi. There are 30% of loss around here. Even those who have reached the diagnostic center, diagnosis happens only in 60%. Here is mainly because they give the sputum, they do not come back the next day to collect the results. Or, you want the 2 sputum. This is 2016 ka data. We still want 2 sputum or 3 sputum. They give only 1. They don't come back for the next collection because all this happens at the facility level. And once you diagnose, okay, fine. You are starting them on treatment. Here again, with a small gap, 60% diagnosed, 57% put on treatment. But look at how many completed treatment. It's only 45%. So here I have diagnosed 60%, but complete treatment is only 45%. But this is 100%, 45% have completed. So I still have a group of people who are spreading the infection in the community. Nobody is there to push them to come complete the treatment, finish the treatment. And this is from our own data. So what do we want? There are only 7 steps where this diagnostic gap can be addressed. And these 7 steps is what I want to concentrate on. This is very simple step. So we have microscopy, move away from microscopy to upfront molecular diagnostics. By upfront molecular diagnostics, what I mean is, so currently it is there in the program guidelines, upfront molecular diagnostic has to be given. But what happens is in many centers, they do smear first. If you are smear positive, you put them for molecular diagnostic to know whether you're RIF or H sensitive, right? But that is not what is upfront molecular diagnostic. What will happen to the chunk who are smear negative? They will never get the DS, they will never get the molecular diagnostic because you do smear positive koi aap log usko DST mein dal rahe. Upfront diagnostic, if somebody comes and gives you a sample, it has to go directly into molecular diagnostic. Don't worry about the smear positive or smear negative. So, this is what should happen. Move away from microscopy and do molecular diagnostic for the initial diagnosis. We are not talking about follow-up. Follow-up, you still collect sputum, you still need microscopy. We're not telling get away with microscopy. Because once diagnosed, the DNA still remains, and in the follow-up, we don't go with molecular. But upfront molecular diagnostic, that is what we mean. Smear positive, smear negative, anything, it has to go upfront diagnostics. The second, you have high complex NAT testing. That should become point of care. Instead of asking people to come to the facility, it should be a point of care NAT diagnostic. By point of care, what I mean is, okay, the ideal situation would be if I have a stick like a pregnancy test. Pregnancy test, what do we do? It's very simple. Go to the counter, get a test, ghar mein karo, kuch hai, so then you, right? Something like that is what we would. I cough for 3 days. Okay, I'm worried. I get a stick, get it tested. That is a wish list. This happened for COVID. Towards the end, remember, all of us had a stick antigen testing where people could test. Okay, that was giving a lot of false positive. That's a different story. But it still got people alarmed and they went to a nearby doctor to check. Now, that is a wish list. That is something we would want. But here, what I'm saying is decentralized point of care testing must be complementing the centralized lab facility. I still do a point of care testing. It is showing me something is positive. I refer the patient to the nearest laboratory. And this can be done at household. The question is, do I need 2 sputum? Do I need 3 sputum? All that will get away with this. I'm coughing for 3 days. I do this test. I find something is suspicious. I get alarmed. That is what the community would want, rather than going to the doctor every time. Oh, 7 days, gilna mere ko, aaj 5 din ho gaye. Let me wait for 1 more day for 6 days, 7th day. Then I go to a doctor. All that will get away if I have done. That is something which we want. The other thing is get away with the single disease testing. Go to a multi-disease testing. What I mean is, I have HIV. I go to an HIV provider. He will test only HIV. It was earlier, okay? I have diabetes. I go to my provider. He will do only diabetic testing. But now, instead of that, if a diabetic individual goes to an NCD clinic, they should look for all other disease, which is more common in that. For example, influenza. How many of our parents are taking influenza vaccine every year? We don't. And now the 2 disease that is being tested is HIV and diabetes for TB patients. But what about hepatitis? We again need to do another study to say hepatitis should also be bidirectional testing. Right? There are so many other, So diabetes and HIV is what we could push, and that is what is getting tested. But test for other disease, COVID. Every person tested for COVID should also be tested for TB. That is still not happening. It's happening in few states. I won't say blanket, it's not happening, but it's not universal. But every TB patient, at least HIV is getting tested. We want diabetes, we want COVID, we want influenza, we would like hepatitis, all this also to be tested. So that is a multi-disease testing instead of doing a single disease testing. Get away from just doing sputum test. Do a non-sputum sample starting from tongue swab, urine lamp, stool testing. Many of our kids cannot give you sputum. What they give you is hardly saliva. And how many of us get a proper NGT ka sample? The gastric aspirate or gastric lavage, which is not properly taken, it comes negative. If we can start doing stool testing, which is being now done at small centers, not scaled up also. Oral swab, we've been listening, talking of oral swab. Dr. Nair is missing for this talk, because that is something we really want to get this oral swab out there in the community to see. Okay, like Dr. Soumya said, we will miss cases, but here is a test where if I go, Asha goes to the center, goes to the house, she finds somebody's got fever for 3 days, no cough, there is no sputum, but just fever for 3 days. Easy to get a oral swab and bring it to the lab instead of asking the patient, agar aapko aur 2 din bukhar hai, to come to the clinic or come to the PHC. This can easily be done by our healthcare workers or the volunteers. So non-sputum sample is something which we have to replace the sputum testing. Again, healthcare facility-based testing ke bagair, it should be closer to the house. Maybe the stigma will go if people can start doing closer to the home. We wanted a doorstep testing done. Even if that is not possible, they can come to the health and wellness center. Now we have moved down to the health and wellness center. Health and wellness center is the first point where anybody with symptom can approach the health system. So instead of passive case finding, it should be active case finding. By active case finding, what I mean is, instead of the health system going and asking you for symptom-based testing, if you have symptoms, you please come to the center. And then focus, this is something very important. Instead of focusing on test accuracy, newer diagnostics, we talk so much about validation testing, lab validation, field validation, sensitivity kitna, specificity kitna. We want everything to be above 90%, PPV and all that. Instead of that, if my test can pick up in the population, even 60% of presumptive TB, I'm good. I don't want 100% pickup. I'll miss 40%, but I'm still picking up 60%. Abhi kya ho raha hai? We are going on waiting for the best test, best accuracy test to come up to the field. So in this case, what will happen is I can pick up subclinical TB. So what a subclinical TB is? The person doesn't have cough. There are no symptoms, but he's harboring the disease. Harboring a culture positive bacteria inside, which might take another 3 months or 4 months to become active, or he may clear it by himself. I'm not saying every person who has gotten a bacteria active will develop disease, but there is a stage called subclinical TB where there's no symptom, but the bacteria is actively multiplying. That can be easily picked up by these kind of tests if you're not waiting for the so much of accuracy. And the last one, of course, is more volume to be tested in the lower middle income countries, which is affordable and less expensive tests. So only these 7, if we transform, I think the diagnostic gap that we talked about can be bridged. WHO does have a standard. I know people do not like to see the WHO guidelines, but it is there. So I'm showing you the slide. This is the universal access to rapid TB diagnostics. They have only 4 steps. Step 1, identify the presumptive individual who has got screening. This is high risk symptom screen. But not everybody is symptomatic. Chest X-ray can still pick up. So chest X-ray and symptom screen is what we are now suggesting. And that is where this portable X-ray plays a very big role. Identify the presumptive TB, bring them to accessible testing facility, up-to-date diagnostic algorithm using rapid diagnostic access in the PHCs. By PHCs, if you need to do it, you should get away having a biosafety cabinet. You should not ask for, who's to do all this test. Still, it should be very friendly and accessible kind of a test that can be done at PHC level. Coverage should be reach all. And the testing capacity should match the needs of the community, need of that particular village or that particular district. The third step would be once they are tested with quality testing, they should be put on proper treatment based on the universal DST. So we have only 2 kinds, right? Drug sensitive, drug resistant. You do one single test that tells you whether it is DST, drug sensitive or drug resistant TB, and put them on right duration of treatment and make sure they complete the treatment. The last step 4 is receiving the diagnosis and putting them all on treatment, timely delivery of the results. Many times what happens, test ho jata hai, result mil jate hain, but it doesn't reach the patient and the patient doesn't start on the treatment. Now the question is, community says, mere ko health worker ne result nahi diya. Health worker says, I have too much of work, too many patients to cover. It's patient's response. So some place even the patient should take the responsibility to go collect the results and start on the right treatment. These are all WHO recommended diagnostic that we have our own here, which was approved in 2019. If you look at this list, how many of them are originating from India? IGRA. I don't see anything here, but then this. So I think even from our side, from the scientific community, we should also, think of more. And this is what we expect to happen in 2035. By 2035, this again is a wish list. So this was an interview done among doctors, a database across countries, around 2,000 and odd, 3,000 and odd doctors. Everybody feels they want a NAT test. The NAT test is something which gives you, yes, you have TB, you have no TB, and what is a drug that can be given on. Majority want a NAT test. Then this is the next they want is sequencing. Sequencing gives you more than what a NAT can give because it gives you at one go. It gives you the entire stretch of all drugs. And this is now coming directly from the sputum. Earlier sequencing was done on culture. Abhi culture bhi nahi hai. You give a spot of sputum and they're able to do, say whether it is TB, not TB, and it gives you a list of all drugs. But WHO still not recommending targeted sequencing for patient management. India we are trying to, bring evidence or generate evidence. This is doing much better, especially in difficult to treat. By difficult to treat, I mean as you have treated them once, but still they come back with a recurrence. So what is needed? So this is something which is evolving in the country. Then of course you have omics, non-molecular diagnostics, lab on a chip devices, and of course biomarkers and biosensors. This is all the thing that people want to be seeing before 2035. So to conclude, newer innovations, yes, we are looking for newer innovations, especially like tongue swab. I think it will come very soon. Urine-based testing, stool-based testing, cough AI, chest X-ray AI, and most important, sample transport. Major diagnostic gap is how does the sample reach the lab? So the best solution is take the lab to the house. But you cannot be doing it for every individual, right? Some level you have to stop the lab. Maybe at the mohalla corner, not to every household. I don't want, he comes, takes blood, that is fine. But putting up a kit there and setting, how will the community accept it? I have my sasuma at home. I am coughing. I don't want my sasuma to know I'm getting a TB test. And that stigma is still there. So, so innovative sample transport to the nearest lab, which is how near the lab can be. It's a buddy or your partner, somebody. So this is all still going on. We're very happy to see the results of these soon. Upfront investment and better diagnostics so that we have something as curable and preventable like TB. We do now have strong political will, but unfortunately the funding is still way less than what we would want to see. Very simple example, Dr. Gularia, he asked about 3HP, right? We've been fighting to bring 3HP to show whether it works or not works, because 3HP is again a drug. What happens in latent TB, not everybody still has the bacteria within you for the drug to go and kill the bacteria. It is more an immune response. The bacteria is there, it creates an immune response. It may get cleared off, but the immune response still persists. So the test that we're doing picks up this immune response. So does this drug, but there is still a group of people, something called recent infection, where you still have the bacteria. In those individuals, 3HP would definitely work. But in the rest of the population, where it is a remote infection, where my IGRA is showing positive, bacteria may or may not be there, will 3HP work? We don't know. Second, do we need repeated cycles of 3HP? Repeated cycles of preventive therapy, because I'm in an endemic country. I have taken 1 month dose or 12 doses of 3HP. I travel in the bus, somebody sitting next to me keeps on coughing. Do I need another dose? Should I quickly run to the person saying I had this exposure? Should I take? Or I'm working in a clinical setup, social workers keep on talking to the patients. Do they go on taking? We don't know. So those answers we need. For that, we need more research, and research is not possible without funding. And I'm telling you, we are acutely short of funding for this. The one more thing is that nutrition supplement. Everybody knows nutrition is good. It's an immune protective ho jata hai. But we did a very small or big study which said what kind of nutrition delivery system the people want. Are the people okay going to the PDS system and saying, give me more rice, more chawal, more dal? Or do they want the food to be delivered to the home? So we wanted to know what kind of delivery system the patient would want. This was done with the FGDs and individual interviews. And surprisingly, we found out 80% of people do not want the additional rations from the PDS shops. We came up with a lot of ideas. We'll give you a red slip jaake aap de do. They will give you additional PDS. They didn't want. They feel, why they will ask, why am you are getting additional? The stigma is still there after so many years. It's very much there. When you tell them, no, we will have someone come and deliver the food to you. 5 kilo ka rice and another 2 kg. So they don't want that also. The one thing that came up was they want everything delivered as a package in the center where they're getting their medicines, where they get the drugs. That is something it came from the community, which maybe the program managers, policy makers would think PDS would be a better option. So what kind of a delivery system would work? We need to still do more research. Not one single thing will work in all districts, in all communities. It'll vary. So this is a more community-based research which we're trying to do. So funding is very much lacking when you want to answer simple questions. So I think that is it. Thank you.
Thank you, Dr. Padma. We need more people like you if we are to fight to end TB. I think
I have to go. Just one small thing.
Yes.
Only one small request. Please do not do Google search for your medical conditions. It gives you horrifying results. You just put some simple photo dikhata hai na, you will. Please don't do Google search for medical conditions. Approach the nearest, whichever doctor, whichever specialty. Thank you.
Thank you. So next we have Dr. Ishwar Gilada. Dr. Gilada, Secretary General with OMAG and President Emeritus with the AIDS Society of India and Secretary General of PHO. Dr. Gilada.
I once again thank you very much for having me here. I'm one of the backlash survivors. As a doctor, we get backlash from patients, families, other doctors, government, media, everywhere. So if we are talking about survivors, we are also survivors. Secondly, I have a disclosure. I'm not a TB specialist by profession or by qualification. But over the years, we have learned TB. But I started my professional life with another mycobacteria because TB is mycobacteria tuberculosis. I started with mycobacteria leprae, leprosy. But my first day in JJ hospital, my first doctor I met was TB specialist, and thereafter I got inspired. Secondly, I would like to salute Goa, which is the land of quickest transformation. If you have learned about Goa, Dominic D'Souza was the first AIDS activist who was isolated here, jailed here in Goa in 1989. And within 3 days' time, we could change the entire law. In 3 days' time, I was the first person to be allowed to speak in the assembly. I'm not a legislator. So that way, Goa has done fantastic. On 3 days before all media were writing, fantastic thing. Goa government has done wonderful, putting me in jail so that no one can get HIV. And within 3 days, they said, no, what was done was wrong. And to stop TB, and I'm comparing that with HIV. Next slide, please. I have to go in a Vande Bharat speed because there's some slide. Initially, okay. Which one next? Okay. So, because initially I was to speak with slide, then I was to speak small. Then again, I realized that a lot of people may not understand what is extrapulmonary tuberculosis. You say you need sample. How do we get a sample in extrapulmonary tuberculosis? So even extracting sample is difficult. You say you need to diagnose early. How do a doctor diagnose? If doctor starts treatment without diagnosing, there is a chance of MDR TB. So there are a lot of delicacies we are. So is it different than TB alone? How extrapulmonary TB is different? Other concerns are DDI, drug-drug interaction, iris, adherence, latent TB infection and IPT, and diagnosis. I don't know what some words are being missing. I don't know. Which one is the next one? Can you operate? I just said stuck next. Okay, that's better. I would like to have a little clarification on Padma and Somia. They misunderstood me. I wanted to say the 3 HP for TB HIV patients. When we are giving already 180 days of course of isoniazid, and we wanted to change that to only 12 doses of lifapentin and INH. And that is not happening only in India. It is happening all over the world. Medicines are supplied from India. Now, what is common in TB and HIV, in addition to respective infectious agent, both are immunological disorders. Both are chronic diseases. Both have stigma. And one is the stigma of sexuality, and other one is the stigma of contagion. If you consider stigma, HIV has more stigma. In tuberculosis, we had known Kamala Nehru, Jawaharlal Nehru's wife has TB, and Kamala Nehru hospitals are there. We know Kasturba Gandhi died of tuberculosis, TB hospitals are there. Have you known any public figure in India? One central minister died of HIV, two chief ministers died of HIV. Have you seen any hospital in their name? No. So stigma is more in HIV. And HIV people have fought stigma much better than any other stigma fighters. And both diseases required lasting commitment. And therefore, I really salute all those media who are here with a lasting commitment, and they are going to be with tuberculosis and HIV for another couple of decades maybe. Though we say we will end TB by 2025 and HIV by 2030, it is not going to be ended. So they are good goals. So when we have a TB and HIV, they are double troubles. And we can see TB is now leading infectious cause of death globally. Now, if you just consider tuberculosis death, within 2021, we lost 500,000 people to tuberculosis. And in the entire 3 years of COVID, we lost 500,000 people to COVID. Still, COVID is called bigger and not TB. Next, please. Vande Bharat, next. So you can see India has the highest burden. Now, being a country which is #1 in population, is going to be #1 in many diseases, many problems, many rape, many things. But at the same time, India has a disproportionately high number of tuberculosis. We are 15% of population and 26% of TB burden. And therefore, we are in that, and smaller countries than us, like Thailand, Cambodia, etc., they have done wonders, both in HIV and tuberculosis. Next slide. So when you talk about in TB and HIV, we have 4 different groups of patients: TB and HIV, MDR TB and HIV, TB and MDR HIV, and MDR TB and MDR HIV. can you imagine when we are managing MDR TB and MDR HIV? And in that, there are two, communicable TB and non-communicable. So being a public health person, I would like to see that the communicable TB is treated first, because that person doesn't transmit to others. But even non-communicable need to be looked at, and which is much more neglected in society. Next slide, please. So when we talk about India is third highest burden in HIV, but first highest burden in tuberculosis. Next slide, please. So what are the issues? Prevalence is around 40%. Means all of us, 40% of us are infected, even though not manifested. Lifetime risk is 5 to 10%, 10% per year with HIV. So HIV has 5 to 10 times more chances of getting tuberculosis. Incidence is 28 lakh cases per year. 87,000 are HIV infected in that. Next slide, please. 15% of the incident TB and 25% of TB deaths have HIV. MDR TB twice as common with HIV. And mortality of TB HIV is twice that of HIV alone. Next slide, please. So a lot of people in HIV, they die of tuberculosis or extrapulmonary tuberculosis. Next slide, please. So we need to have a rapid clinical deterioration to be understood. Next slide, please. And a typical presentation. In HIV, what we see, normal X-rays in almost 30% of the patients. So we do X-ray, but X-rays are normal. Sputum negative. We have subclinical tuberculosis, and we have 40 to 80% of them have extrapulmonary tuberculosis versus 10 to 20% in HIV negative people. Next slide, please. So I have seen almost tuberculosis of all parts of body: eye, sex organ, bone, spleen, liver. I show you. So sometimes we need to be when you see a patient and we don't compare, then it can be tuberculosis, it can be HIV, it can be both. So very difficult to find out. So I have compared HIV and TB. HIV, tuberculosis is 0% preventable. Somebody was talking about prevent. You cannot prevent. It is 0% preventable, but 100% curable. HIV is 100% preventable, but 0% curable. Tuberculosis is glamorous. Now some glamour has come after Prime Minister inaugurated that program in Varanasi and thereafter. But HIV has been highly glamorous because we had Rock Hudson and a lot of Freddie Mercury getting diagnosed with HIV. After over a century existence, only 12 to 13 molecules and only 2 new molecules. In HIV, within 36 years, we have as many number of molecules available. TB follows in almost all HIV patients, but HIV may not follow in all TB patients. Now, despite all these disparities, these two organisms coexist. And they coexist in such a way to ruin human beings. Next slide, please. So you can see that it's a typical fibrocavitary. I don't want to go in medical terms or medical jargon, but you can see typical and atypical kind of tuberculosis. Next slide, please. And when you see how the big part of the lobe is involved or lung is involved. Next slide, please. Next slide, please. And you can see the 2 different patients and 2 different atypical presentations and patterns of tuberculosis. Next slide, please. Pleural effusion, that is a water in the lung on one side, and you can see hilar node. Only node is there, but there is no cough, no production. Next slide, please. And you can see endobronchial cavities are there. So a lot of cavities are there. Usually we think cavity means a bad tuberculosis, or it's a good tuberculosis because it doesn't spread the bacilli outside. Next slide, please. Then miliary pattern, one of the worst things, where you just seeing mottling of the lung. All the lung is totally small molecules. Next slide, please. And you can see one side of lung is totally gone. But there are hardly any surgeons who want to operate on this kind of patient, because unless until you remove a part of lung, that person cannot improve. It's called lobectomy. Next slide, please. So MDR TB in MDR HIV patient, a major challenge, and DST, that is the drug sensitivity test, takes 6 weeks to report. Hardly any prognostic markers are there, and polypharmacy. A lot of patients are taking those TB and HIV medicine together. Next slide, please. And pericardial, you can see the heart, entire heart is involved in tuberculosis. And here you see mediastinal lymphadenopathy, that means in the abdomen there are lymph nodes involved. Next slide, please. You can see splenic abscess. You can see abdominal lymph nodes. Next slide, please. You can see liver, such a big liver. And as soon as we put a FNSC needle, and we can see so many FB bacilli. So have you heard of tuberculosis of liver? Next slide, please. Then this lady came with a swelling here. Somebody was telling about mother getting or somebody getting a nodal on the skin. Yes. So these are the skin tuberculosis. And in this case, When I referred her to biopsy, they said biopsy will cost 50,000. She didn't have money. So empirically, we started treatment. You can see after 5 months, the same lady is fine. So sometimes we have to use that kind of discretion of treating patients. So when you talk about diagnostic assay available and what are the utilities, X-ray and CT scan, very important. Sputum microscopy detects less than 50% of TB cases. MGIT sensitivity is around 100%, but more than 95% have a smear negative. So that is a gold standard. Gene expert or TrueNat sensitivity 70 to 95%. Now what happens is a sputum sample. When we say sputum, sometimes people bring saliva. So we need to gaada thuk chahiye andar se nikal ke, khansi karke. And sometimes we need a bronchoalveolar lavage. Bronchoalveolar lavage cannot be done in OPD setting. You need to send them hospital. The minimum hospital stay 10,000 rupees per day. Can you think of getting samples so easily? It's very difficult. Line probe assay, LPA, hardly any availability in many places, and where you can diagnose. Urinary lamp, one of the best tests in HIV patient. You can do urine test and find out. It's not available. It's only in research setting, only in National TB Institute. It's not available in public. So when we talk about diagnostic assays, radiology, X-ray, CT scan, detection, bacteria smear, microscopy culture, molecular assays, gene expert, TrueNat, and line probe assay, and antigen test, TB lamp. Next slide, please. So these are the issues which we need to confront always, and we need to have a very good sensitivity, very good specificity, and that is there in this kind of TB-NAT and TrueNat. Next slide, please. And see, line probe assays are also there. Next slide, please. Lateral flow urine assay or urinary lamp, one of the best tests available from some companies abroad, but it is for research and we need to make it available, and it's very cheap test. Next slide, please. So when we talk about TB and CD4 association, CD4 in HIV, as soon as TB CD4 goes down, TB goes up. And one of these scientists where I learned my HIV lessons in 1987 in USA said, when you don't have CD4, you look at ESR, erythrocyte sedimentation rate. And ESR, you will not see about 100 except tuberculosis. So you see ESR in tuberculosis, and a lot of doctors will do all the tests, but ESR is not done, which is costing only 10 rupees or so. And we can decide who should be given this rifampicin INH or only INH, or should be given or not. And it was decided and globally accepted that those people will need at least once in 2 years, 6-month course of INH or 12 tablets of rifampicin and INH. Next slide. So in condition where we have a CD4 counts are low, less than 50, we cannot start ART treatment immediately. The moment you start the treatment, TB goes up. TB is like आँख का पानी, दुख में भी आँख में पानी आता है, सुख में भी आँख का पानी आता है. When the immunity is going up, again TB can come. Next slide, please. So what drugs we have to choose? Drug-drug interaction we have to understand. IRIS, that means we don't want people to die of immune reconstitution syndrome because of early treatment. HIV treatment is not an emergency. Though we said test and treat, we can always wait. Pill burden and adherence has to be seen, and overlapping toxicities, because there are some drugs which will interact with rifampicin and we need to avoid. And rifampicin is the most potent drug in tuberculosis, which we cannot get away. So we need to understand this, and this is again a table to understand which drug can be better. But next slide, I can show with the TB. These are the 3 drugs which will work fantastic, and we have very good experience of using. It's called TLE, tenofovir, emtricitabine, or lamivudine, and efavirenz. Next slide. So when we look at other concerns in IRIS, next slide, please. And you can see that people getting IRIS and they are dying of IRIS, getting paralyzed because of IRIS, getting brain involvement because of IRIS. Next slide, please. And almost 11 to 45% of the people get IRIS because of HIV treatment. Next slide, please. And that happens within 60 days. So low baseline CD4, low hemoglobin, low weight. These are the parameters we need to look at. Earlier ART initiation after anti-TB treatment. So we need to do that. And extrapulmonary focus and disseminated tuberculosis. So if there is an extrapulmonary tuberculosis, then we need to be very, very particular, and ESR is a guiding principle. If ESR is very high, there has to be tuberculosis somewhere in the body. Next slide. And rule out multi-drug resistant TB, lymphoma, or other opportunistic infection. So somebody said very rightly that there is always confusion between lymphoma and TB. Sometimes we suspect lymphoma, it comes out to be TB, and sometimes we consider TB, it comes out to be lymphoma. Next slide, please. And decline of viral load. So viral load will stay down, but CD4 is also low, and that is also something to be inside. Next slide, please. Pill burden, next slide, please. And we need to look at whether 6 months of INH or 6 months of 3 HP, there's 12 doses of rifampicin and INH. Next slide, please. Next, please. Next slide. So they are all what I have spoken, crystallizing in six parts. Next slide, please. So basically, what is the experience from HIV? 90, 90, 90 or 95, 95, 95 targets. Very important. We need to make similar targets here. U is equal to U, easily understood by affected communities. Here, there is nothing to understand in tuberculosis. Linkages and continuum of care from diagnosis to treatment to viral suppression and treatment as prevention is very much established in HIV, is not so in tuberculosis. These strategies help in people demanding HIV test, best of the treatment, like a currently dolutegravir-based regimen. Within 6 weeks, you become undetectable. Undetectable is untransmittable. And viral load testing. Community-led monitoring is also a norm in HIV, but that is not seen in tuberculosis. So in TB, stark disconnect between diagnosis, treatment, and cure, and prevention. So care continuum is less understood in tuberculosis than HIV. Next. So numbers screened, which are basically verbally, not with portable X-ray, not point-of-care molecular test, as per WHO guidelines and active case finding definition. Among those symptomatic, how many got tested? Among those who are tested, how many were put on treatment? How many got cured? So these are all verbal kind of statistics. We do not know really proof of that. Delay in TB diagnosis, studies now, average delay was 2 months almost, and that is Dr. Madhukar Pai from Canada. In TB stories of patient, track, test, treat is a norm. But in TB, what is happening? Treat, and then maybe test, which is the norm. Next slide, please. So global North versus South, I always compare, and I'm trying to be ambassador for the global South because we are always oppressed by the global North. India provides 92% of the medicines globally for HIV and TB, but futile questions raised on bioequivalence. This is deep-seated, unscientific, anti-people attitude and bias of those people. Same prejudice and bias prevalent towards made in India diagnostics and equipment. Unfortunately, in India, make in India diagnostic and equipment has been late as much as in medicine. But whatever is made, people are opposing us. The urgency to get most value of every penny is paramount. If we are to reach services to the unreached, and they never acknowledge if they copy from India something, for example, fixed combination from TB and HIV. Next slide, please. So basically, we need to stop HIV, stop TB, and stop both. And we have to go miles, though we have a target. So thank you very much. Thank you, Molbio, and thank you, Bobby and Shobha.
Thank you, Dr. Gilada, for your Vande Bharat presentation. Now I invite Mr. Wayne Van Gimmert. Sorry if I pronounced your name incorrectly. He is Project Lead and Diagnostics Technical Officer from Stop TB Partnership from Geneva. I think he's joining online.
Excuse me, he just sent a message yesterday that he was not well. So he has sent his recorded presentation. He said he won't be available online at that time.
Hi, everyone, and greetings from Geneva. My name is Wayne Van Gemmerts. I'm a Diagnostics Technical Officer and Project Lead for the Introducing New Tools project at the Stop TB Partnership. I'm sorry I can't be in person there in Goa today for the Media Summit, but I appreciate getting this opportunity to share some of the experiences we've had with our Introducing New Tools project. Firstly, I'll give you a little bit of a background about the project. This is a collaboration between Stop TB and USAID to introduce innovative diagnostics, treatments, and digital health technologies in 11 high-burden countries. Very briefly about the 8 technology components. Firstly, we've been introducing ultra-portable digital X-ray systems together with software for the computer-aided detection of TB. This is software that uses artificial intelligence. We've also introduced Molbio TrueNat systems. This is into 9 countries. And we've also introduced the QIAGEN QFT Plus IGRAs for detection of TB infection in 3 countries. These are the 4 topics I'm going to go more into detail because I know the topic of this summit is about finding TB. But just for your information, we do also, in this project, we have components around connectivity solutions for GeneXpert and TrueNat in 5 countries, software that are digital treatment adherence and support technologies for 5 countries, targeted next generation sequencing for drug susceptibility testing in 1 country, and lastly, TB preventative therapy for 170,000 people in 6 countries. So about our objectives and approach, so we've aimed to introduce new tools for 2 main reasons. Firstly, to help countries reach the 2018 UN high-level meeting targets for the detection and treatment of TB, drug-resistant TB, and TB infection. And secondly, we've also wanted to demonstrate feasibility of using these tools and guide wider scale-up. So the funding from USAID for commodities, it was almost $27 million, and the procurement started in 2021. Most of the projects have been supplied through our global drug facility, the GDF at StopTB, and we've also supplied monetary grants to some local organizations to procure some of the products that aren't available through GDF. We at StopTB have collaborated with USAID together with countries in the programmatic planning, organization of trainings, implementation research, and monitoring product implementation. And USAID has supported the implementation in country through their missions as well as the implementing partners. So I'm going to start with sharing the project experience about introducing the ultra-portable X-ray and CAD software. There were 7 national TB programs that worked with partners to bring these systems to very remote areas that were able to screen for TB, and by doing that, find TB much earlier. The software, this CAD software, it uses artificial intelligence to indicate whether TB is likely or not. And for those people in whom TB is likely, they are then provided with either a TrueNat or a GeneXpert test for bacteriological confirmation. And by using the CAD software, a radiologist is not needed on site. So the people who are operating these systems in our project were trained radiographers. In total, we provided 63 of these ultra-portable digital X-ray systems. Most of them were Delft Light from Delft Imaging in the Netherlands. And some systems were the FDR X-Air from Fujifilm in Japan. And they were all provided with perpetual licenses of the CAD for TB software of Delft Imaging. We were happy that GDF was able to negotiate these perpetual licenses. It helps with sustainability of this project. And this was the largest multi-country rollout of these ultra-portable X-ray and CAD software technologies. If you haven't seen the CAD software before, the image on the left here, you can see a heat map of the parts of the lungs where TB is likely. In the next photo, this is a radiographer in a sub-county hospital in quite remote Kenya. He has a Delft Light system. You'll see the detector panel is attached to the wall. This can also be easily attached to any door. And then this photo on the right, this was from a very remote community-based case-finding activity in the Philippines on Cebu Island. You can see here that the panel is on a tripod here. So the experiences of countries using these products so far has been largely positive. You can see from the latest data from the reporting countries, and this is Q2 data as the Q3 data is still being processed, over 330,000 individuals have been screened and over 10,000 individuals with TB have been detected. I would say one of the bigger challenges in this project is that these instrument systems are being deployed to very remote settings. And sometimes technical issues do arise, and it's a challenge getting service and maintenance on site, as well as replacement parts. So we at StopTB, our GDF, has been working closely with suppliers to remedy these issues. And some countries now, in fact, are getting stockpiles of parts, making it a lot easier to quickly make repairs as needed. And we're very happy that of the 7 countries that received the systems in our project, all of them have plans for wider scale up of digital X-ray and CAD systems using Global Fund resources. And the experience from our project has been used to develop and refine a few resources. Firstly, some practical guidance, training modules that can be downloaded for decision makers and end users, as well as a number of case studies and webinars that have been published on our website that allow for countries to share their experiences and to build awareness among countries that are outside of this project. At the end, you'll see the web link for the New Tools project. So now moving on to the experience using TrueNat. So this is the technology from Molbio Diagnostics in India there, and it's the first WHO recommended rapid molecular test for TB and rifampicin resistance that can be used in peripheral health facilities and in community settings. We provided 301 of these instrument systems under the INTP. Most have been placed at peripheral sites that previously were performing microscopy to detect TB, and where previously molecular testing was only available by referral of samples, or worse, referral of the people needing the testing. And in some cases, there was no molecular testing access at all previous to this project. Similar to the X-ray and CAD systems, this has been the largest multi-country rollout. And of the 9 countries that have received the systems, 2 countries, the Philippines and Nigeria, have used some instruments in a portable fashion. So you can see in the images here on the left, this is the suitcase in which the systems can come to facilitate transportation. And the image on the right, this is in fact the same community-based active case finding event in Cebu in the Philippines. So the experience so far introducing TrueNat, again, as of Q2 2023, we estimate that over 350,000 people have been tested and an estimated 40,000 people have been detected with TB. We're really happy that the latest data has shown that adoption of TrueNat has resulted in a very significant percentage point increase in people having access to a rapid molecular test. This is between 16 to 79 percentage point increase. And this is compared to historical data to the period before implementation, when again, as I was saying, the availability of such testing relied on referral of specimens or people to other sites, or it's absent altogether. So far, 5 of the 9 countries have plans for wider scale up using Global Fund resources. In fact, some are very much larger. We're very happy about that. And we're working with the 4 remaining countries to try to build the evidence and convince them about the utility of this technology to build access, fill gaps in their existing molecular testing networks. So similar to the X-ray and CAD systems, the experience from this project has been used to develop and refine practical guidance on implementing TrueNat, a training package. We've developed operational research questions, a costing tool, and there are also, again, case studies and webinars on our website where countries have been sharing their experiences. Okay, for the last topic, I have to give.
Right. Thank you for stopping that, Bobby, because I think this is a good time to bring Mr. Sriram in. We will, of course, share this presentation with everybody. But we would like, and TrueNat is a good place to stop that. And if you can then talk to us, Mr. Sriram, on TrueNat and other innovations in diagnostics. Thank you.
Thank you very much.
Oh yeah, and sorry, if we can keep this to between 5 and 7 minutes.
I'll make it.
We are already way. Thank you.
So thanks, and as you already saw, we're talking about new innovative diagnostic tools for TB, and we've been talking all day about the need for early diagnosis, accurate diagnosis, and how do you find TB in people, right? So that's the basic question. And we all know that for a long time, microscopy has been the main tool for diagnosing any suspects. And we also know that it's not been very effective because the TB burden still continues, and fundamentally coming from the fact that microscopy is only about 50% sensitive. So half the people don't get diagnosed in time. So we heard all that already. So the point is, how do you then make high quality diagnostics accessible to people? Because culture clearly although being a gold standard is not deployable, and molecular tests also were all highly centralized, so that didn't make too much of sense to be used as clinical routine tools. So that's where we came in the picture, and we spent about close to 12 to 15 years of research to develop TrueNat as a completely portable point of care solution where you can do a molecular test practically anywhere. A completely laboratory independent platform. You can do a PCR right here. You can do a PCR in the field. You can do a PCR at the patient's bedside, at their home, wherever you want. You can do a PCR. So that's the kind of refinement that we wanted to do in the technology. And TrueNat is actually doing that today. And it took us a long time, as I said, about 12 to 15 years of research to develop the platform, and another 4 or 5 years to get it validated, because when we said we can do this, nobody believed us. And so it took a long time in ICMR took about 3.5 years to validate the platform for TB. And, FIND took another couple of years for validation for a WHO endorsement. All that finally happened in 2019. And we're just about, so the Indian government placed an order for rollout in the TB program. And that's when COVID came in. And we had a test for COVID at that time. And so then it was on COVID for 2 years, and now we're back to TB. But having said that, I just want to highlight that, like Dr. Padmapriya was talking about, an ideal platform. So I think that's what we have tried to do with TrueNat. It's not only a TB platform, but it's a multi-disease platform. So at the point of care closest to the patient, you can do not only TB, but you can do HIV, you can do hepatitis B and C, you can do HPV, you can do dengue, chikungunya, you can do malaria, typhoid. There are 40 different parameters today in the market already approved by CDSU, which are available on TrueNat. So the machine is the same, the platform is the same, just the consumable, to a chip that is different from different diseases. So people can just order what they want and they can do. Now at the primary level, these 40 different parameters. So this is the kind of level we have come to. And in TrueNat, even for TB, apart from TB, we can do rifampicin resistance. And today we also have an INH resistance chip, which is already approved. And a test for fluoroquinolone resistance is ready, awaiting for validations. We hope that will happen quite soon. So with this, it will practically potentially can replace an LPA right at the primary level itself, right? So that's, and then we have a test for bedaquiline, which is also ready for validations. So once that comes in, then we have an SDR TB capability right at the primary level. So that's what we are working on TrueNat. Advancements have already happened. So there are many studies going on at this point of time. And ICMR is also planning to start a study now. And globally, there are some 2 or 3 studies going on, and the reports so far are very encouraging. Of course, we also found that we have to be a little bit more innovative. So in a tongue swab, I'm sure my colleague, Dr. Nair, will speak about this later, but you expect the bacterial loads to be much lower. So we have found an innovative way of breaking the bacterial cell walls to get highest efficiency of DNA coming out of it. So data shows that the sensitivity of tongue swabs also is pretty good. May not be up to sputum, but very close to that. Of course, we need more data generation to happen. But I think the way it's going right now, it looks like it's not going to be too far before we have a tongue swab test in the market. So TrueNat is now being built to address all these gaps that are coming up and trying to find more and more, solutions. But apart from that, we know that that's only for, so we can do a molecular test, but then it's mostly meant for people who are coming to the health system, right? To the primary center. So these are all presumptive TB cases. But then there is also a need for active case finding, as we've been talking about. If you want to do TB elimination, you have to pick up asymptomatic cases, high risk burden areas, people living in slums, people close contacts, and so on. So, and it's clearly understood that a molecular test cannot be done on anybody. So now we have a digital X-ray system, which is a handheld digital X-ray. So this is completely developed in India. through our partner company. Again, there'll be presentation on that. So we already have the tool, so you can now use that and TrueNAT, and maybe even put that into a 4x4 vehicle like a Mahindra Jeep or something like that, and go anywhere, and you can do screen population with the X-ray. And there's an AI-based algorithm for automatic interpretation, so you don't have to wait for a radiologist. So within 2 minutes of an X-ray, you get a report. And if the report says that it indicates presumptive TB, then you can confirm that on a PCR right there. And once you confirm on the PCR right there, all the PCR machines are directly linked to Nishchay portal. So it updates Nishchay directly and you get into the program straight away. So the same day you get final diagnosis, even in asymptomatic screening, and the same day they can be put on treatment. So that's the level of efficiency that we are trying to achieve this kind of a model. So these are all very innovative ways we're trying to go about this. Dr. Bhagavapriya spoke about an ideal solution of having a lateral flow kind of a pregnancy test kind of a test. So we are working on this platform. This is an antibody test for active tuberculosis, and it seems very promising. So ICMR is just going to start a study on that, and that works. It will not be, of course, a confirmatory tool. It will be more of a triage test, but it will be able to rope in presumptive cases again, asymptomatic cases also, and you can then confirm through PCR for the steps that we go along. We are also working with the company on the cuff-based system for vocalization of cough as a marker, and that is also awaiting more validations, but they've come a long way in that also. So we're doing multiple things to see that we're giving this 360-degree kind of capability in terms of tools for TB diagnosis, and that is where Molbio is sort of coming in the picture. So just to give you a gist of all that, one more part of this was how are they going to be deployed? Because one is to innovate, which we are doing, but then now the innovative tools are there, but are they getting deployed adequately is another question. Although India claims is probably one of the countries which have adopted this faster, but even in India today, only 23% of people are getting tested with a molecular test, right? In spite of this technology being available, could be a point of care, working as point of care solution already, but still there's a big gap. So this gap has to be filled. If you want to end TB, 25-30 is immaterial, but whenever we want to end it, we will have to ensure that everybody has access to this tool and everybody is actually, being diagnosed with a molecular test. So from 23% to 100%, how much time it's going to take, we don't know. And that's what needs to be compressed. So in this forum, this is what I want to bring forth, that while it's good to have, talk about innovative tools and developing tools and all, but they also have to be deployed effectively and used effectively. And there are a lot of gaps. So there is a political will, there is a need, there is a program which wants to implement, but still things are not happening the way they should happen. Right? Is it because of funding? Is it because of, bureaucracy? Is it because of, some disconnect? We don't know. So I think that's where all of us, including the media, can play a role in trying to keep on highlighting this point, because every time people keep saying, no, we need tools, but tools are there. So why don't we use them, right? So that is one thing I want to leave away with. And second thing is this always issue comes about, don't cheap test, but then there's a limitation to how much cheap can be, right? So you have to see the cost effectiveness and the impact of the test, right? And clearly there are many studies which have shown that putting a molecular test, the cost effectiveness is far superior to, a cheap test, as simple as that, right? So that needs to be understood also in the context, so that we don't get stuck with these kind of things. Thank you very much.
Thank you, Mr. Natarajan. Now we have a speaker online, Mr. Shibu Vijayan. He is Medical Director of Global Health. Do we have him?
Yes, I'm with you.
Hi, Dr. Vijayan. Welcome.
Yeah, I probably need the support for sharing my slide from here, and I already emailed that to Bobby. I can try it from my side, but sometimes it goes everywhere. Just can you see my screen?
Yes.
Okay, cool. Then I'll do it from my end. Thank you.
Dr. Vijayan, before you start, if I may just say, if you could, restrict around 5 to 7 minutes.
Yeah, I'm going to do that.
Thank you.
So, I mean, you might have already heard about the value of X-ray, and also mentioned, Dr. Sriram just mentioned about ultra portable X-ray with AI as an interpretation tool. So I'm going to introduce a technology which is available, which is Indian, and you also heard Wayne talking about ultra portable X-rays and AI interpretation being tested in the new tools project. Just wanted to mention that is that what you heard from Wayne is a technology which is a pioneer in triaging, which is developed in Netherlands, and we do have the similar thing, much better versions available in India. I just wanted to introduce that. So the value of X-ray has been mentioned earlier, but again, X-ray is coming back like bell bottom in the fashion industry is coming back in the TB space. So X-ray get a lot of traction because we are seeing in prevalence surveys X-ray have value, and because the people who are asymptomatic has been flagged in series prevalence surveys, which is plotted in this graph. I just don't want to repeat it, but there's a clear-cut value in the triaging and using X-ray as a test to understand asymptomatic cases. So this has been recognized by WHO, and WHO has already given guidances about using AI tool for, in the absence of a trained reader, AI could be relied as an interpretation tool. So that's been widely deployed in the world. So I represent a company called Cure.ai, the medical director for global health. I've been in this TB space for more than 2 decades. This product is an FDA approved, again, recommended by WHO. So it is mentioned in the WHO guidance document for diagnostic and case finding. And also we are now a company which actually impacts almost 5 million lives annually with the 200 employees deployed in more than 75 plus countries. So coming specifically to the X-ray AI tool, which actually helps in interpreting just X-rays. This is a software. There is 30 different abnormalities could be identified, and it pre-populates a report as a radiologist report. It calls out the probability of the probability of tuberculosis is a combination of findings, which calls out and quantifies the probability from 0.0 to 1 or 0 to 100%. So by default, we have given a threshold of 0.5 as a probability score, and then there are methods of calibrating it. But again, by and large, that's the threshold which we provide. So wherein the AI will provide in a good setting with a fairly good internet, more than 10 Mbps, it will give a report within less than 1 minute with an interpretation of chest X-ray normal or abnormal, with all the findings getting reported, and also calling out a probability of a TB score. So these are various use cases of X-rays, like normal, abnormal. It also quantifies lung cancer, early lung nodule, which is small lung nodules, could be quantified with a cancer scoring given, the probability of cancer scoring given, something similar to tuberculosis scoring. So there's a value of integrated screening for TB and lung cancer together. It also have capabilities of calling out occupational lung diseases like silicosis. It have value in calling out the cardiac thoracic ratio, and again, probably giving a probability score for impending heart failure, and also looks at emergency situations like rib fractures, pneumothorax, etc. So I'll just focus on how it's getting deployed. So there are typically X-ray has been used in the TB space for active case finding, and again, this we have seen when Wayne mentioned about it. I'm not going to touch about it, but I would want to mention. I will take a couple of minutes on the incidental case finding experience from Mumbai and in India, and also integrated screening for TB and lung cancer from Vietnam. So if you follow this workflow, which you see seen the screen, so X-ray AI has been recommended or suggested for mostly where doctors are not available. So Mumbai Corporation realized even if their facilities, like the secondary and tertiary facilities, they are finding it. Patients are losing. They had a hunch that they might be missing cases. So they said, okay, can the AI be deployed in the X-ray department So all chest X-rays happening in the X-ray department will get an opportunity to get screened by AI, and AI flags an abnormality of tuberculosis. It get notified to the TB staff within the facility, and all these facilities are co-located with either TrueNat or Gene Expert, so patient need not go too far to get it tested. The post the notification, the health staff will touch base with the patient and then collect the sample and get into the molecular diagnosis. So just wanted to emphasize that this is not actively asking patient to go and take an X-ray. All X-rays happening, chest X-rays happening will get screened. So patients who are landing up in emergency department, patient who are in ICU, patient who are admitted for some other reason, patient who come for the pre-anesthetic checkup, everyone will land up. So interestingly, what we have seen over the last couple of years, 100,000 X-rays has been screened. And we found 35% of the cases confirmed of the diagnosis were not from the TB referral pathway. They're not referred for excluding any lung conditions. They were just randomly picked up. So there is a value in actually using X-ray even in tertiary facilities for AI in tertiary facilities for picking up cases which probably will get missed. So as we are heading towards early detection, this is a good tool to be deployed. And here comes the value of picking up subclinical tuberculosis also, because these are asymptomatic cases, but still there is an X-ray signal and then subsequently microbiologically positive. So just keep this in mind. So we also did a modeling based on this thing. So we have 800 district hospitals in India, which is pretty much similar to a secondary or tertiary hospital in Mumbai, wherein 400 to 500 outpatients are coming, 100 X-rays are taken per day. So if you do it judiciously across all the 800 facilities, we probably will end up in getting 200,000 extra cases per annum, as additional incidental cases. We also, so subsequent to the Mumbai experience, we also got support from US side, Samarit, to expand it to 50 other hospitals in the similar way. So what you are seeing. But again, this is much more lower. So as we encountered, because we also see that I'm just going to talk about a different use case. So when we started deploying in the government facilities, we also realized that a lot of facilities are still in the analog analog X-rays. It's not digital X-rays. One of the prerequisite for any AI tool to function is like a digitization of digital images necessary for it. So with support of India Health Fund, we developed a mobile-based application which actually helps in clicking the photograph of an analog X-ray and kind of digitizing that and then run the algorithm over it. And we also done extensive study on how the algorithm's performance on digital X-ray versus analog X-ray getting digitized to a mobile application, which is pretty much comparable. So we deployed that along in partnership with Pyramid Swasthya Foundation in Chhattisgarh in tribal population. We are getting encouraging results. So you see that the microbiological test positive is roughly around 25%, and then it also augments more clinical diagnosis as well. So yeah, so this is a last slide which I would want to mention about the value of X-ray getting used in tuberculosis. It's go beyond tuberculosis. It's a health system tool. It has, and now AI has a lot of actually capabilities to pick up multiple diseases, and it reports. So it also auto-populates the report. So it takes away a lot of time for the doctors to kind of doing all their clerical job. It enhances their efficiency because they get a pre-populated report. It also increases their quality because it's, the software is consistent across the time and across the full duration of the day. We as doctors probably will get fatigued, and our quality of response will get varied. So software could be a good quality assurer for a clinician as well. So there is scope for actually using beyond tuberculosis, even in Indian setting. This is a Vietnam setting wherein we are getting identifying more number of early lung nodules, which actually helps in detecting lung cancer, and then very early, and then further profiling and offer treatment, and better outcomes will be there. Just thank you. I'll leave it there. I know that this is super fast, but I'm happy to answer any question through emails. I won't be staying throughout the session. So, and if you have any pressing comments, I can come live now for another 5-10 minutes. Thank you.
Thank you, Dr. Vijayan, for your presentation. I don't think we will be taking questions right now because we are really far behind the schedule. I think if
here have any question, they can email to.
Yeah, thanks. Appreciate that.
Next, we have Mr. Krishna Prasad. He's founder and president of Prognosis.
Hello, good afternoon, everyone. I'm Krishna Prasad from Prognosis Medical Systems.
Mr. Prasad, sorry to interrupt, but if you could, finish in about 5 to 7 minutes.
Sure. So we are a company that focuses on development of digital X-rays. We design, manufacture, and offer digital X-rays across India. Next slide, please. So we have a full range of digital X-ray products, fixed units, sealing systems, mobile, and of course, handheld. So the handheld range of products, ultra portable or handheld as they're called, are new. This is primarily developed to address the TB challenge that we have across India. And we team up with Molbio. We are a part of the Molbio group, and we work very closely with Cure. Next slide, please. So this is our product. It's called the ProRad Atlas Ultra Portable. Next slide. Basically, it's very, very light. It's less than 3 kilos. You can take it to the field. And the best part is it's touch panel based and it's very operator friendly. So you just need to touch the chest X-ray in the anatomy figure that's shown at the back. And the size of the patient, you have 4 options: infant, thin, mid-size, and thick patient. Automatically, all the parameters are set based on earlier program, APR, that's already a part of the. So you just focus and shoot. Next slide, please. So these are some. Next slide again. So what we couple this with is a digital panel. It's a special ProRad detector, which we have designed for field use, because the goal is to take all these devices, especially the digital X-ray system, along with the TrueNAT, to the field. So one of the first things that we realized is that an expensive product like the detector, next slide, which is basically built on a TSR or a glass panel, can break if dropped, which is quite possible in a field. If it drops accidentally, the entire substrate breaks and thereby making the entire panel unusable. So one of the first innovations that we have introduced into this field, along with the ultra portable, next slide, is a special purpose non-glass based substrate, which means that there is a lot of robustness that is built into the system. Now, the technicians who use it in the field can use it with a lot more, confidence that even if the detector is dropped, there is no collateral damage. There is no damage, so that the entire show stops there. Next slide, please. Yeah, so some of the areas, typical areas of application, it is not just for chest, but you can use it for fractures and extremities and other areas, including the skull. There are more applications that can be done. The next slide, please. So one of the important things when you deploy this in the field is to capture the patient information. So what we have done is we have a platform which is called the electronic medical record, the ProRad EMR, which talks to the medical devices. It can directly connects and grabs the data. In this case, it's the X-ray ultra portable. So what you do is you register the patient, you take an X-ray, the chest X-ray is taken and pushed to the AI system, which is within the laptop. It is within the system. So you don't even have, if you go to the field and you don't have internet connectivity, which is quite common, quite often across multiple areas, no problem, because the result, the AI result in about a minute or so is available on the very same system. So based on the outcome of the AI system, we can immediately connect or send the patient for a TrueNAT confirmatory test. So this is all connected. This is all capable, and we additionally have a teleradiology or a teleconsultation system in case the technician feels that he needs to consult a specialist. Even that is available as an option right then and there. Next slide, please. So a standard kit that we offer consists of the ultra-portable handheld unit, a detector which is robust, which is drop resistant to some extent, a laptop which comprises of the electronic health record, which is basically for registering the patient. Second, you can take the chest X-ray, and as soon as the X-ray is taken, it shows up on the screen within a few seconds. You can refer for an AI diagnosis or an interpretation right there. And within a minute, you have the interpretation. And if the patient is, if the TB score is on the higher side, and if the patient needs a confirmatory report, the same system can be connected optionally to a TrueNAT device, which is available then and there, and a confirmatory result available within the hour. So this is what Mr. Sriram was talking about. So all of this fits into a backpack. And next slide. Very easy to carry. You can carry it to the patient to small remote villages on a motorcycle, or we also have special purpose vehicles which we have designed. Next slide, please. This is a Jeep or a Mahindra SUV which has a four-wheel drive capability. You can drive it anywhere. It's been designed specifically for this program. As you can see, it has a X-ray safe area where a patient can be examined. 3 people can travel in it. It's completely a hybrid system, which means all the batteries that are running these systems get charged when the vehicle is being driven. There is an optional solar panel. You can connect it to the main grid when you park and conduct the investigations. All of this is available within one van. The next slide. So it's the same thing again in a more descriptive way. Next slide, please. So this is one of the larger formats where more tests can be conducted. This is typically, we work with organizations like the WHO. This is one such example. Next slide, please. Yeah, these are others. Other than tuberculosis, we also work with Molbio for screening cancer. In this case, we are looking at breast cancer through another partner of Molbio, and also the HPV screening that is possible on the TrueNAT itself. Next slide, please. Yeah, the next one. So finally, what we are saying is this is all built in India. These are projects that we do not only in India, but across the world. The good thing about this entire innovation is the digital X-ray system, which is a very compact, lightweight one, can be taken to the field. It's battery operated and can do up to about 100, 150 exposures made in India. Connecting with AI system that's also from Cure. We partnered with Cure on this. That's made in India. Molbio, which is the TrueNAT manufacturer and the giant behind the entire program, that's also made in India. So we have everything that works, and we are very proud to offer this for not only for the Indian requirements, but also for the globe. Thank you.
Thank you, thank you, Mr. Krishna, for your presentation. Again, as I said, we won't take any questions right now because we're really behind time. So I would like to invite Dr. Karthikeyan, Technical Lead TB for KHP. Dr. Karthikeyan. And the standard disclaimer, if you could keep it to 5 to 7 minutes. Thank you.
Good afternoon, all. Sorry to stand between you and lunch. Thank you, Shobha. Thank you, Bobby and Pramod. Clock is running. I'll have to finish by 5 minutes. So many technologies, wide range of display. The happiest thing is we have it in our own country. But again, I am reminded of what beloved friend Dr. Tara was saying, though Prime Minister announced TB-free panchayat, how many of our panchayats know this agenda? National agenda is there. There is a vision in the country, but has it trickled down to grassroots? That's still a question. Two examples from my city. It's a metropolitan city. Even now, though CBNAT is there, TrueNAT is there, it's not done for pulmonary tuberculosis as well as for EPT. When friends come for second opinion, I used to ask them, can I see the report? Not even any test done, empirical treatment is started where there is a provision to do molecular test. There is no dearth of testing facility, cartridges in that city, but still that message has not yet reached even to the treating community. Whose responsibility is health? I need to be aware of these are the tests available, not the treating physician, not anybody else. The common people will have to know these are the tests available for your own health. If that patient X and Y asked, why no test is done for me? Why not NAT test has been done for me? Then the doctor who was treating those two patients might have thought, okay, there is something else is there. But unfortunately, till 2 weeks before, this is the scenario in a metropolitan city where I come from. So sad to say this. Where do we miss? The message is very clear. We will have to bring upfront molecular testing. But who are the effective messengers? Are we the effective messengers, or do we need to invest on effective messengers who are in the community? There are two examples, two lessons which we learned from Karnataka and Bihar. During COVID time, once quarantine period was over, vaccination started. Lot of vaccination hesitancy among people. Who bridged that gap? It is Gram Panchayat members bridged that gap. The vaccine hesitancy was overcome by Gram Panchayat leaders when they are trained about the efficacy of that vaccine. So our focus needs to be, who are our effective messengers? We will have to go down to the grassroots level. So many technologies, if we want them to reach the grassroots level, we will have to choose this effective messenger. Second experience from Bihar. We all know about Jivika Group. In 3 districts where KHPT worked, we are still working, Purnia, West Champaran and Bhagalpur, 1,300 self-help groups who are trained, not sophisticated training. 3 major things. TB is a problem in your place. Second, these are the symptoms of TB. Third, TB treatment and testing is available in your neighboring facility. These 3 messages are given to self-help groups. Those Didis, Jivika members took it as a passion, and these 3 districts could reach the target of presumptive examination rate compared to all other districts where the self-help groups were passionately working. So we will have to focus now on effective messengers, then ending TB will be a reality, not as a dream. Thank you.
Thank you, Dr. Karthikeyan, and for keeping within the time. Our last speaker for this session is Dr. Ashish Jain, who's the head nutrition and health at the JSW Foundation. Dr. Ashish. I'll add 5 to 7 minutes. Thank you.
I'll keep it for the
Thank you. Thank you, everyone. Good afternoon. I know the time is constrained, so I'll keep it as simple as I can. 2 days ago, when Prabodh invited me for this, I was contemplating continuously that how to interact with media when I am having the most limited exposure with the media. What type of thing I have to prepare all these things. But sitting here and listening to everyone, many things had come out, be it technical thing or be it operational thing, community-based thing, system-based things. We have to identify the problem which everybody is saying. But in my view, if you're not asking the right question to the right person, things are not happening. And I'll give you one example. I'll give you an example of my association with Prabodh. We are supporting Prabodh's organization. If you will ask question to me that why things are not happening in the community, I'll be the happiest person to answer that. I'll give you 10,000 types of answer saying that प्रबोध को तो ये बताया था, प्रबोध को पैसा दे दिया, प्रबोध को टीम दे दी, प्रबोध को ये कर दिया, ट्रेनिंग दे दी, एक्सपोजर दे दिया, कहानी मेरे पास बहुत सारी रहेगी, लेकिन मैं बच जाऊंगा. So you're not asking the right question to the right person. What type of input I had given to Prabodh, or what type of interaction we had with Prabodh? What is my connectivity? And this is second example which I'm giving is that at most of the occasion it happens. It happens at, in my various assignments previously when sitting with central ministers or the state ministers. Health problem and health or the nutrition problem. You connect from the topmost to the directly to the last person. You are asking the topmost person that what that last person is doing. And you are having all the answers. Where is the middle management? Why we are not fixing the question to the sir has done with their people. If the things are not moving, and I'm saying it why it is not moving, that out of many problems, if I have to equate tuberculosis and nutrition in the country, the results are against us. Against us means against everyone. Whomsoever is saying that they are practicing in whatever their capacity would be technical, scientist, implementation, whatever. The results are against all of us. And against these results, we are not asking the right question to the right person. And therefore, we are unable to ascertain. Somebody was saying that we have to ascertain what is the problem. Therefore, we are unable to ascertain the problem. And going further, the technology, when I say that, when I was thinking about this innovation, why it is innovation only in technology? Why this innovation cannot be the thought process? People are advocate of their own program. People are advocate of their own guidelines. But results are not there. So what is the point of implementing the same guidelines which are not giving you results? So somewhere, if you are thinking innovation, we had to ask question non-technologically also. Why there are innovative way of partnering? Why they should not be innovative of networking, bringing new knowledges? If we have to achieve those results, we have to break down backward. We have to define those every day, what we have to do every day with whom. Otherwise, and we have to learn it from the successful model which we have implemented. We have implemented one of the successful model of reducing mortality rates, particularly for the children, particularly for the neonatal deaths. What we have done, there are successful models. Many more. This country has escalated in this area like anything. What was the successful model? The same people, same set of people, same set of systems. They are giving the results. But the same type of system, same type of people are not giving results. How it is possible? So innovatively, we have to position our questioning also, programming also, program designing also, new partnership, new things, it has to be brought in. Keeping in mind the results and the time frame. We cannot say that we are doing it indefinitely. For another 20, 25 years, we'll keep on doing the same old thing, which is not giving result. In past 25 years, whatever we have done, Many things had been done, but the results are not there. That means another 25 years, whatever we'll keep on doing the same old thing, the results will not be there. So in my view, innovation when it comes, it's not only technology, it is also the thought process. Not challenging in the time of challenging, but yes, challenging our own standard treatment guidelines, standard treatment protocols, standard guidelines. Unless we don't challenge it, we'll not evolve to another level. And therefore, the results will be on that side. The problem of resources, I don't think that the country is having a problem of resources. The problem of getting the resources is a problem. When many people say that what is the problem in tuberculosis, we say the result is a problem. Result is not a problem. Getting to the result is a problem. So we are not identifying, innovatively, we are not identifying the right problem. We are identifying the old thing, saying that we are the biggest carrier of tuberculosis, diabetes, nutrition. Well, we all know it. But why we are unable to achieve it? We are not identifying those things. So with my limited submission, limited time period, in my view, that innovation comes if we challenge the status quo where the results are not coming. It could be technology, it could be non-technology, bringing many people, asking the right question to the right person in a right time frame. Time is running against us. So that's my little summation. Thank you, Prabodh, for inviting me. Thank you for everyone listening me. Thank you.
Thank you, Dr. Ashish. And again, I think it's been a long session. We've had many speakers. I think, the role of innovative new diagnostics is a key part to how we, end TB. I think we also mentioned we also need to see how to scale it up. And I think what's going to be important is taking all of this to scale. How do we really ensure that the entire country is covered? And I think that's the part where everybody needs to be in it together. I mean, we cannot do it. One person is not going to do this, and we all have to do this together.
No, I just want to thank Banjot and Prabodh for chairing the long session in a very good manner. Thank you very much. And I now welcome Lata Mishra, Assistant Editor Health at Times of India Plus Digital, and Nurul Islam Hasib, who is Special Correspondent, Dhaka Tribune, Bangladesh. He has come all the way from Dhaka to chair our next session on making a difference in finding TB on the ground.
First of all, apologize that we are sitting exactly at the lunch time or lunch break time. So, but we can reassure you that in 10 minutes, we will stop here and then reconvene after lunch. So in 10 minutes, bear with us. So my name is Nurul Islam Hasib. I am a reporter in Bangladesh. So being a reporter and what I can, and first of all, I should thank Bobby and Shobha for inviting me. And also it's my pleasure to share the stage with my dear friend Lata from Mumbai. So I think without explaining or telling, we should go to the Lata. Yeah. Okay, so basically, okay. So I'd like to invite Dr. Manish Goenekar. And it's my pleasure because this is the most relevant thing I would say. We are sitting in Goa and we'll know the story of Goa. And in this session, basically it's a different session. We'll know what is happening on the ground, which is very important because what we listen in the morning, that there are some local contexts, local solutions, local things. So from Goa experience, I think I can also tell my Bangladesh audience, because in this region, we have some common problems. We people are common. We have so many common strengths and common challenges. So the way of addressing the challenges, I think we can find from Dr. Manish. Thank you.
Thanks a lot. So as far as Goa is concerned, we started Upfront Net from December 2020. Before that, we were doing microscopy test for diagnosis. And we had 24 designated microscopy centers. And at a time when there was COVID and our presumptive TB examination rate dropped like anything, we started with upfront net. So I'll just show you the graphical representation. So in 2020, there was a scare and nobody was ready to come forward to get themselves examined for TB. Everyone was worried about COVID, and because of that, nobody wanted to test for tuberculosis. That was a challenge. Although before that, we were thinking and exploring the idea of whether we can shift to upfront net. But at a time, but we were totally worried that once we start shifting totally from microscopy to upfront net, there would be various challenges. First one was drop in the testing rate. The second one would be how our staff would cope up, because all this while for years they have been doing microscopy. And now if we suddenly tell them to shift to net, it would be a challenge, because in the previous algorithm, after doing microscopy, as per the guidelines, we have to do net test within 15 days to detect rifampicin resistance. But now we had to convince our staff that once the diagnosis is done, they don't have to send the sample out within 15 days for net test. So with this challenge, we were thinking whether we should shift or we should not shift and when to shift. But when we realized that the presumptive TB examination rate has dropped like anything, even if it drops further, we can blame it on COVID. And over a period of time, we will be able to get through and our presumptive examination will go up. So during that time, there were no meetings, physical meetings being held. That was another challenge. So virtually, we had a couple of virtual sessions. First, we thought of sensitizing our PHC health officers or those who are heading the PHCs. We had a quick training for them, and they were not much in favor at that time because everyone was worried about COVID. Then we had a training for the nodal officers. For each PHI, we have a nodal officer for tuberculosis. We had a training for them. The third training was held for lab technicians across the state, those who were doing microscopy. And all the sessions were virtual. We really did not know whether the information has percolated down the line and whether we would be ready to start with upfront net. That was another challenge. But we decided that we will go ahead with upfront net because we had enough testing capacity. We had we had 5 net sites. Both the districts and medical college had net site. So we thought that we will go ahead. We prepared we linked each PHI to a net facility. And we assured that funds can be utilized from the program for transportation of sample. So the transportation of sample they have been doing for UDST, but for diagnosis, the number of samples to be transported would be much more for every presumptive. So we made arrangements for that, and with the support of our staff who would go in the field, our STLS, senior lab treatment supervisors, we assured that each LT from each PHI knows about it. And we moved ahead. After moving ahead, we started taking virtual meetings every week for about 1 or 2 months. Then every month we started taking separate meetings virtually of the PHI. we started monitoring how many samples are referred and whether the tests were made available to that respective PHI, which we were updating in NICSHI. And over a period of time, we did see a drop in number of samples being tested. But over a period of time, maybe 2 to 3 months, every PHI was sure about it. Everyone was doing presumptive TB examination rate, which we carried on. Yeah, please, next. So there was a drop, if you can see 780. Previously, we were doing about 1,338 presumptive TB examination rate was 1,338 pre-COVID, dropped to 780. And then over a period of time, it jumped. Now, if we see from the jump from 1,330 to 1,800, there is a steep rise. Now everyone is aware of upfront net, but when we intensified monitoring to increase our presumptive examination rate, the referrals, the quality of samples would be a challenge. So we started monitoring quality of samples as well during that time from 918 to 1330. And from that time till now, our sputum quality has improved like anything. One more thing, at that time in 2020, when we moved to upfront net, getting a good quality sample would also be a challenge. That is what we realized. And we had a special video in local language for all the LTs so that they are trained to obtain a good quality sample. That also be assured. Yeah, next, please. Next. So the algorithm changed from presumptive TB examination. When a symptomatic comes, we would be doing sputum microscopy, confirmation of diagnosis by microscopy, and start the patient on treatment. At that time, rifampicin resistance wouldn't be known. And then we would be doing the net test and then changing the regimen. So with this upfront net, we can directly start the patient on treatment, the right regimen, instead of changing the regimen. So another challenge was private sector engagement. So we designed this flyer and it was circulated in IMA groups. We had several meetings with IMA. Also, we had CMEs subsequently post-COVID for IMA doctors across the state. So we are also doing on-site evaluation by STLS and quality assurance for the net test, external quality assurance. So this was the video in local language for obtaining good quality samples. So this is the number of, I'm sorry, it's not come up well. So we had 5 net sites, and over a period of time, now we are having 17 net sites, 16 plus one more. So every block has a net site. Every block there is a net site. And maybe another week, we are going to have the 17th site. So we started with 4 CBNet machines and 3 TrueNet machines. And now all the TrueNet machines which were taken for COVID testing, over a period of time, we have shifted for testing for tuberculosis. And now we are having 17 net sites, 17 TrueNet machines for TB testing. And our target is to have equipped every DMC with a net site, so that entire microscopy, what was being done, we would be at all those centers, we will be having a net site. So the next thing with this motivation, now we have started with the end CP culture, sputum culture, and we are the first ones in the country to start with end CP sputum culture. 3 months back we have started, and it is 100% for all our patients. So at the end of the treatment, we are doing microscopy as well as sputum culture. Thank you so much. Thank you. We have our notification is about 2,000 per year. So on an average, we will be having, as of now, 1,400 to 1,500 patients on treatment. Yeah. So the presumptive TB examination rate to scale it up is still a challenge. Our target is 2,500. 2,500. We are at 1,800 odd. Now our target is 2,000, and then for the next year it is 2,500. Coming year it is 2,000, and then we would scale up to 2,500. So how we have done it is we are having 200 health and wellness centers. So each health and wellness center is assigned a target of 2 samples per 1,000 population per month. And one of the PHI has done it 100% in their jurisdiction. They've scaled up, and 2 referrals per 1,000 population per month they've already started. And it will be, we are monitoring it, and over a period of time we hope to increase the active case finding is also ongoing. It's also ongoing. So samples from that also we are getting. Yeah. So about our notification is about 2,000. On an average on treatment, we would be having 1,400 to 1,500 on treatment. Yeah, per year.
Okay. So I think our session for now it ends, right? Pauses. Okay. We'll reconvene, right? We'll reconvene after lunch.
Thanks a lot. Thank you. Thank you.
So lunch duration, Shobha, you can. Yeah. Thank you.
Okay, so I think we've got a lot of food for our brain, but our body is craving for some nourishment. So we break for lunch, and is it okay if we can reconvene after half an hour, not more than half an hour? Yeah, thank you. In the interest of time. Yeah, 2:20. 2:20, we are back here because we'll be having a very interesting panel discussion there. Thank you. Yes.
Hello. Hello.
Hello. Oh, for those of you who are done with lunch, could you please enter the hall again so we can have a group photo? Everybody outside, could you come back in if you're done with lunch? You can't hear? But same thing if I go out. Could we get back into? I was about to walk out with this. Yeah. Could we get? Are we done with lunch? The ones outside who are standing around, please could you come in for a group photograph?
Hello, Dr. Noah, are you online?
Hello.
Rishikesh.
Hello.
Are we waiting for few more people to come or we can start? Good afternoon, everyone. Hi, I'm Lata. I think we have already finished one speakers. It's about session is all about so the session 5, which talks about the making a difference in finding TB on the ground. I think we are all always, I think we are all being criticized for writing negative stories when we are on field. On ground, we always report about what is happening on ground, and when we go to the spot, we see what are the lacking in, when it comes to tuberculosis control program. And I think I've covered many stories which talks about, the real problem the patients are suffering, and how even those volunteers who are helping TB patients in terms of screening, detection, they are not being paid for months. It's a very the situation which I'm seeing since last maybe almost 10 years, and I don't see much changes, as I think somebody had mentioned that why again and again we talk the same thing, but we are not reaching to that level, where we can say, yes, we have achieved this much in terms of controlling the tuberculosis. And now we have screened so many cases. But when we are on ground, we see some different picture. Like, the patients are suffering, or, they are not getting the medicines on time. They are not getting nutrition on time. So many things which we write. I think this session is all about, finding the TB, what is happening on in terms of ground. So I think our next before that, I would like to show one slide which I think it's very important about one story where I want to mention, if it is happening, Rishikesh. Also, I think if it is possible, I think in this session we should also talk about the mental health problem what TB patients suffering from. Like, not I have not seen any session which talks about, or any psychiatrist, or anybody who's talking about the patient suffering from mental health issues, and how we are dealing with this issue. So this particular topic which no, this one. So this patient, this was a story which I want to discuss about. This is he's a ward boy from Shivri TB hospital, and he was attacked by a TB patient. His wrist was slashed by a knife or some blade, and he was working in the ward. But this patient was actually all of a sudden become very violent, and he started attacking on those staffs who were working in the hospital. So it's a very serious issue in terms of, what the patients are going through. In the hospital, the caregivers are not coming to see them for months. There are many patients in the hospital which they are, they are abandoned by their family members. What is happening on them? Is there somebody who's taking care of them? I go to the Shivri TB hospitals, and I see there are many patients who are actually cured, they are recovered from TB, but they are they are not being taken home again. Their relatives are not coming back. They are giving false addresses to the hospitals. They are not coming to see them. But imagine those bunch of patients who are cured, not suffering from TB. They are disease-free patients, but they are still in the hospital. Nobody's coming to see them. What is happening? These are if we're talking about the real, so many patients, but if you see, one hospital, patients are there, women patients are there, and it's like a very sad scene, if you go to any hospital and you'll see. I mean, my only point is that here we should also talk about the mental health of these patients and also those who are abandoned. Why there is still stigma is attached with this disease? Why it is not? Are we doing enough awareness about this disease? Are we reaching to that level? Why there are still relatives are coming and they're giving false addresses? Once the patient is, he's admitted, they're not coming to see them. It's a very scary picture, which we are being criticized for many things because we are writing negative stories, but it's not negative stories, which I want to tell you. It's not negative stories at all. We just want to highlight the real pictures on ground. On the ground, what is happening. So this patient is talking about, I'm getting medicines, the government is taking care of providing medicines, but yes, the kind of food which are given in the hospital, it's watery milk, very less rice, dal, nothing, there is no protein, nothing in the, in their meal, if you see, there is hardly anything is there, no nutrition supplements are added in their meal. So I think nutrition, yes, and now the story is written in 2012, and still we are talking about nutrition supplements. Nothing is being done. Still, I'm seeing the same situation. If I'll go to hospital, if I'll go to any ward, any cities, any hospital, I'll find the same situation. So it's been almost 10 years, and we are the same place, same situation. So I think let's talk about the next.
Can I just intervene here? Lata, I beg to differ on one account. You are saying that we are always told that the media writes negative stories. No, it's not. Media has been praised also for putting spotlight on positive stories as well. And media are equal partners, equal stakeholders. And that is one aspect of this meet here today. We are all equal partners. Thank you.
He actually is from Vietnam, the deputy director of.
Hello.
Hello. He's a deputy director, National TB Program, Vietnam. So he's not here. He's giving his session online.
Yeah, thank you very much for the introduction. So on behalf of Vietnam TB, I would like to present the very fast on the efforts to find the missing TBK to end TB in Vietnam. So in my presentation, I will slightly show you the important role milestone of the Vietnam TB. As we started TB activity from the 1957, and in the year 2006, 2007, and the year 2017, we conduct the National TB Prevalence Survey, and it shows that the TB prevalence in Vietnam is very high. This slide shows you the incidence and mortality rose in Vietnam in the year 2021 due to the COVID-19. Before the COVID-19, in 2019, the treatment coverage in Vietnam is around 61%. However, due to the COVID in the year 2021, the treatment coverage is a reduction to 46%. So it makes the incidence is increase and the mortality is increase estimated by WHO in Vietnam. So that's in the year 2021, Vietnam ranked 7th among countries that accounted for more than 90% of the global dropping the notification. And this slide shows you the TB epidemic in Vietnam in the year 2022, with our country with nearly 100 million people. We have an incident of the 172,000 of TB case each year, with a rate of 176 per 100,000 population. And the estimated proportion of TB case with MDR or rifampicin resistant is 4.5% among the new cases and 15% among the previously treated case. And in the year 2022, we have recovered from the COVID-19 and detected 103,804 TB cases. And this is the increase very much compared to year 2021 and it's around 78,000. So you can see this in this figure in the 2022 compared to the 2020. The TB notification in Vietnam is the comeback after the COVID is 103,000 compared to 78,000. So in order to do that, we have a strengthening active case finding campaign in the year 2022 for recovering the detection. We have conducted 478 active case finding and intensified case finding in the year 2022, with the mainly is funded by the Global Fund, other is funded by the USAID SAT project and local government fund. With the total people screened by chest X-ray is 1.2 million, and proportion of the X-ray abnormality is 7.5%. From the active case finding, we have detected 19,337 TB cases, accounted for 90% of total TB cases notified in the year 2022. So this slide shows you the Vietnam laboratory system. We have one national reference laboratory lab in the National Lung Hospital, and we have 5 regional lab and 34 culture lab. We have 4 LPA lab and 179 expert site with 332 expert machine in the country. We also introduced a TrueNAP machine at 30 sites in the 20 provinces with 38 TrueNAP machine. And in Vietnam, we have conduct the expert for detecting the TB cases. So the MDR TB cases, the number of the TB, the expert test is increased year by year. And in the year 2022, in the whole country, we have conducted about 358,000 expert tests. So this slide shows you the number of MDR detection by year. It's increased year by year from the year 2009 when we start PMDT, and increase until the year 2020 with TB MDR TB case detected is about 3,500 MDR TB case detected, and it's a reduction in the year 2021 due to COVID and come back in the year 2022. However, the number of MDR TB case detected in Vietnam is very low, still very low compared to the estimate by WHO. It's 8,900 MDR TB case incident each year in Vietnam. However, the treatment outcome of MDR TB in Vietnam is quite high compared to the globally. We achieve 77% of the successful rate, and with the 9.7 plot to follow up. We conduct the midterm evaluation of NSP in the year 2021 and 2022. And despite significant challenge during the COVID-19, the Vietnam TB make progress, including the financing, transition TB first line drug under the social health insurance, screening, we pilot thing and early scale up, double it, active case finding and intensified case finding, and diagnostic and treatment. And for the health information system, we are facing the new VTMS for the health information system. However, we have a challenge is remaining is finding the old people with TB through the expanding the active case finding and intensified case finding, combined with the TPT for the priority risk group. It's require a lot of human resource and also a lot of the finance. Expanding new VTMAT implementation, and promoting free of charge for TB care for people without the health insurance cost. So we use the evidence-based document for the updating the NSP for the period 2024-2026 based on the result from the second national TB prevalence survey in Vietnam conducted in the year 2017-2018, and the result of the inventory study, TB costing survey, and relevant study, and also based on the time modeling and economic. For the TB cost survey in Vietnam, is the estimate that 63% of TB patients have a catastrophic cost. This is the cost for treatment and diagnosed TB cases is more than 20% of the annually family income. So for the NSP People Center framework for problem prioritization, we have 3 areas, which the red area is the major of concern, the orange is the area of intermediate concern, and the green is the area of no concern. For the people who are not accessing the health system, and for the people with TB who seeking care and not diagnosed and not notified, and for whom is diagnosed but not successfully treated, or treated but not notified. And you know that for the prevalence survey, 50% of people, person is a asymptomatic disease, not seeking healthcare, and I note in the prevalence survey. So this is the red line. For the goal of NSP 2024-2026 and the vision 2035, we follow by WHO guideline and the MTB target by the year 2035, 90% reduction of TB incident, 95% reduction of TB mortality, and zero TB affected family facing catastrophic cost due to TB by 2035. So the priority solution is we have an active case finding, intensify case finding with the routine activity, and expand double strategy for bigger scale AI application support in X-ray reading. So we apply both the CAT4TB and Cree AI. And the study AST3 in Kamau, after 4 years, the TB prevalence decreased 44% faster than in the control group. And if including TB impact, it will reduce by nearly 72% after 4 years of the community intervention. And the result of this activity have a public in the New Journal of Medicine, And we also organization for the diagnosis and treatment of the latent TB is for the study of the ACT4 is a feasible and effective of the TST in the community. And the solution number 4 is combining public-private mix to increase TB detection in the health facility outside TB network. And the solution 5 is enhance the effective of treatment, especially treatment of drug-resistant TB, organize drug-resistant TB treatment program in the community. So we also conduct the study of PPAN and PPAN-M with the support of the KNCV in Vietnam. In the last slide, we also doing the 12 benchmarks of the WHO in progress is for the 4 areas. The first area is identifying presumptive TB. Is a systematic screening of high-risk group, check X-ray for TB screening. And you can see here is the green color is the data who are available and easily to collect it. And the orange is the data were not available, but with minor effort could be collected. And we have a pilot collecting 12 benchmarks of the WHO in 3 big cities in Vietnam. And the second area is assessing the testing up-to-date diagnostic algorithm. What recommendation diagnose assess in the primary healthcare, diagnostic coverage reach on, and testing capacity match needed. And being tested is the monitoring quality testing all patients with presumptive TB tests with WHO recommendation diagnosis, universal DST provide. And we also, for the 4 areas, receiving a diagnosis is the all pulmonary TB patient have a WHO recommendation. uh, diagnosis result, and test positivity rate is monitored timely delivery of the results. So this is my quick overview of the TB activity in Vietnam. How to we trying to find the TB missing case. Thank you very much for the attention.
Thank you so much, Dr. Nguyen Bin Hoa. Very grateful and very sorry to keep you waiting for over 2 hours. So very grateful that you took time to share with us. Thanks a lot, sir. Thank you. So friends, just because there was some technical thing, so I just wanted to re-emphasize, underline what Dr. Hoa shared with us. He and his team in a place called Camua in Vietnam actively screened using X-ray and molecular tests everyone, not only those with symptoms, everyone. And the TB case rate came down by 72%. Dr. Hoa, please correct me if I'm wrong.
Yeah, it's correct.
Yes, thank you, sir. So 72% decline in TB rates because he screened all. And that is why I really wanted Dr. Hoa, requested him, appealed to him, please come and present to us, because it's a very important proof of concept. If we screen everyone with tools, not just verbal, with tools which we are seeing since morning, and provide them and link them to the continuum of care of treatment, the TB case, TB pandemic, TB rate can really dip, can really bend, and look at the kind of decline which he could achieve. When we began this meeting, I showed you a vision of our vision, of our government's vision, which was 10 to 15%. This is 72%. This is amazing. This is exactly what needs to happen. Many years ago, and of course, I was born in early 71, so that's a very old. But in those years, Australia and many rich nations had done active case finding with tools that which existed back then. So you can imagine what they basically screened everyone. They basically tested everyone and put them to treatment, etc. And TB rates declined to elimination level in rich nations like Australia. This is another one in Vietnam. This is exactly what we said. For 4 years, to 72% decline, with over 15% decline every single year.
Yeah, it's correct. Yeah, thank you.
Sir, what were the years? This study is available. I will share you the study link. All right, with everyone. Thank you, Dr. Hoa. Thank you so much again. And so sorry to keep you waiting. Thank you. Very good. Thank you.
Thank you. Bye-bye.
Really wish that Vietnam study spurs more action on these lines. Thank you.
Yeah. Thank you. Bye-bye.
Thank you, Doctor, and thank you, Bobby, for summarizing the presentation. So basically, we will proceed further. So this time there will be some good practice examples of reaching the unreached or difficult to reach. So sometimes we think that difficult to reach population means those who live in very remote areas or poor people, but working on the health issues, what I have found a different story in like few years back, in like on nutrition story and even the EPI vaccination, child vaccine coverage. What I have found that the children, who are in the richest quintile, they live in the apartment buildings in Dhaka. So the field workers of the EPI or the government's field worker, they cannot reach them. So sometimes it is also difficult to reach them also. So there are, I think with the good examples how to do when it comes to tuberculosis. So I think it will be, but what I heard that they are not here or online. You will present a video. Oh, okay. So. So now you present, Dr. Lalu, right? Okay. So now Dr. Daribianka Lalu, sorry for my pronunciation.
Oh, it's fine.
GM Molbio Diagnostics. Thank you.
Thank you, everybody. We were all going through so many, talks about, and also why we're all here. We are here as multi-sectoral, multi-stakeholders. Meeting together. I basically wanted to share with you an example of what we did in Meghalaya
just about a month ago. We got all sectors together in a meeting, and we decided that let's do a health camp together and see what these new diagnostics can do, and also what each partner brings to the table. And what was very, very wonderful was that everybody was full on. We didn't really have to prepare too much because everybody kind of knew what they were going to bring to the table. And so we decided how it all started was that we had a meeting, a planning meeting, where we selected which block would be the best place to focus on. We went through a lot of discussions, and then we also looked at the various healthcare indicators in this place. And it was selected with the government, with the Department of Health and other partners and NGO partners. Then we focused on this block mainly because it was a block that people still had a lot of traditional beliefs about health seeking. And also their, all their indicators was not going very well. So we had a whole round of discussion, and then we came up with who is going to do what. So we had NAGRIMS and then the Department of Health who sent their specialists. We had about 3 specialists, 3 types of specialists: medicine, ENT, obs and gynae, pediatrics. We also had general physicians. And what was very unique about this camp as well was because normally when you're doing a camp, you tend to focus on one disease. But what we decided to focus on was diagnostics. What we said was, we have a point of care diagnostic tool. Why don't we try it and get people, have same day detect and get treated at the same time? And it was very exciting. Believe me, in the discussion, everything was going very well. And then somebody pointed out, what about treatment? Let's say we detect somebody who has something which they cannot afford to treat. And then somebody stood up and said, oh, but we have the Meghalaya health insurance system. Let's link them to the health insurance. Then another idea popped up. Then another one said, but you need Aadhaar. So then we had Aadhaar linked in. Then somebody said, to open Aadhaar, you need a bank account. We looked in the bank. So we were a huge group of people at the end, of partners, all bringing in various services, including NGOs with counseling. We included adolescent health. We included antenatal checkups. We included immunization. We included nutrition support. There's an organization called NESFAS in Shillong, and they give nutrition support to patients. So the flow of the event was very, very interesting because we kind of used what would be the journey of a patient, right? From they enter, and how would they go consult a doctor? What is the next step? They would go get their diagnostics done. Then they would get their results. Then they get treated. And then now, of course, you found out that you're sick, you need counseling. So we then send them to the counselors. So we even had one kind of a booth for pre and post-test counseling, just in case we needed it. And then we had various counselings for various diseases. We linked everybody to the national programs, whether it was TB or whether it was, cancer screening, because we had a bunch of, diagnostics, which Sir has also mentioned. So we had taken along with us the ProRad Atlas, which was the ultra-portable X-ray. Along with that, we also had the TrueNat for confirmatory of various infectious diseases. We did not stop only at TB. We brought in parameters for many, many diseases that were prevalent in the area. We brought in dengue, chikungunya, malaria, influenza. I mean, whatever you need, we did it. So hepatitis and all of that. Then we also had thermolytics, which was from Niramai, the breast cancer thermal, for early cancer detection. We also got that in. And then we also had a portable ECG, which made, ECG testing for the general medicine who were there, the specialists, very easy. What was fantastic was that then we were all sitting there, and then the district administration told us, what will I bring to the table? And then the block development officer said, I am going to mobilize communities. He mobilized 780 people with the help of the self-help groups. He had meetings with SHGs, TB champions, I mean, you name it, every community worker, ASHA, A&M, everybody. We had meetings with everybody and mobilized people to come to this camp. It was a lot of effort by all of the partners, and also it was a good success for us. The main thing is, it was a very versatile camp, which demonstrated the importance of grounds up, synergistic, sector collaboration in bringing integrated healthcare. And this into the most needed communities in Meghalaya. And we did this in a day. So can you imagine what we would be doing if we all worked together constantly? It's fantastic. I also have a little video to show you on that, but I just wanted to say, you know, collaboration, working in tandem, keeping the patient in mind, and ensuring end-to-end healthcare service provision. It takes the strength of each partner to minimize challenges that we face when we are going about doing things in silo. This makes the patient experience a very holistic health and total well-being, experience for the patient. And so we have a video for you. Let's work together for a healthier tomorrow. Just a little video from the camp.
In the heart of Northeast, where the beauty of Meghalaya meets the spirit of humanity, something remarkable was about to unfold. A landmark collaboration between Molbio and several partners, driven by a noble cause, came together to make a difference in the lives of countless people. It was the first time that multiple sectors have united, forging a powerful alliance to organize a free, comprehensive healthcare camp. In just a short span of time, they conducted a health camp that broke all records. Thousands of people from all walks of life gathered, hoping for a chance at a healthier tomorrow. A record number of individuals were screened, bringing healthcare to those who need it the most. Early diagnosis is the key to fighting diseases like tuberculosis. This collaborative initiative successfully aimed at creating awareness and providing cost-effective diagnostics. Lives were changed, lives were saved. But it wasn't just about diagnostics. It was about caring for those in need. The health camp in Jayantia Hills was more than just a healthcare event. It was a testament to the incredible impact we can make when we come together with a noble cause. It was a powerful reminder that in unity we find strength. Molbio Diagnostics, pioneering healthcare solutions, one life at a time.
Thank you. Just a little bit about the data, because I forgot the data part. We had about 93 TB screenings. We used the X-ray. Out of the X-ray results, we had 5 presumptive TB that was, showed that could be TB. Then we did a TrueNat confirmatory for all of this, and we found 1 patient positive. Immediately, the patient was introduced to the program since they were right there with us, and the patient was put on treatment. This patient was then further sent for nutrition support advice. And besides TB, we also did a lot of breast cancer screening. Fortunately, it was a normal scan. We did a few other parameters of tests. We found 1 patient with GBS. We found 1 with hepatitis, another one with HLA. Another thing which was very interesting was the X-ray. Besides TB, we also did a little X-ray for limbs. There was a patient who came there who had a fall. He did not even know that he had a fracture. And since the X-ray was there, we said, okay, let's take an X-ray of your leg, and it was a total fracture. And then he said, oh, I didn't even know I had a fracture. And there's things like this that we are missing out and these are people who really need this. So, of course, everybody was referred to treatment, and and it was like a wonderful experience. Thank you so much.
I think, Bobby, next you will show the video. Okay, thank you.
So last year we had a partnership with USAID to work on TB active case finding. So we had this project with Fujifilm Ultra Portable X-ray and Molbio's TrueNat machine. So both of these technologies are called the Introducing New Tools project from USAID. And so last year, from September to October, we were able to screen 1,774 TB presumptive patients because we were able to bring this technology right to their doorstep. So how it works, if for the people that are not aware of this, the Fujifilm Ultra Portable X-ray is an X-ray machine that looks like a camera. And you can bring it anywhere and it doesn't need electricity. It can be charged and used with a battery pack. Same with the Molbio's TrueNat machine. It's a very small machine and you can use it to test the sputum of the patient with or without electricity. So we were able to go to the farthest flung areas here in Bantayan. So most of these people can't afford to travel to the mainland for treatment or for diagnostics. That's why we had this project, and we brought the tools and diagnosis to them. And we saw there was a very, very high increase in case detection and also case success treatment. So by bringing these technologies to the people were more open to getting tested and getting checked for tuberculosis. So here, Bobby, you can see how the machine is lugged around in a suitcase. It's like a plastic, that's the ultra portable X-ray. It's in like a plastic container / suitcase with wheels. So you can like take it anywhere with you. And the TrueNat is also in a similar setup for transportation. And as you can see here, it's out in an open field area. So the machines can be fit in a giant plastic container or a plastic tub. The same tubs that you can use to put things in when you store them. We had these giant tubs and then we brought them in our boats. So in the Philippines, we use what's called a pump boat. So it's kind of like a smaller catamaran that we use to travel from islet to islet. Yeah, so here's an example of us on the boat. This is from our Facebook page. So a little bit of shout out to my staff from Bantayan Rural Health Unit. You can add us on Facebook at facebook.com/bantayanhealth. So on the left is a picture of my staff and I commuting from the islet to another, from our island to another islet. So as you can see here, the weather conditions are pretty bad. It was actually raining and the waves were big. So we were wearing rain jackets and it was a bit cold. Believe it or not, it can get cold in the Philippines, especially if you're wet in the rain on a boat. And then so on the right, this was one of our last mission trips out in the field. And this was during one of the typhoons, Typhoon Paeng. We actually didn't know there was a storm signal raised until we were maybe around 4 p.m. because the place where we were at, Barangay Patao, did not have any signal. So we didn't know that there was a storm signal #1 and that everyone was pulled out and excused from work. Yeah, we were still working into the afternoon. So we couldn't stop rain or shine because the patients were there and actively waiting for us. So this is one of the challenges that we saw was the weather conditions. But you know what? It took a lot of teamwork and effort with my staff and with the barangay healthcare workers and the officials. New Tools project helped us detect TB. So we did this in September and October 2022. So as you can see in 2021, we only had 110 TB cases. That was because it was still the pandemic year. and people were afraid to go to the doctor or the hospital, and we were still a bit cautious about doing barangay missions because of the rampant increase in COVID cases in Cebu province. So back in 2022, we had a higher case detection rate because of the TrueNat and the ultra portable X-ray. And now in January to June 2023, we have 202 cases, but now in August, we have 254 TB cases now. So this next slide shows how the ultra portable X-ray and the TrueNat machine was very helpful in aiding us in the diagnosis of TB cases. So in 2022, we had 2,506 TB cases, and 1,774 of those were just from September to October 2022, using the TrueNat and the ultra portable chest X-ray. As you can see, bringing new tools to the barangays, to the people, can increase case detection by over 1,000%. This, I'm telling you, these tools are very, very crucial in eradicating tuberculosis. And for me, especially those of our GIDA or geographically isolated and disadvantaged areas, these tools can really help eradicate TB one barangay at a time. The message is to fully support technology and new tools for case detection and for active management of tuberculosis, because you have willing healthcare workers such as me and my team on the field who are willing to promote these tools for the eradication of TB, because unfortunately, I don't want to see another person die of TB. Just yesterday or 2 days ago, we had a patient living with HIV who also had tuberculosis pass away at the age of 24. And I don't want this happening anymore, because I want the people here to be resilient and to be successful in whatever that they do. But unfortunately, with these diseases of poverty, a lot of people don't seek help because of the stigma. And because the diagnostic tools are such a far-flung reach for them. So I hope that by bringing point-of-care testing to their doorstep, we can help eradicate tuberculosis one country at a time, or one barangay at a time. So that's my message for them.
Next message from Dr. Arvind Mathur, right? Yeah. So is that WHO representative from Timur Leste?
Detecting the TB cases and the diagnostics are very, very critical part of this whole ending TB strategy. The government's highest commitment within the National Action Plan for accelerating efforts for ending tuberculosis. And within that, one of the major areas that was identified was that what and how can we bring the diagnostics closer to the people. And that's how, like this idea of one-stop mobile van came, particularly also looking at the geographical difficulties, the terrain. We thought it was very important that we have a solution that can be quite comprehensive and is closer to the people. So the idea was that it's a van which is equipped with the TB screening facility, which actually consists of a digital X-ray unit, a two-lab platform, a connectivity to cloud services for accessing the artificial intelligence algorithm, and a telehealth system, along with the cloud electronic health records. This technology-driven approach and the lab actually have has been something where we could say that the TB screening, particularly with the X-ray and with the TrueNet, we have kind of seen an increased number because it is something people are saying, oh, this is coming to us, this is for us. It is also addressing somewhere that the stigma of accessing the health facility for this purpose. And I think that's where we can say that in a short span of time, it's around 7,000 individuals who have been screened like in a short span of time, with more than 600 people who have been identified, like for, like in terms of the presumptive for tuberculosis, and, like those who will be then put under the treatment or with the other approach that we are putting it up with other interventions. From the policy and political commitment to action on the ground is the way that lab on the wheels got actualized for the people of Timor-Leste. For this very reason, why this one-stop, lab on the wheel was put into place, and why this was considered that we are looking at it in a manner that it brings, like say, increase in the case detection, which we are seeing is already a 32% increase in the detection that has been observed. Because if you have digital X-ray with AI-enabled function, if you have TrueNet and you have Gene Expert network, it is possible for us to get towards a data that needs to be utilized for decision making. And that's where we are actually transitioning towards an integrated case-based electronic surveillance system. And it's not only for TB then, we are also looking into integrating with HIV and malaria as a first one, which is again a commitment that the country is making. I mean, the lab on wheels, not only for the tuberculosis program, but even otherwise, it's a very important, particularly in the arena when we're talking about, high threat pathogens and our ability to detect and diagnose them at the earliest level. At the time when we're talking about climate resilient systems, but the climate sensitive diseases and the related diagnostics that may need to be there. In relation to also the border areas, the land border, particularly countries which share the land borders, in such places and such situations, the lab on wheels could really play a very, very important role.
So thank you. I think with that, our session comes to an end. I would ask Lata to close the session. But before that, I would say it's a really great gathering, and I will request Bobby and Shobha to keep this network, because end of the day, this will help us to write stories, because for writing this kind of stories, we need a lot of examples, not a lot of new knowledge of experts. So if we have this network, then I will, from Dhaka, I will get to know what is happening in Goa or in Pune or in Delhi, so in Kathmandu. So that will also help me to tell my readers, my policymakers, that okay, you would do it. Because end of the day, this region, what I said in the beginning, so we are South Asia, we're kind of common people, common problems, common strength. So let's do it together. Thank you.
As Hasid mentioned, I think thank you so much for inviting us here, Shobha ma'am and Bobby. We know each other since long time, but yeah, I think we're meeting for after a long time only. So yeah, I think only thing you say, I was just feeling that my Mumbai TB officials were not here. I mean, is there something like that you guys are just wondering, because I think Mumbai is the largest, having the TB tuberculosis population in Bombay. In terms of numbers, there are more than 6,000 MDR, 40,000 TB patients only in Bombay. So why does it TB, nobody's representing Bombay here. So is there some reason, or what is it? Like just I'm curious about it, nothing else. Would you like to answer?
No, there is no reason behind this. We really wanted that everyone should come, but we did spread the word and stuff. But let's hope that the next meeting is happening in Mumbai and we get to learn more about Mumbai issues. So this year we really tried to get the CTD, but we didn't hear back much. Also because there are meetings happening, that's the response we got in Delhi. And we invited Goa STO, especially because we all know the reason. We wanted to hear the journey of Goa, and how they have replaced microscopy with 100% molecular use, and what are the lessons learned and stuff, which Dr. Manish Gonekar did it so ably. And so yes, we look forward to the next summit in Mumbai.
Next conference, we can take it in Bombay, and, and we can showcase all these, hospitals in Bombay, how they're working, how BMC is working. That would be a great experience for the other journalists who are here, and it will be nice to. So thank you so much again. You please.
No, thank you very much. And please take that forward of our coming to Mumbai, Lata. Thank you. And thank you, chairs. Thank you. Yes, please. We now move on to our next session on Find All TB, and this will be a panel discussion. So I once again invite Pramod Bambal and Maitri Porecha, who's Senior Assistant Editor, The Hindu, to chair this session. And let us keep it small and beautiful. I love that book. If many of you must have read it. Small is beautiful. That's by a German author based on Gandhian philosophy. Thank you. No, yes.
We'd like to call on stage Selena Menzies, who's the Global Alliance for Human Rights, who works with the GAHR, Archana Oinam, who works with GCTA, Daksha Patel for TBpeople India, Subrat Mohanty, who's a Senior Advisor and Project Lead Allies, Reach India, and Sumit Mitra, the President of Molbio Diagnostics. So we will set a brief context here. Our agenda for today is how to stop missing TB cases. And every year when the TB India report and the WHO report are released, we have a very favorite tagline that we go with, and that's what we lead with, that 1 million missing cases or cases are, sort of falling through the cracks. And honestly, I'm tired of writing that lead, and I'm tired of, sort of that tagline anymore now. To start with, anyone on the panel can volunteer to take this question, is about the screening, right? So if anyone who represents a patient community can tell us why screening is challenging in the community, that would sort of set the context here. Would Selena want to go first?
Can you repeat the question again?
So in the cascade of care that we look at TB, we first look at screening or kind of going into the community and finding the patients. Then comes the detection part of it. And after that is the treatment, the follow-up, the access to drugs, including nutrition, which includes DBT, giving money or food packets, preventing relapse. And then there are allied issues of infrastructure, staff shortages. So if we set the context like this of TB care, the cascade of care, the first important part would be screening. So what are the challenges, when the people who work with TB, especially in the government, the NGOs, they go in on the field in order to convince people to get screened, or the health workers, and what are the challenges from the patient communities?
Yeah, from the patient perspective, the challenges for screening, what we feel is that everybody who we are missing on, I think, our stakeholders, like everybody should be involved in the community. Like some people go for tea, so tea shops we should be stakeholding. Some people have pan shops to hang on to. So pan shop fellows could be one of the stakeholder in getting screened. Then it comes to pediatric TB, like school teachers, already Anganwadis, all those. I think if we think about one person as stakeholder and missing other stakeholders, I think that is very important in getting screening so that we don't have cases missed out. And many times what happens, the asymptomatic people come only with symptomatic, that is pulmonary most of the time, or when the glands or something appears. Otherwise, other cases are being missed out.
Excellent. Thanks for that, Selena. Maybe the next question, if maybe Sumit, if you can take this on detection, and again, we've heard today of all the new tools and technologies that can be used. What are your thoughts around detection?
It's okay. So I'll start off with what Maitri just mentioned, something that she's been tired of writing for over a long time, in terms of the millions that's getting missed. So you'll be happy to know that there is already a global coalition that's named Driving to Find the Missing Millions. And in the past few sessions, we've seen the ideation of the testing modalities getting deployed on a vehicle of several sizes. And globally, this is being done, and Molbio is the partner, where Toyota provides Land Cruiser, and these are being deployed across countries. Cameroon is the first one. Nigeria, Bangladesh are soon going to follow. So that's one part, that there are interventions, and this is being recognized globally. And everybody is kind of sitting up, taking note, and implementing whatever needs to be done to kind of go deep into countries, to the extreme interiors, and find cases among communities. Coming back to your question in terms of the diagnostics, I think we've seen right through the day in terms of the new tools that are already existing. Of course, as Mr. Shriram has also pointed out, TrueNat, though being the flagship product of our company, we are not restricting our resource allocation to TrueNat and TrueNat alone. So there are other areas like the antibody test, which is going to be a very simple rapid test, the one with the cuff signature, and as Selena just mentioned. So just imagine the areas where the cuff signature intervention could be used. Any place that has got a lot of people, say a school, a college, a university, a marketplace, could actually set up a kiosk with that small adaptation of the microphone. And all you need, and this is not going to be a big deal for today's generation, everybody has a smartphone. All you need is the app on your smartphone. So you don't have to be coaxed, or you don't have to be kind of prodded to go and cuff. So if you're having any kind of feeling within yourself, you just go and cuff into the microphone, and within a couple of minutes, the results back on your microphone saying, see, you could have this, or you could have that.
Just as a quick follow-up, Sumit, and then we'll move on to the next panelists. But I want to press upon the challenges that emerge, in modicums like CBNAT and TrueNat. Especially, I'd like to bring some statistics forward here. 11 out of 15 cities, and this is an internal Ministry of Health presentation, lacked CBNAT cartridges on the field. And I would have loved to show a chart out there, but we'll do that later. I can share a screen grab. In 11 or 15 of these cities, there was 0 cartridges available on the field because of raw material procurement challenges that the government faces, at the field. Now, when it comes, but those cities did have TrueNat machines. They were all diverted for COVID at that time. However, what I'm trying to press upon is that the TB patients were not getting access either to CBNAT or to TrueNat. And sometimes, due to a lot of manual interventions in your machines, the people who are using it on field complain that there is a lot of manual intervention there. Sometimes the error rates would be high. And sometimes the temperature control is not 30 degrees. So in primary healthcare centers, where sometimes, you don't have electricity, you do not have enough cold storage facilities for vaccines, here now you have to maintain a 30-degree temperature, which is not even, like, I don't even know how, would you refrigerate? So then how do you deal with all these challenges in terms of rollout? Because yesterday you said that there are 1,700 machines with the center and 2,800, and sky's the limit. There are 14,000 microscopy centers. So it's like an 8 times or a 9 times growth. But now you're also foraying into other assays, because do you think that the scope for TrueNat, therefore, for your company is then limited? And how does that impact detection?
So if I got you correct, there are two points in your question. One is the part on the unavailability of stocks. I would wonder if what you had in mind or what you wanted to project was figures from the pandemic times, because that was a time where many a company, including us, did not have the sanction, if I can use that word, to kind of export, or the others to kind of bring into our country. But if India is the context, then I would say for TrueNat installations across the country, stock out has not been a problem. There have been adequate stocks. Maybe, as many has said, that we are such a huge geography and such a diverse team that goes into procurement and stuff like that. So there could have been a few bottlenecks here and there, but by and large, there have been supplies that's gone on. So that's the first part. In terms of the second part, which is kind of more technical, yes, you're very correct. We do claim, and we are probably the only company that claims a room temperature stable assay, which is good. We claim up to 30, but it's good up to plus minus 3 or 4 degrees. But anything beyond that, there would be a kind of a issue with the shelf life. It will still work. So the question is, how do you circumvent having understood what the things from the company are, and then ensure that you kind of end using up everything and without wasting anything off the shelf. So one way forward would be, as and when the Central TB division buys, they buy in terms of millions of tests. You can actually skew the supply chain. You don't supply all at the same time. But for that, of course, a little background work needs to be done as to what is the requirement for across all the provinces or the number of installations that there are. Figure out what their requirements over a 2 or a 3 month period would be, so that you could have a supply, an order which has come in one point of time, but staggered supplies over, say, every quarter. So that will, in a large way, kind of mitigate whatever you are saying. But at the same time, TrueNat now not limited to the country. We've gone across many, many countries, and conditions are very, very similar in those countries. Worst case scenario is that just in case you do have temperatures which are kind of exceeding 30 degrees, you have a small room refrigerator which can take care of most of your issues. So that's the only thing probably you require, nothing else.
What is storage?
So that's about it. So just in case the temperature kind of shoots beyond and it continues to remain as such for over a period of time, all you require is a regular refrigerator.
I think supply chain is a big issue, and it is something that we really need to find some very good solutions, because there's no reason why we shouldn't. It's right, exactly. No, that all forms part of the supply chain. But maybe, Arjun, if I can ask you, the basic question, and I think that what this whole session is about, find all TB. So from the community perspective, what do you feel are the important steps that we need to find all? And I think the emphasis here is all. How do we find all TB?
When we are talking about, there are lots of documents available by the Global Fund and by other donors on how to find the missing millions and what are the guidelines, what are the strategies and all. So I was just thinking that it reminds me of that program at Doordarshan, it used to come, you know, that Gumshuda Vyakti. And then as a child, I used to feel very bad, like, oh God, he has been missing for such a long time and the family members must be worried and all. But now, but what I'm trying to say here is that these are not the missing people. I think we should also look at what have we created? You know, what is it? Why is it that we are not able to find the people? What is the problem behind it? You know, one of the things which has come up in many of the discussion earlier is the stigma and discrimination. Stigma and discrimination is one big factor that people are not coming out. Or what is the reason behind it? Another is that maybe there is no availability of treatment, or even if the treatments are there, the accessibility is very low. I mean, from research point of view, I'm just talking about the 3 A's and the quality that we need to look at it. So I will come back to the point which I said in the morning, like, you know, we cannot work in just one vertical way. Like we need to work all together, and we need to find and we need to invest in the community. I mean, you know, we might be having the best state-of-art facilities, but if people are not coming out and if people are not accessing the services, what's the use of the services? So let's invest in the communities, and then let's build up the awareness, and then people will come out on their own. We don't have to go out and say, you know, these people are missing. I mean, it's like we just have to create the ambience. We just have to create the environment enables for people to come out. I think these are some of the issues that, I mean, I'll just come from community perspective. And as I said in the morning also, that we just need to do what we have done with the HIV movement, with the harm reduction movement. You know, we just have to invest in the community, empower the community. And obviously they will demand for such programs, and it will be like, you know, we need it. The stockhouse shouldn't be there. We should have the best of, you know, testing facility. Like COVID, you could have the test done at home. Why can't we do it in TV? Yeah, you know, there should be that we should build a demand from the community. And I would just say that from community perspective, I think we all need to work together and please involve in the community, and most of the questions will be answered.
I'll just pose one question to Daksha, and then we'll move on to Subrat. My question to Daksha is on nutrition. Now, you know, we've often wondered what is the best way to provide food to TB patients. You know, how do we ensure that not only do they get food, but that they, you know, it doesn't get sort of diverted in their family, or that, you know, how is it ensured that, you know, we put it on their plates and make sure that they eat it, right? And there are a couple of models that were tried. And one was a direct benefit transfer model with 500 rupees. And, you know, it was all clubbed, you know, so it was a monthly sort of an incentive until they completed treatment, right? And then what we started realizing is that these DBT payments were getting super delayed. So, you know, I met patients in Samastipur in Bihar, where there were two neighbors. One was an old lady and one was a young laborer. Young laborer got his DBT payment in his account, but that was also delayed by some 6-7 months. And the poor old widow had still not gotten her DBT, and she just had one cow in the family. They were all women in the family. There were no men. And the young children needed milk. So the elderly affected by TB, she was getting affected, right? So after DBT, the new thing that the Prime Minister announced in Varanasi was that aap adopt karo, aap Nikshay Mitra ban jao. Matlab, you know, today, say Bobby can just adopt 10 TB patients, and then Bobby has to make sure from his pocket that they get the nutrition. And then I can adopt 2, but then I can give 1 kilo of dal and Bobby can give 5 kilo of dal. You know, how do we fix any sort of accountability? This is not scientific in, you know, my opinion, right? So that is a Poshan Mitra, it was a Nikshay Poshan Mitra Yojana that started, which doesn't put any accountability on the government. And in the middle, there are all these other malnutrition tackling schemes like midday meal and all, which are more generic in nature. They're not targeted at TB. So I want to know from you what patients are thinking, because you work with people and community, on how should we put food on the plates of TB patients.
First off, just think all of us, 500 रुपए में हम क्या purchase कर सकते हैं? That is a basic question, because I will manage my travel. I will manage my other cost to reach the setup. or I will manage my nutrition food. So this scheme 500, when I understood and I came in a world of this HIV, and when I understood TB, so from that I seen that nothing is changed. But our health budget is not also increasing. It is GDP, everything we will see, it is on different way. तो अभी जब हम पेशेंट पर्सपेक्टिव से बात करते हैं तो फर्स्ट द थिंग इज हाउ मेनी कम्युनिटी मेंबर आर गेटिंग काउंसलिंग अबाउट द न्यूट्रिशन, बिकॉज बेस्ट पार्ट इज कि हमारे घर में जो भी है उसी में से हम कैसे गेन कर सकते हैं हमारे प्रोटीन और जो मैनेज विथ टीबी मेडिसिन. सेकेंडली अबाउट द गवर्नमेंट, मतलब पासिंग बॉल दैट इज नॉट सॉल्यूशन कि मेरी स्कीम 500 रुपए में है, आप निश्चय मित्र बन जाओ. बट हाउ यू विल मेक अकाउंटेबिलिटी ऑफ द डोनर, क्योंकि व्हेन वी आर इन अ फील्ड, आई पर्सनली टेलिंग यू, वन ऑफ द डायमंड मर्चेंट, जब उनको डील हुआ, उनका बिजनेस कुछ अप हुआ या फिर उनका बर्थडे हुआ, तो वो 10-20 ऐसे कम्युनिटी मेंबर जो टीबी पॉजिटिव है उनको न्यूट्रिशन किट दे दी. But I want ration for my till I am on treatment. Secondly, who are the providing nutrition? They doesn't know that which nutrition is important when I am on TB treatment, right? तो मुझे अगर X, मतलब मुझे प्रोटीन वाला जो चाहिए पैकेट, तो that person may be making like making different because they are comparing cost and big packet. So this is the difference of the thing. That's why now I'm coming on my all colleague what they discussed before. We need a differentiate care and service package and treatment package for different people. Like if I'm talking about widow, child, aging, so this package of service must be different. And secondly, this is the reason we want community member, not as only health champion or community champion, but we have to build their CBOs, community-based organization, to develop their voice, to mobilize resource, to make and design the program, demand their program, and even not only like what you think, like you are using community member, or sorry, it's utilizing community expertise in only sputum collection. They are expert more than it. You invest in community, not only like calling in one AC room and build their capacity, but without resource, person how will make advocacy to make this policy change? Who gone to this Prime Minister office? How many letters sent by community member? So that is one question. When in Varanasi, there is a big platform of the TB community. Where was Indian community TB member was on that stage? No one. So how like other, we are respecting to international fairs also, but we are missing. So find us first. Find us first. So this is the thing. It's not about nutrition only, but the overall service package. We want community CBO needs to be developed. HIV learning, COVID learning in TB program. If you see see the Global Fund investment, even other PEPFAR investment in HIV program, if you will see the investment in community networks, CBOs, if I will compare with TB, I'm I'm not comfortable to share that data, because unless it will not make change. And lastly, I want to share one more thing about testing. Testing, there is so many things is happening, but again, demand about like HIV positive who are the community member. हमें पता है कि एक TB लैम्प टेस्ट है, which is very easy, accessible, and मतलब उसको immediate हम लोग diagnose कर सकते हैं. But there are WHO accept किया है और वो qualified है, लेकिन फिर भी आज भी country में उसके ऊपर research चल रहा है because demand is not there. So this is my conclusion that including nutrition is very much important, but we need to advocate this policy and we have to make Prime Minister accountable.
Thank you for that, Doctor. Yes, I think there are areas that we
add on community when we are talking about when we are talking about community knowing about their TB status, I feel that fear from the community has to be gone, because the moment if somebody goes for TB test, I don't want to go to the local TB center, because once they come to know my status will be known to everyone, I will be getting discriminated. Oh, then what if someone comes to know at my workplace? There are lots of issues. So that fear has to be removed, and then the diagnostic as well as treatment centers should be patient friendly, where it is confidential, counseling should be given properly. How many people who are having TB knows that urine will be red after rifampicin? So for the little things, community is not aware the treatment, how long the treatment will be, what if I find some problems within the treatment, who to talk about, all that thing.
No, absolutely. Thank you, Selina. So I think we'll have one last question over here. Subrat, you've been working in tuberculosis now for over 20 years. And I just want to hear from you. You see, I mean, we know that there are challenges at every stage, right? From screening to all the way to adherence. But if we were to look at some of the challenges that we have around adherence and completing treatment, what do you think are some of the big challenges there, and how do you feel we should be addressing that?
Thanks, Prabodh, for this very interesting question. And before I start my answer, I also would like to say a few words on the missing number. See, Prabodh, the missing one, you divide into 3 stages. One is that people who are not coming from the community for the diagnosis. One. Second, the people who are also going to the private sector, which are not notifying to the niche. And third one are the people who are coming for the diagnosis, getting diagnosed, and then moving out. We do not have any data. So these are the scenario when I'm talking about the missing number. Okay, going back to your point. So what is happening now, Prabodh? I think as a TB program, and you said I've been in TB program for 20 years, I've been part of the Stop TB board and everywhere. The India TB program is doing well. And when I say the community engagement in last 5-6 years, it has been really phenomenal. I mean, now not even a single meetings are happening without somebody from the NTP or a district level NTP are there. The challenges and issues are probably basically one, I say the knowledge level. We presume that in the community, the people having the knowledge about TB, but it's not the fact. Second is the awareness. There's so much of awareness happening in the field, but that also not translating into action. And when I say action, it's a behavioral change. So what we have to do is a question of diagnosis to the care cascade of treatment and everything in the adherence. There has to be kind of a massive kind of mobilization in the community. And here comes the role of the TB champions. They are the frontliner now. You cannot bank upon ASA, Anganwadi, or Mitans now. There are thousands of TB champions available in the community. They need to be really roped in and ask them to do the work. Issue on adherence, Prabhu. You asked the question of adherence. I take medicine 2 months. I feel much better. Rifampicin, you start 10 days, complete it, your weight will be gained. And when you are working in factories, with anywhere, you tend to go back and tend to forget completing the or going for the continuation phase. Follow-up is something is not happening on a regular basis. Follow-up in point of the program or community, it's not happening. After the second 2 months of treatment, they are supposed to be follow-up to test the sputum. It's not happening. But they don't know whether they are in negative or they are still continuing the program. And then they tend to forget taking medicine also, and nobody is supporting in the field. So there are number of issues around of your livelihood, and look at other dimensions. People are, today morning I have been listening about that technology and many other areas. We are not talking about TB and beyond TB. Are you talking about TB and disability? Are you talking about TB and comorbidities? TB and diabetic? Different kind of care not happening. So there are many things now around TB. Livelihood, beyond TB, what is that family? Is 500 rupees you talked about? Is a small thing for one person in a family of 4. Who is taking that? Is that male? Is a female? Is that person? We don't know. So there are so many issues, Pramod, around which I feel now the challenge is, okay, of course, the diagnosis tool, everything has to be improved, and we have in the country, there are enough of things happening around the diagnosis tool, improving. But beyond it also, we have to go and look at the other things. Thank you so much.
There has to be the continuum of care. I mean, suppose I got tested over there, the doctor has prescribed, but I need to be linked up with my support system, with my peer group, in order to, because I don't know a bit about it. I may do Google search or I may ask around. And because of stigma and discrimination, I may not have the courage to go out and ask people or to find out. So all this thing needs to be considered, and then I need to be linked up. I mean, this is what we have been talking about, the TB champions, the role of TB champions, where they come in. So we need to be linked up. There has to be a link continuum. Okay, it's not just the 2 months or the 1 month, but it has to be linked up so that then we can talk about the household contacts and other things and all. So it's just not one approach, but it has to be a continual care that the person is being brought into.
I'll just add, yeah, please, Daksha.
Just I want to add 2 points here. One is about the we have to build a community champion capacity for treatment preparedness and treatment adherence. And
I'll just add one thing here, that community champions, correct me if I'm wrong, are not given any incentives and they are not paid.
Yeah.
So will they work for free is the question. And, they are like ASHA workers, or for instance, how do they, what is their situation, right?
So that's why I'm saying we have to mobilize community members and build their capacity with budgetary provision. It's not क्योंकि आप भी कितना free में media में ये,
because that's exactly what is happening right now.
I would like to answer your question in a different way. The program, what is the program saying now? In each of the health and wellness center, there will be 2 TB champions, 1 male and 1 female, right? So within the 500 population, there are 2 TB community members, and they will be incentivized based on the activities they perform. And the program, the district and state TB program, they have to put that budget in the PIP. And then the money comes. That is happening in few places. In Jharkhand, in Odisha, in Chhattisgarh, they are getting some incentive.
I just want to open up the floor for any thoughts, questions, advice, guidance, anything that's coming to your minds right now, because this got a highly charged conversation. Yes, Mint.
So, other mic. turn that on.
हाँ वो तो है ही हाँ ओके नहीं बॉम्बे में आई रिमेम्बर दैट वंस व्हेन आई वेंट देयर एंड दे वर सेड कि आप अपना खाली पैकेट दिखाएंगे तभी आपको 500 रुपए मिलेगा तो so which is not everywhere of course but the thing is that it's a very most of TB treatment is I was discussing with it's like आपने अगर अपना ट्रीटमेंट ठीक से लिया आपने मतलब सहा सब कुछ तभी आपको अच्छा ट्रीटमेंट मिलेगा नहीं तो आप मतलब बिल्कुल यू आर इट्स अ आप स्टिग्मा की बात कर रहे हो ये जो स्टिग्मा है ये उससे भी बुरा स्टिग्मा है मेरे हिसाब से दैट व्हेन यू डू नॉट टेक योर ट्रीटमेंट फॉर whatever reasons that the stigma of not completing your treatment is sometimes even bigger than even contracting TB because then in your entire it's if you will not from the programmatic level but at the level of your PHC and your dots provider or everyone you're shunned. So like what are we doing about that and even in our champions or nobody talks about this कि मैंने अपना दवाई खत्म नहीं किया तो फिर अभी मेरा nobody everybody is perfect है ना तो उसका हम क्या करेंगे like what do we do about that where why is this perfection expected of TB patients whereas if you are a BP patient you can skip your treatment if you are like उसमें कोई I understand कि scientifically you have to finish your treatment there is no doubt about it.
So funnily actually like there is a story that I just want to recall here and it is about using technology for adherence. So गाँव में क्या हुआ कि एक TB पेशेंट एक लेडी थी उनको एक पत्ती दे दी और उसके पीछे लिखा डे 1 डे 2 डे 3 डे 4 डे 5 पे लिखा कि कॉल करके आप हमको अडियर करो. अब वो बेचारी उसको एक तो नंबर पढ़ना नहीं आता था दूसरा 99 डॉट्स दूसरा हुआ फोन पति ले गया तो the poor woman couldn't call. So we're like, ठीक है चलो और एक alternative technology field पे क्या try हो रही है? What is getting tested? So it was basically like a chip that was fixed in the medicine box. That was the second pilot. And every time the medicine box would get opened, the chip would say patient ने दवा ले ली. But तो बच्चा भी open कर सकता है ना उसका. तो ये सब अभी field पे test हो रहा है, but nothing is like foolproof in terms of tech adherence.
Yeah, no, I think when it comes to adherence, and we need to use technology, and we want to use technology more and more. But I think we also need to think how to use people more and more. And
going to the houses, either calling that on the phone or even So, there are studies which are going on, behavioral studies, counseling studies to find out whether actually people are taking. So they're doing their follow-up calls. They're actually going and visiting homes. So it's all at the study level. So, how far this is impactful then goes back to the, ICMR for programmatic implementation.
Okay, we have just, right. All right, Ramya, and then we have Nivas Patik, who's a TB survivor from Goa. And we would like to hear from him. But Ramya, please. And if you can use the mic.
Sorry, just a short comment. And it's just funny that we were talking about this because in my understanding, TB is the only disease that had a DOTS provider. A provider that went home to deliver the drugs to. So, I mean, it's just ironic that, आज we are sitting here and discussing compliance because, it was the only disease. It continues to be the only disease that had a supervisory model.
Sometimes the same DOTS provider is doing 6 tasks.
No. Given, but just pointing out the irony, that's all.
Yeah, no, and the fact remains that and that happened in many places, especially here in India, where we have very good policies and very good things written down on paper, but execution is where the problem is, right? We are
now it's a family duty.
Yeah.
So a family member can also be the
the
supervisor for that person.
Yeah.
So
yeah. Okay. So let's have Mr. Navas speak first, And then we'll come to this next question.
सबको मेरा प्रणाम। मेरा नाम निवास पाटिल, मैं लाइफलाइन फाउंडेशन बोल के संस्था है गोवा में माइग्रेंट वर्कर के लिए काम करती है। उसमें जो नॉर्थ गोवा का प्रोजेक्ट है माइग्रेंट के लिए काम करता है, उसमें मैं प्रोग्राम मैनेजर बोल के गए 5 साल से काम कर रहा हूँ। उसमें भी मैं एज ए टीबी चैंपियन डायरेक्ट हेल्थ सर्विसेज पंजिम उनके साथ जुड़ा हूँ गए थोड़े महीनों से। और मैंने यहाँ में गोवा में जब मुझे टीबी हुआ, यानी कि मैं महाराष्ट्र कोल्हापुर नेटिव प्लेस मेरा, मैं यहाँ पर 15 साल से रह रहा हूँ। मुझे 2007 में महाराष्ट्र में कोल्हापुर में टीबी हुआ था। फर्स्ट लाइन पहले शुरू किया था कैट 1, लेकिन तभी कुछ अवेयरनेस नहीं था, डर बहुत था समाज में। तो मैंने वो 3 महीने बाहर से खरीद कर दवा लिया और छोड़ दी मैंने। मेरे पिताजी भी गुजर गए थे, घर में सपोर्ट किसी का नहीं था। जब से गोवा में आया 2009 का और 10 को मेरे को डिटेक्ट हुआ, फिर से चेस्ट में पेन हुआ, टीबी हुआ है। तो मैंने तभी दवा स्ट्रेप्टोमाइसिन के 24 इंजेक्शन और बाकी के 8 महीने की दवा पूरी की ठीक तरह से। साकली का जो स्टाफ था हॉस्पिटल का, ब्रदर्स वगैरह, उन्होंने बहुत अच्छी तरीके से इंजेक्शन देते समय उनकी भाषा, जो प्यार भरा उनका जो संबंध था हमारे साथ, यानी कि मुझे नहीं लगता था कि वो मैं वहां पर पेशेंट बोल के गया हूँ। यानी कि मैं मेरा रिश्ता समझता हूँ उनके साथ। ब्रदर कैसे हो ऐसा पूछता था, वो बोलते थे अरे तू कैसे है ऐसे बोल। यानी कि मेरे को घर के जैसा लगा। यानी कि गोवा की हेल्थ फैसिलिटी बहुत अच्छी है, मुझे बहुत अच्छा सेवा मिला। और मैं अभी एक काम कर रहा हूँ। पहले मैं 10 साल गोवा में आया तभी फीमेल सेक्स वर्कर का प्रोजेक्ट था। बिचुली सत्तरियान पार्ट ऑफ पोंडा तिसवाड़ी और बारदेश, इस एरिया में जो सेक्स वर्कर काम करती है उनको HIV एड्स के बारे में जानकारी देना मेरा काम था। वहां से अभी मैं प्रोग्राम मैनेजर बन गया 5 साल। तो वहां पर मैं एज ए डॉट्स प्रोवाइडर बोल के काम किया मैंने। ठीक होने के बाद मुझे भी अच्छा लगने लगा। किसी की दुआ पाना भी बहुत जरूरी है, क्योंकि हमेशा हमारा हाथ ऐसा रहता है, कभी भी हम देने की भी दानत रखेंगे। और ये भगवान ने दिया है समाज सेवा करने का मौका, मैं उसको गवाता नहीं कभी। और अभी यहाँ पर मेरे काम के शेड्यूल के हिसाब से मैं प्रोग्राम मैनेजर हूँ, तो मुझे बहुत सारा घूमना पड़ता है। सब कंस्ट्रक्शन साइट, मच्छी पकड़ने वाले, रेती निकालने वाले, हर एक टाइप का कस्टमर, होटल वर्कर, माइग्रेंट वर्कर ओनली। तो मैं करता क्या हूँ, अभी मैंने इनके साथ DHS के साथ जुड़कर टीबी डिपार्टमेंट, मनीष गावनेकर सर आए थे, टीबी स्टेट ऑफिसर, उनके साथ मिलकर मैंने अभी जो मेरा HIV सेक्सुअली ट्रांसमिटेड इन्फेक्शन गुप्त रोग के बारे में जानकारी देने जाता हूँ। मेरे स्टाफ को लेकर मैं भी वहां पर टीबी के बारे में जानकारी देता हूँ। जितना हो सके उतना एक टीबी के उसमें मैं एक मेरा रोल अदा कर सकूं, ताकि मेरी इच्छा है कि मेरे को टीबी हुआ, मैंने वो फेस किया, ताकि और किसी को टीबी ना हो, और 2025 तक जो हमने विजन रखा है वहां तक हम पहुंच पाए। सभी को और एक बार प्रणाम, और जिन्होंने प्रोग्राम अरेंज किया उनको भी मेरा हृदय से धन्यवाद।
Thank you, Nawalji. I think in the interest of time, I know that there are a lot more questions. We can sit here and debate and you know, look at the various challenges and how we're going to address them. But in the interest of time, I think if fine with you, Maitri, we can bring this session to a close.
We've had a very good discussion. Just wanted to involve the audience here a bit. Wanted to ask them a few questions if you are up for it. Are you okay? Okay, there are 2 more. Got it. Okay, so we'll do this little thing later informally. It's fine.
Many things are happening now, and I try to fix in the community that let's all try to make sure that healing is part of the program. So many things are happening, but community-led point. Yeah. Over to the chair.
We'll move to the next thing.
Yeah. Thank you, chairs, and thank you, the panelists. And this can go on forever, but thank you for keeping it small and beautiful once again. I now invite Kalpana Acharya, Editor-in-Chief, Health TV Online Nepal, and she has also been former President of Health Journalists Forum, Nepal, to chair the session, An Idea Can Save Lives. I will be just sitting behind her, and she'll take the lead.
So good afternoon, everyone. This is me, Kalpana, health journalist from Nepal. And basically, my station is in Kathmandu. I hope you have visited in Kathmandu. First of all, I would like to thank Sobha Madam, Bobby, Molbio Company, and other organizers for inviting me in this August gathering. Personally, I learned so many new things sitting in this session. So thank you so much for this wonderful opportunity. Our session's theme is an idea can change lives. How an idea can change the lives, we will discuss on that. Yes, ideas have the power and they can change the world. We will discuss on that. For this discussion, we have Mr. Chandrasekhar Nair, co-founder of Molbio Diagnostics. I would like to call upon Mr. Chandrasekhar Nair.
And so we would like to hear from you, from ideation to product development, to validation, to the rollout in India and abroad. It must have been a long and arduous journey. We are enjoying the benefits of the end product, but how did you come up to that level?
Thank you, Chairs. It's a pleasure to be standing here and talking about our journey today. It's been a very interesting journey. Let me start by talking about the impact. Can I have the next slide, please? And I can't read that at all. So it doesn't matter. So I think the impact is, I should know this, isn't it? So today we have the TrueNat platform that can detect more than 40 diseases, 40 pathogens on our platform. And for a molecular test at point of care, to be able to do so many different tests on our platform is exactly what was discussed earlier in the day in terms of the need of molecular tests that can do that. I think there is an echo. Yeah. Yeah, it's okay. So technologically, when we started off with this idea, we wanted to do NAT at point of care. And why NAT at point of care, you know? See, I'm an engineer by training. And this very beautiful technique that PCR is about, which has extremely high sensitivity and extremely high specificity, is not usually found in the real world. Sensitivity and specificity are like two parts of a balance, and ultimately you come with a balance, isn't it? But this is one of those anomalies of science. Very beautiful sensitivity, excellent specificity. And we wondered why a technique like this was not available. And I'm talking about the early 2000s, you know. Before that, I was a bench researcher doing tons of PCR, and it was very interesting. But the fact that such a technique was not available to us in the clinic was something that troubled us. And when we started this company, that is something that we set out to do. It was an interesting thought process. But today, we have this very satisfying position of having translated that dream into a product. We've done that with a lot of different skills, a lot of different experiences, a lot of different strengths. The strength to take what is essentially a biological technique, build an engineering platform around that, and take it through the various stages of product development, but not just product development, but into translation. The ability to translate this at scale is a very different different and less known technique, I should say. And that is the reason why we don't see too many products in the market from India. We saw a list of products for TB earlier today. We saw only one product from India. And that is because I think as a community, we require to still learn how to do this translation and do this translation effectively. Our goals are not to stop here. Our goals are to go far beyond. Our goals are to understand the clinical need gaps that are required at primary care. You heard from Sriram earlier and Sumit earlier that we're working on a bunch of different technologies. I would like to touch upon some of those. But if you go to the next slide, we started in the year 2000 with this idea. And it took us 5 years before we could actually show something. Show a device, show a chip. Because till then, we did not know how to even fund ourselves. We were a bunch of engineers who were generating some revenue from software and who thought that we could push this internally as a product development story. It took us 5 years to do that. Why did it take us so long? Today, if you look at it, during COVID, you saw so many different people thinking of so many different techniques of nucleic acid amplification. Let me remind you, this was year 2000, very, very early days. And this was technology that was inspired by a technique called microelectromechanical systems. It was at its infancy at that point in time. We were able to show this to CSIR's New Millennium India Technology Leadership Initiative program. And they finally were the first government agency to give us a soft loan. There was no question of giving you a grant at that time. Right? And they gave us a soft loan because we were generating revenue from software services. Otherwise, if we did not have a balance sheet, that would not have happened either. But that was a very interesting program because we had some of the best names in Indian science mentoring us as part of the program. It was not just the money. We had Professor Padmanabhan, who was the former director of the Indian Institute of Science and subsequently was the chairman of multiple committees of BIRAC for a very long time. We had Dr. N.K. Ganguly, who was the ICMR Director General. We had Professor Mohan Rao. We had fantastic guidance. And among the most valuable things was that they believed in us even more than we believed in ourselves. So we were able to cut short a 5-year project into 3 years. This never happened in the history of Indian innovation, but it was not just us and the team, it was the kind of guidance that we got that allowed us to do that. And we were given an additional project to now do this with a clinical use case, because in the very early days, nobody actually believed that we would be able to do PCR on a chip with an Indian technique, with an Indian company, isn't it? By 2010, we were able to show that we could do hepatitis B viral load. So quantitative testing on our platform. And as a bunch of scientists that we typically were, we were wondering now what to do. Because we had blinkers towards that goal. Can we do PCR with a clinical sample? And that is when I met Sriram multiple times, multiple conferences. It helps that this is a very small community, so you keep running into each other very often. And of all the different options that were there in front of us, and this was Big Tech Labs I was talking about, the only place where the wavelengths matched and the need to create impact with what we were doing matched was with Sriram. And that is how the journey of Molbio started. I must tell you that it has been an absolutely incredible journey from that point on, because everything that we did not know in terms of regulation, in terms of manufacturing, in terms of go-to-market, and in terms of scaling and supporting something at this kind of volumes is something that we were able to do together. As Sriram talked about this earlier today, 2009, 2010, we had the H1N1 epidemic. That was the first time that the word PCR came into public domain. If you remember, there were huge queues outside the very few centers in every metro city to test for H1N1. Bangalore, people used to say, can you please test this for us, because most times the results went to the patient after the patient died. But we were able to, along with the National Institute of NIMHANS, Mental Health and Neurosciences, and the Rajiv Gandhi Institute of Chest Diseases, show that you could do PCR right where the patient is and provide the results in less than 1 hour. That is how ICMR got interested. And ICMR decided to fund a multi-centric study, and that took us 4 years to complete. That is the time when the clinical community really realized that something like this is super valuable. So they wanted more out of the platform. And they kept on wanting more and more out of the platform. But by the time we had H1N1 validated at the end of 4 years, they wanted a platform that could do H3N2, H5N1, and any future variation of influenza on this platform. Somewhere around that time is, of course, Sriram, once we joined forces with him, was very insistent that we work on TB. And I must tell you, you're talking about stigma today. I must tell you, as a bunch of scientists, none of my scientists wanted to touch a sputum sample. It is the most difficult sample from an engineering perspective. I'm not talking about anything else. This sample can be extremely thick. It can be extremely watery. It could be in clumps. It could be in all kinds of forms physically. And it could vary with the climatic conditions. It could vary with geography. And to take this sputum sample and to homogenize it in a way that the TB bacilli is available for you to break open and subsequently do nucleic acid testing is a far cry from doing a blood sample. That way, blood sample is the charm. A urine sample is even better. So from an engineering perspective, it was a massive challenge for us to do. And preparing this was a very, very major part of our challenges. I went to Dr. Soumya and to Dr. Katoch. Dr. Katoch was at that time ICMR Director General, and asked him, we want to do this, but I don't have access to samples. And he said, Arey, you're telling me we don't have access to samples? You're from India, you're from Bangalore, staying next to NTI. But luckily, Dr. Soumya came to our rescue, because you can't work on molecular techniques unless you have characterized sample banks. And we don't have that. We still don't have that in this country. If you want a characterized sputum sample bank, you have to get it from FIND, correct, in Geneva. Because unless you test on a large number of samples, how do you know whether your technique is even worth taking out for clinical evaluation? Correct. All of these are long stories, and I will just cut it short by saying that by the time we finished our TB validations, as Sriram said earlier today, and FIND finished its validations, we got our WHO approval in Jan of 2020. We were prepared to scale our technology. We had invested in manufacturing. We had invested in parts. And COVID happened, and we were able to deliver those 1,500 machines. That was just because, as a company, for us, again, I should emphasize it was about impact. We had done this even before we got the order. Otherwise, there was no way in which we could have delivered 1,500 machines during the lockdowns of COVID. So when people look at us and say that you have done 14 million COVID tests, you grew so massively during COVID, they don't understand that there were 2 decades of work behind that. It was not a flash in the pan. And COVID was not our first test. Possibly it was not our 10th test also. There are so many different tests on that platform before COVID. Next slide, please. We were talking earlier, I think Dr. Padmapriya mentioned tongue swabs. There is a lot of interest in tongue swab today. So the tongue is a very complex organ. with a lot of folds. And the premise is that as a TB patient, if you're producing sputum, some of that will stick to your tongue, to the holes in your tongue. So even for a child who is not able to regurgitate sputum, you will still have, the tongue should still have bacilli. The question is, how do you break open this bacilli without going through a huge processing step? And considering that TB is already paucibacillary, already is something which has very low bacterial loads. From there, if you're going to a sample type that has even lower bacterial loads, how do you see that your sensitivity is not impacted? So we worked on this. We worked on this technique. We have a device now called True Lies, and it does a beautiful job of breaking open the TB cell. We are very excited about this, but I must tell you about with a caveat here. This requires extensive clinical testing. This is not something that is going to change or revolutionize the world of TB as everybody imagines it will without that degree of evidence gathering. And I say that because we have to see what happens with trace samples. We don't want to go and test somebody for TB again and tell them that you don't have TB and allow them to continue to suffer and continue to spread TB in the community. We've just come out of the era of coming out of the era of microscopy. Do we want to get back there? So technology is one, but technology validation with extensive clinical evidence is the other, and that is what will possibly be required for this particular technique to move forward. Next slide, please. Today, we have a very extensive install base. We have a large number of devices. We have spoken about this throughout the world. We have a large number of tests that have been delivered on this platform. It is a proven technology. And what we have actually shown is that we have the capability to manufacture this very interesting and very intricate technology at massive scale. And you've seen the facilities yesterday, most of you have. It has taken us a lot of learning to kind of create this kind of world-class manufacturing facility. It has also taken us a lot of learning to create world-class support. We are talking about supporting devices at point of care. It is not supporting devices at a district, headquarters. Some of the places that our devices are in take days to reach there. So how are you supposed to ensure that your devices have massive uptime? You also heard earlier that we have SLAs now for our device, and within 5 days, we will have that device working again. Nobody in the world has ventured so far, has had the courage so far to say that they will do this for any technique. But for us, again, it is about impact. And the impact of not having a test after it is installed is not something that we like to talk about. So we've created methodologies, expertise to ensure that these are available very highly. Next slide, please. You heard extensively about the handheld X-ray, the ProRad X-ray. What we've talked a little less about is our ability to take this, and Krishna Prasad earlier in his presentation talked about this, making this extremely mobile so that you can take a combination of an X-ray and a nucleic acid test to wherever it requires. We can do this not just for X-ray and AI, but also for other techniques that we talked about with the breast cancer screening tool from Niramai, or our HPV high-risk screening tool. All of these require to go closer to the patient. And why does it require to go closer to the patient? The next slide will tell you. Can I have the next slide, please? This is a slide that I'm super excited about. This data has just come to us from FIND, which was a study done in Tanzania and Mozambique. Everybody knows that we want testing closer to point of care. So in this study, district microscopy or designated microscopy centers in Tanzania and Mozambique. About 29 of them were selected. 15 of them had TrueNAT installed, and the other 14 had what is standard of care, actually a slightly elevated standard of care. So what happened there in those 14 centers is people got microscopy as their test, but twice a week, those people were also transported to a gene expert site. Okay, so that they don't miss getting a molecular test. The data is super interesting. Nearly 2,000 people were tested with both techniques. The incidence rate was roughly the same across both the populations, which was expected, around 7.5%. But just see the yield of TrueNAT, 7.3%, vis-a-vis 4.8% for microscopy. Assuming that all of them got a molecular test also, same day initiation of treatment for all those people in those 15 sites, 83% of those people who were diagnosed got initiated on treatment on the same day. Within 7 days, 98% of all of those people who were diagnosed on TrueNAT were put on treatment. Compare this to not having molecular test at hand, but having that at a district or district hospital or an equivalent. Only 64% of those people were initiated on treatment after 7 days. What this does not tell you, and what the graph shows you, is about 7% of all of those people who did not have an upfront molecular test at point of care were never treated. Complete loss to follow-up in this very small study. Can you just imagine? And this is a study. This is a properly conducted study with properly conducted follow-up. What happens in the community? You saw the evidence of that from Vietnam today. This is exactly what we are talking about. You saw the evidence from Dr. Padmapriya's slides today. We are exactly talking about the same thing. About 3.5% completely missing after getting a molecular test. Because it is not just important to test, it is important to initiate treatment right then and there. And that is the impact that we have created by going closer to care. That is what drives us to keep on going closer to care. Hence our mobile platforms. Next slide, please. These are the various collaborations that we are today talking about. We've talked about this throughout the day, but we're working with a company called Stellar to create a rapid test for triaging. We are working with a company called Doctrinal to help scale their cough-based sound signatures for triaging. That, along with the X-ray, provides us a multi-pronged way of screening populations that can bring in a pipeline for molecular testing. It is not possible humanly to have molecular testing to everybody who presents for TB. It may not even be technically feasible. So these techniques are going to be extremely important there. Going beyond TB alone, let's talk about sickle cell. We're working with a professor from the Indian Institute of Science and his company to very rapidly screen populations for sickle cell using optical spectrometry. Very simple technique that can be scaled in the field. And it is as sensitive, if not more, than HPLC and equivalent techniques. We're working with this company called TBpeople, and we already have a device now that can do a 5-part CBC at point of care. And this can do a 5-part CBC in 5 minutes. Just imagine you go to a clinic. The doctor takes a peripheral sample of blood and is able to decide your course of treatment based on a CBC result. We're talking about nucleic acid testing. Simple things like CBC are not available at point of care. I don't get a CBC test when I go to my doctor. I get it after 1 day, after treatment has been initiated. Just imagine the transformation something like this can bring to primary healthcare. Very low cost, extremely highly sensitive tests, highly accurate tests. We're also working on ways to improve the number of pathogens we can test with the PCR test when you get a sample. So today we have a platform that can do at the minimum 15 different pathogens. and at the maximum 63 different pathogens with one clinical sample. So syndromatic testing can be really achieved and can be achieved at an affordable price point. See, all of us come across these things. I recently had my school classmate's daughter who was misdiagnosed, and she died of sepsis within 8 hours after seeking care. So can we do sepsis detection within 1 hour of that patient being admitted? Now with sepsis, it's a complicated situation because you treat for a bug, and if it is hospital acquired, you will have another bug come up in the next 24 hours. If you're going to send your sample out, that patient is going to die unless you are able to diagnose right then and there. So a technique that is able to diagnose within an hour of that sample being present is something that we're working on. We are also working on providing information about biochemistry. We are talking about TB the whole day. I hear about diagnosis of TB. I hear about kidney troubles. I hear about liver troubles. How did those get diagnosed? These TB patients, if we are talking about TB patients and putting patients right at the center of diagnosis, shouldn't they be monitored very actively in terms of the effect of the drugs? How are we going to monitor them? We have to be able to do many of these things, including blindness. We're working on techniques that can actually detect blindness very, very quickly. So this is what we are doing. Next slide, please. Now, to make it a little more formal, we've just announced a partnership with the Health Innovation Exchange, which is a Geneva-based organization, quasi-UN organization, to do this a little more systematically and help other companies scale rapidly. Because just imagine where we were as innovators a few years ago. Innovators are focused on innovation and how that innovation can impact lives. They work very hard on trying to create that innovation. Sometime along that, they stop being innovators and start raising money. So they are on a treadmill of fundraise. To do what? To understand and bring people who can do manufacturing, regulation, sales, support. So we have done the hard yards. Can we work with the Indian ecosystem? Can we work with the international ecosystem of innovators? And can we help accelerate the journey for faster and more timely impact for the patients? It's better to have technology today rather than 5 years from today. With that, I would like to stop talking and welcome any questions if there is time.
I have a question for you, sir. And I would still again go back and talk about TB. Could you explain a little bit about the validation process which you had for TrueNat and some data, share some data on that? Yeah. How many tests and how does it compare with validation of other molecular tests? Thank you.
So the TrueNat had the first mover or the first child advantage or disadvantage, I should say. You know, even when parenting, if you have more than one child, you learn through that process how to parent, isn't it? So our validation also went through the same journey. So we went through 2 phases of validation, a phase 1 for detection of TB and a phase 2 for rifampicin resistance. And I think they were about 10,000 data points, if I'm not mistaken, 10,000 data points across 5 centers, if I'm not mistaken. Then we had an in-country testing where 10 states and 2 sites per state. One is a district site and one is a low burden or DMC site were selected. So totally 100 sites or 10 different sites per state. So 100 sites, 50 of them DMCs, 50 of them district hospital sites were selected. And people who were doing smear microscopy earlier, the smear microscopy technicians were trained to do TrueNat. 18,000 tests were run by them. that evidence was very interesting because for the first time, and I forget to mention this, TrueNat is a completely connected platform. You can push data to Nikshay or to a central authority almost instantly as soon as the test is done. And when this was done for the first time, the program had live data of testing across these 100 sites. You were able to see what is the incidence live. So about 30,000 data points over 5 years is what we generated just with ICMR. And then we had the global testing by FIND. So that was the validation journey.
So this, I don't know much about how a product is validated, so I'm just wanting to get a second part of your question.
Yes, and I'm going to repeat that.
No, I got you loud enough.
Okay.
So as Candy said, we've done about 30,000 tests within India and out of India, and time frame of maybe 5 days. To this, the other companies which came in before us, which is of course taken in the New England Journal of Medicine paper, they did about 1,750 tests. I mean, their validation was for about 1,750 tests, and it took what, a year and a half in 4 to 5 countries. So I guess, as Candy said, the balance is there in front of you. But again, we've been first in terms of the real point of care. We went through it, and I think we gained that much more for the whole.
Absolutely. I would second that. Whether the, if I understand your question, you were asking. Yes, yes. Today, our protocols are more evolved. I think even ICMR's protocols are more evolved. And I think a newer test will not have to go through this journey. We have to look at it from the lens of not having any Indian product in any Indian program before this. And hence the burden of evidence. Yes. Yes.
But when you test and treat in tuberculosis, you don't have to see any other disease whether there or not. And secondly, along with all your messages, prognostic marker should go like a sedimentation rate, because none of the NAT would be able to differentiate between treated and untreated case.
Yes.
And therefore, sedimentation rate, ESR, which is a very cheap and can be point of care, should be always included in all the discussion, because there is no other prognostic marker than weight gain, appetite, but the best marker is sedimentation rate.
Absolutely, loud and clear. By the way, we are also working on a test that can differentiate between treated and untreated. So
there is one more question.
Yes.
I have one message. I like the idea about lab on wheels. So that talks about it, getting everyone to know that there is a testing going on here and come and test. And I have one suggestion to that is those people who are found TB positive, that is the day to change their lives. If that day is not protected, they will go missing.
Absolutely.
So the counseling should be right and followed by peer counseling. A person who's cured of TB, because that person goes through fear, depression. So if the counseling starts from there, he gets introduced to a person who's cured and I'm absolutely fine and you will be fine too. That goes with the message, with the treatment.
Absolutely right, ma'am. In fact, that is the reason why I'm excited about the fine data that has been done with a lot of effort, because we know this. But data has to also talk about it. And finally, we have data talking about it as to what happens if you have molecular tests at point of care and same day treatment initiation. But your point on initiation being a 360-degree effort is well taken.
If-
So you mentioned the excitement on the lab on wheels. So what we say is low is the new high from Molbio. Lab on wheels is the new high. Low is the new high. And we actually got this in a poster form, and we've kind of sending across this message across the globe.
And I would like to add one thing there. It's now also lab on the boat, which Philippines has shown.
One second. Just to go back on your last question about the number of tests that we had to do. See, we were the first people who were claiming that the test is going to work as a point of care test at the primary level, right? So there was a lot of disbelief that this can happen, right? So that had to be proved. That had to be proved not only from the technical point of view, but also the fact that it's coming from India. So that was an even bigger burden. Even for ICMR, they had to absolutely be 100% sure before they even said something, because, and we have seen this globally a number of times where people have tried their best to discount us time and again, but then this was part of the game. So all this testing, all this data helped tremendously. If we hadn't had that kind of support, we would have been probably not there at all.
Yeah, but on this point, I also want to acknowledge the role of Government of India. Okay, in terms of actual support, in terms of money, maybe a fraction, a very small fraction of what we ended up spending. But those support at those critical times, starting with the first support from Nimitli, then support from DBT for validating a few of our tests, then support from ICMR. It's been tremendous. So it's not just us, it's not just this company, it's this entire community in a sense that is responsible for our journey.
Thank you. Thank you so much for your wonderful presentation. Thank you. Thank you all.
And thanks to Kalpana now for chairing the session. And now I request Anuradha Mascarenhas, Senior Editor, The Indian Express, Pune, to please chair the next session on local actions for global goals.
Good evening, good afternoon, everyone. Thank you, Shobha, Bobby, Molbio, for this opportunity. And it really is a privilege to chair this session and introduce Dr. Tara. I think what he said in the beginning of the session, the inaugural, was very interesting, that he says, we have to change our mindset and we have to engage people. And that's what's coming across through the entire day. So, I mean, even in my conversation with Dr. Padma Priya, she was just telling me that, we need to, we have to be a little more self-aware. I mean, smoking, diabetes, TB, see the connect. Why aren't we all aware about these kind of issues or problems, etc.? So just before I get Dr. Tara in, I just wanted to talk about how even small local actions can really help. From where I come, at a medical college, so there's a chest and respiratory OPD. So the TB patient is newly diagnosed. The doctor tells the TB patient, भैया अभी यहाँ से pediatric department पे जाओ. वहाँ से a counseling team will talk to all the family members, tell them household contacts, tell them again counsel, then they will again get back to them. Keep on talking to them, calling them up. So, this is where this engagement from the community at the local level can help. So, Dr. Tara is, he is...
I think I don't need that one.
No.
Yeah.
Allow me, please. He is the board director, Asia Pacific Cities Alliance for Health and Development Singapore. He is the director of Asia Pacific Regional Office of the International Union Against Tuberculosis. And he has advanced local actions at sub-national levels in over 100 cities of 12 countries in Asia. Not only tobacco control, but, NCDs prevention and so on. So, of course, with so much of experience in TB, HIV, AIDS control, health systems, etc., it's really a privilege to kind of introduce you, Dr. Tara. And
The floor is yours. Thanks.
Thank you very much. I think always I hate that last part. This I don't like. So I'm just Tara. Yes. Thank you, Chair, for your introduction. I think I will go very quickly to my all this presentation, just highlighting so actually what do I mean by local action, the community engagement. So in my whole presentation, I'm going to a bit highlight more on the local governments. So why I believe on governments, because governments all about us. It's a system. We are talking about the system, not about the people who runs the governments. Yes, the system is a system. So I don't know. Yeah, thanks. Just what I have learned. This is my the slide. I went out. Remember, so actually I thought it's better what I learned from this. The whole team, all the speakers and the things from morning until now. This is my learning actually. What I have learned. Just you bring me, you put me everything in my almost 30 years back. So my guru, teacher, he used to teach me like this. That's I learned from this one. Again, it's a reflection. So in this part of the world, in our settings, so our child or any child, they don't burn with TB or anywhere in the world. So, but in our regions, in our settings, it's a bit different scenario. The high burden, high developed countries or developed countries, maybe they are not susceptible to TB, but in our setting, once the child born, always there is a risk. Always there is a risk to get TB, that is exposure. So there are many other factors, to really accelerate the tuberculosis in a community. I don't want to go the more details, but Dr. Ishor and others already highlighted this in their presentation and whole discussion there, crowding, migration, indoor environments, so that we talk about infection control within the health setting, also beyond the health setting. So those are the things, that are key drivers also for TB infection. So we also talk about the TB infection in our community. So like, for example, in my country, Nepal, about 45% of the, of the population, they are infected with TB. It doesn't mean they have a TB disease, but they are infected with TB. So from infection, when you really look at about the disease, then there are many other factors, determinants. Like a smoking, malnutrition, diabetes, alcohol, HIV. That we also discuss a bit. I think we talk more about the malnutrition, diabetes, HIV. But I don't think I didn't hear it from anyone talking, also highlighting about smoking and alcohol. I think that is also another area as a TB control or TB elimination. The advocates, we should think broadly. Therefore, I think that these are the also other determinants that accelerate the from TB infection to TB disease. So when people get sick, with TB in our community, I think that's all about we are talking there. Therefore, we are saying I find all and treat all with a high quality, the technology, medicines, the healthcare. We all are talking about actually on that side, the people with TB. And we also talk about the missing TB case. Actually, I hate the word. I think the Arthana, I think you rightly pointed out, it's not missing actually. They are not missing. Because we are not there. We are actually, actually, it's not a missing the case. I think that's the whole things we have to change. Why we put all the blame on the people? It's not their fault. One of the TB expert, he came from the UK in my country, I think 1996, and he was telling us in a big conference like this, oh, the TB is very difficult and hard to reach area in Nepal. Yeah, it's a hilly country, it's a mountainous country, it's a hard to reach there. Of course, it's a difficult to reach there, but the system should be there. They cannot. I asked him, can you change this whole things? Like, can you make it flat? My country, And then it's easy to assess. So those are the thing, very practical thing. I think we have to really understand, So whatever we discussed this morning and until now, we are discussing about the practical areas, practical things. What is happening in our community? How could we address whether stigma is really problem or not? Actually, it's not. Stigma is not a problem, but we didn't understand the local culture. We didn't contextualize our TB program in that context. But we said, oh, stigma, people don't come. That's not reality. So there are many things. I think that's why we are talking about find all, people, treat all people with TB. I think that is something, that part. So when it goes up again, so if we don't, eliminate that part, or it means like if we don't find all TB cases in our community, always our child, our children, or the people who is going to, whatever, is always susceptible to TB, always risk on TB, to get TB. So our goal is to really cut the chain of the transmission at that point. First, I think that's our priority. For this, we need to find everyone in our community. So therefore, this is just a reminding. So there are also many discussions going on whether we do the active case finding or not. If you look at the WHO whole, if you read the whole book, I say book, it's a really book, or any partner's book, it's even my organization book. It's a very thick book. Always say, oh, high risk population. Tell me in India or in my country, Nepal, who is the high risk? Are we risk-free here? I don't think we are risk-free. Why we blame only the HIV positive? Why we blame on the smoker are high risk? Why we only diabetes, the people are on high risk? No, we all are on risk. It may be different in Singapore. It's very almost TB elimination. Maybe in a high income country, Europe, may be different. But our setting in Asia, Africa, I think we all are on risk. So why we go only for the high risk group? Why not for all? So if you only think high risk within our community, for example, in India, I don't think even we should not dream TB elimination. So therefore, my always priority is we have to understand the local context, work with the local context, find all. It's not that difficult. Okay, I'll come in few minutes on that. Okay, then the next, I want to just touch upon the TB determinants. So this is something like, we appreciate WHO. They are the one to compile all the data. Okay, so this is the WHO data. So anyway, in the recent reports, we see at least now they have identified some TB determinants that includes the factors like, for example, alcohol, diabetes, HIV infection, smoking, and malnutrition. So these are also the key risk factor we need to think about, and we need to integrate in our program. In many programs, when we talk about this, the first, the government official, even the civil society, we first come up with the resources. Oh, we don't have resources, because we are very, very self-centered. Just believe me, please, we have to be very honest. Go back to your office, organization, and look at the TB budget. How much budget you have allocated for your organization only? How much budget actually we have for the people, for the program? I think the ratio would be around 15, and for program, 85% the organization. It's happening in many organizations. So we are very focused. Same thing in the government side, Ministry of Health. If their budget is very huge, if it really factors, actually there is very small percentage, less than 15%. Actually, in my country, I know, Nepal, less than 15% budget only for programs for the people. But 85% of the whole TB budget is for their travels, is there for supervision, is there for monitoring, is there for, recording, is there reporting, all these things. So I think that is something we have to also think. So these are, when we see the budget, these are some intervention easily can be integrated within the the programs. Doesn't require the additional money. It's all requires about our approach. How to provide a comprehensive quality service to our people. I think it's not only okay that we talk about the compliance, right? Well, what do we mean by the compliance? Just the people with TB, just they take a medicine. We count like it's a compliance every day. They take a medicine until 6 months or 4 months, whatever they know the duration, depending on the country. That's not a compliance. Compliance means there's a comprehensive quality care the patient should get. I think that's so. These are also another the components included in the quality care. I think that's really important. But if you look at this, the exposure, the risk is a depending on the size of the problem in different countries. But if you look at it here, the exposure, I would just highlight the one thing here. Look at it, about the 1,000 million smokers, they are exposed to TB. They are always on a risk. It's a huge number. Forget about this, the population fraction or percentage. Huge number. If you count the number, that's huge. I think India is the second largest country in terms of the tobacco consumption. Can you imagine? So I think in our current programs, is there any intervention to address this? Of course, India is doing very good tobacco control program. I would say that's it's good. It's improving a lot, but we need to do more. Okay, just another I don't want to go in very details, but the smoking or passive smoking or active smoking is a really significant risk factor for all the way in the path of the TB, the diagnosis, treatments, and also all. So it's not only the infection. It has some issue with the treatment outcome. It has an issue with the relapse, the failure, MDR, TB. The most important in the delay in diagnosis. So let me explain you my next slide about the delay. Yes. Oh, it's manual? Oh, sorry. I thought it's okay. So I think this is just to highlight here is one of the example from Indonesia. So one third of the estimated tuberculosis cases actually attributable to tobacco smoking. 1/3, 300,000 TB cases, they are attributable to tobacco smoking in Indonesia. But if you look at this side, I can't see, but I can see the differentiate the color. So the tobacco smoking remains in most of the high burden settings still the either number 1 or number 2 risk factor. So I think we really need to think about that as well. Next slide, please. Okay, if you look at the prevalence of tobacco smoking among the TB population, if you look at this, so we have like in India, it's the compared to male and female compared to the general population. If you look at here in India, the smoking prevalence, among the TB population in male, almost 90%. It's a huge, So in Indonesia, it's almost 100%, 96, 97%. Can you imagine? Among the male population, compared to if in a general population, look at only 42% in India, 65 is quite high in an Indonesian setting, and in other countries like in South Africa, and it's still high. So it's a significant risk factor. So we cannot just eliminate this from our tuberculosis. We need to integrate the tobacco smoking intervention, alcohol, and others, the intervention in a regular program. Next, please. Delay. I think this is one of our story, that we did in Nepal, in Kathmandu. Kathmandu is the capital city of Nepal. Okay, it's a long time back we did this study, but I think it's still relevant. And this morning, I think in one of the speakers, he was also talking, or yes, he was talking about that there is 2-month delay, right? So I think Padma, Dr. Padma, the presentation. So in Nepal, if you look at, this is an urban setting. Kathmandu is the most accessible area. So hospitals are there, doctors were almost 60% of the whole Nepal, the doctors, they are in Kathmandu. You know, the big hospitals are there all. So if you look at the smoking, the delay is more than 100 days. In general, delay to seek healthcare and delay plus the diagnosis and treatment. So it's the most important part is the delay for health seeking is really, really high. So then we have further analysis. We did a bit further analysis to look at the difference between smoker, former smoker, and never smoker. You can see among the current smoker, if more than 4 months, the delay, it means the patient still remain in a community until 4 months. And we are talking here about the stigma, accessibility, and all these things. There is no point to blame them. And one of the answer, we asked another one question, why? At that time, we talk about the symptoms, right? About cough. Now we don't talk about the symptoms because there are many studies that suggest, more than 50% of they don't, present symptoms. But that time is a cough, more than 2 weeks or 3 weeks, all these things. And we asked the question, why did you remain in a community or undiagnosed or something? They said, because of smoking. They thought their cough is because of their smoke. So that's something, that of course, its needs are really very strong, powerful, the health awareness campaign, the messaging, in a community about TB and its risk. So that's and then look at overall, it's really quite high. But if you just compare it among smoker and non-smoker, it's a big difference. Next, please. So this is also another interesting finding from the same study. It's about the at that time it's a microscopy era, yeah. So it's not, but it's still relevant. But when we really translate this in a public health program. So at that time, the grading of the sputum examination 1+, 2+, 3+ or something is a number of bacilli that is seen in the sputum microscopy. So the 39, about 40% of the population, the samples, they present the high degree of the bacilli. But if we have a further, they made some analysis here of these 241 or the TB patient, and we look at whether there is any difference between smoker and non-smoker. If you look at the smoker, they had high number of TB bacilli. That means these are the smoker are really, they are the one to they remains longer in the community, and they are at the same time transmitting the disease to their household or the friends or a community. So we need to also have an intervention, integrated intervention of smoking. Next one, please. So how to address the problem? Next one. Good. Now this is my another part. That's the problem. Now the solution. The solution, we realized, we thought, how can we change something? So in any public health area. So the thanks Parvod here also. We had a very good lesson learned from Indonesia because I'm working in Indonesia. It's almost 16 years my work in Indonesia in tobacco control and some other public health intervention as well. So the lesson learned from Indonesia, we have translated in Asia Pacific. I don't want to go in details about Indonesia. 2016, Bobby here. So I can see the founder member is still, yes, I think 3, including me 4. Yeah, anyway, it's a good number. So established the Asia Pacific Cities Alliance for tobacco control and NCT, but later on, the name was changed like Asia Pacific Cities Alliance for Health and Development. It's basically a mayor's network, the mayor from many cities. So in 2016, it has only, I think, 12 cities from 8 countries. Now, 2022, we had the recent the summit that we had in Bali last year. So now its member reached to 121 cities of the 12 countries, including India, Bangladesh. Bangladesh is also the big number actually. So what's the main objective of this alliance? The first thing is very simple: gain political will. So I will explain a bit in my next slide what we mean by the political will. Second, the sustainability. It's not like a project. Many donors, they love to have a project, but we don't believe on the project. We want the programs, and the program must be sustained. Finally, it's accountability. So that includes all of the components, including the government's accountabilities and community accountabilities. So, this alliance has two co-chairs. One is the mayor of Bogor City, Mayor Bima from Indonesia, and Mayor Francis Garcia from Philippines. And they are really very active in driving this alliance. And we have also the country alliance in many countries. For example, in the Bangladesh, it's very powerful mayor alliance there. We have in Cambodia, we have in Indonesia, we have in Philippines. We had in Myanmar, but due to some current political things, it has there are some issues. We have in Timor-Leste as well. So it's a really big, the political alliance at the subnational level to deliver the things on the ground. Next slide, please. So what we mean by political, the commitments, the political leadership. The first thing is awareness and the commitment. Awareness on the agenda, whether it's TB or tobacco smoke control or NCD control or anything. So we need the local ownership, the mayors, the leaders' ownership first. It's not a health leadership, it's the political leadership that we would like to have, okay? The second point is we always talk about partnership. In any city, we can organize any meetings, okay, inviting the private sector, community, civil society, but who is responsible? We have to make the leader responsible to engage all the private sector, civil society in any public health initiative. That's why the private sector partnership. The third point is vision. Once we have these two components, therefore now we are coming up with like for tobacco control, we have a vision like a smoke-free city. For TB, maybe the TB-free city, anything. So very clear visions with programs. When I say the policy, it's not technical document. So it should be legalized. There should be a legal mandate for any intervention. For example, in tobacco control is a local regulation law, and that mandates all the the sector to implement the program. Same thing, I think it can be done for tuberculosis. In many countries, some countries there is a national TB law. In some countries not, but it needs to be translated in the local setting. I think that's really important when you talk about the human rights, when you talk about anything. But a technical documents is just a technical. So it's like a volunteer. I think we need to make a mandatory the policies. So those are the points there. And also another point I would like to point, if we do something at the local level, actually that really inspires something to the national governments. So I will talk a bit later about the more on the result side. So the story from Indonesia. Donors. I put in the donors a leadership part. Most of the times what is happening in many countries, it's a donors driven program. That's the reality. Okay, that's the reality. But I think it doesn't mean, I don't mean by we don't need the donors' money. No, we need the donors. We need their support with both a technical, financial, all. But it should be for the local agenda. So who can set the agenda is the local leader, the political leaders. I think that's really important. So that's why I put that is part of the if I define on behalf of the APCAT what is political leadership, these are 3-4 points. So the sustainability comes this side. So I talk about sustainable whole of government approach. what is happening now in most of the public health program is only the health sector always run the programs. I think we have to completely forget that concept. It's not the health agenda. It is a development agenda. So all the sectors at the within the government, they should be engaged. And for example, when I say the whole of governments, I don't know. For me, at the local level, there are different government departments, health department, finance department. There is police, local, the police, the local enforcement agencies, planning divisions. There is so many, the departments there. So we really need to engage everyone together. That's the whole of government's efforts. So the Ministry of Home Affairs at the local, I don't know what they call, but in Indonesian setting they calls like the Satpol PP or something. It's a really unique thing. So they manage all the local prison, jail. Okay, so we have always problem with the TB in jail, TB in prison. So if we engage local authority, it's their role. They have to provide the services to, So why we talk about this is a barrier? No, it's not a barrier. It's all of our working style, how we engage the local people and offer, the support and build their ownership. So the another part is accountability. So I don't want to go in details, but these are the three key pillars of the Mayor Alliance. Next, please. One success story. Yeah, next one. In Indonesia, when we started the programs, there is kosong. Kosong means Indonesian language is zero. Yeah, null. None of the cities had any tobacco control program. That was in 2008. And tobacco control in Indonesian setting is it's a big problem. Okay, it's a really huge, because Indonesia is the only country in the world hasn't signed the WHO Framework Convention on Tobacco Control. And industry influence is huge at the national level with the politician, member of parliaments, presidents, minister, all. So when we went first time as the union in 2008, and we had a one-to-one meeting like with the director of the DG of CDC, and what he told to us, please don't come for tobacco control in Ministry of Health. You can go in other ministries. That was the environment within the Ministry of Health, because it doesn't mean they don't want to do tobacco control, but they were very scared with the politician because there was really, the very good engagement. So in that setting environment, it was really almost impossible to work at the national level, but we tried to work with the sub-national level, find out the ways at the sub-national level. It started with the 4 cities. We got a really good success. We had a local law on tobacco control, implemented very well and expanded now throughout the country. So you can see the green is like a comprehensive quality tobacco control or smoke-free, like 309 cities and districts until now out of 500. The rest, there is something happening. So it's a really good, successful story from tobacco control. Why not we can implement this in TB control as well, building the ownership of the local government. Next, please. The second part, I want to bring you for another public health program, that is rabies prevention. So APCAT also in collaboration with the World Organization for Animal Health, WOA, there is some intervention on rabies prevention and in Bali. Next, please. So just it's a quick highlight. This was just a recent engagement of the APCAT, the Mayor Alliance in Bali. So last year, the scenario was just comparing the results, only the one activity, the vaccination, dogs vaccination. In 2020, this all is yellow 2022 targets. Okay, in at least three cities in Bali. In a Bali province, there are 9 cities or 9 districts. So I'm just presenting the 3 cities results. In 2022, in this city, the achievements were only 32%, the vaccine coverage. But, if we compare, about 90,000 dogs should be vaccinated in this district in last year, but only 32% of them were vaccinated. Same thing, very low, the green one. So in 2023 until September data, this is again the overall dogs estimated population remain the same, but this city, Badung, is already achieved over 98%. I will tell you why later. The another is Bangli, and this already achieved almost 80%. And Denpasar is the capital city of the Bali province, already achieved over 70% dogs vaccination. Why? How? What happened? What's miracle there? It's nothing. There was no any miracle. In 2022, vaccines there, all logistic supplies, people, everything remained same, no change. Last year and this year. Okay. So I don't need to explain everything. Only thing missing, I think somebody has made that point this afternoon, communication. Communication to the mayors. The vaccination program, rabies control program, it was remain within the animal health departments. No communication with any other, very limited communication between animal health and the public health, but no communication with the mayor, with the whole government. And when we asked why, they said, we don't have the operational cost. Vaccines there, operational cost, just very, very small amount of money. Who said this? The animal health department. And we took that message and made our mayor alliance, the people, they made the city mayor of each district. They didn't know about that. That health department or public animal health department, they never raised that issue to the mayors. They were really surprised, Now they said, we want to take the ownership of this rabies control program. We means the mayors, they want to take the ownership of the rabies program, allocate the budget from the local, they have plenty of budget. Budget is not an issue. It's all about communication and messaging. Because of that, now there is no any issue. The vaccination campaigns running smoothly. I believe they will achieve their targets. So that's another model, that's another things. Therefore, we need to think beyond. And communication is sometimes we forget it. But it's a very important message, and we have to bring this to the right people. That's very important, and the right time. Next one, please. Another one is the TB and smoking, the success story. I have one or two slides for you. Yeah, next one. It's about in a Bogar city, one of our co-chair of this APCAT, we work with it. There are several good examples. I would like to just highlight here the smoking cessation within the TB programs. So this is, and some other country as well. This one is the Indonesia one, the middle one, you can see. But this is from Bangladesh and the China. Just to, in Bangladesh also, it's not a health department. They did the smoking cessation. It's all from community health volunteers at the local level. They were engaged on the person who provide the duty on a daily basis. Simply they were trained on one day training or half day training, and they provided some counseling message, and they offer in every occasion, every event, the encounter with the patient. So it's like what we call ABC, ask, brief advice, and cessation support. Very simple message that can be offered, that was offered in many countries, 5 to 7 minutes, integrated with the DOT, TB message. It's not only the tobacco smoking cessation. So the results, the quit rate was really high in all these countries. The same methodology applied in China, Indonesia, Bangladesh. We have Philippines data also, some other countries. But again, yes, India as well. Why I didn't have that one. Anyway, the quit rate was really high in all these countries. So it's possible to integrate. There was no any additional money. Yeah. So I don't want to highlight no additional money at all. It's integrated within the regular TB services. Next one, please. This is very interesting one. This, we also assess the exposure to secondhand smoke at household level in a patient home. So, the 0 month means when the patient start TB treatment or diagnosed, and then at the end of the TB treatment. The exposure among the current smoker, of course, they were smoker. They used to smoke inside the house, but when the community volunteers provide some information about danger of the second-hand smoke, about the danger of smoking, even you can see, the significantly reduced at the end of the 6 months. So it means the patient, they become like as an advocate. So even for the former smoker, even they were not smoker, they quitted already smoking, but at the 0 month, we asked them whether they were exposed to second-hand smoke in their home. They say yes, because their other family members used to smoke inside, inside the home. But again, we provided a message through the TB patient, the ex-smoker. They convinced their family members not to smoke inside the home, and also never smoker. So, if we engage the people and we achieve more, no resources, no any additional the money here, 0 cost, but only what initially what the health center is what they did, they provide some smoking related message, quitting message, counseling, some message about the danger of smoking to the patient. There are many the good example I would explain. Okay, I don't have next one. Oh, this is kind of good. So this is the most important slide I would like to highlight here. And we discussed already the first point. We are not begging. We should change that mindset. We always, even still, we think, the missing TB case. Also, it's a begging. We should empower the people to demand something. Why don't I have this, the services near to my home? I think we have to create the demand. How to create that demand? We need to engage not only the people with TB. I think we have to raise the rights of the people without TB as well, because the exposure always they are exposed to the TB bacteria. So we need to really empower both communities. That's really, really important in all the messaging. The second, I also talk about the whole of government approach and whole of societal approach. Whole of societal approach, what do I mean by societal approach? Is we have many elements, like for example, the CNS, the media organize this workshop. I don't think that we had this, the dream in the past. There are many people, we are not only one to do the things. There are many other people. We may need their 1 minute, 30 seconds, or 5 minutes, 10 minutes. It's enough. What we see always, we want to see others also like me. I want to see you also like me. Should do as I do. No, it's not possible. Everyone has their own agenda. But what we need there some contribution, some time. Therefore, in a society, there are many people. We need to engage, like a media. There are, the TB people also there. That is very important. Every sector we need to engage to build the whole of government approach and societal approach. And One Health approach is critical. One Health is not it's just an approach. It's an intervention, more coordination, collaboration with the different departments, including one of the key things, it's very popular during the COVID time. Now also, it's one of the most sexy agenda, hot agenda now, One Health, One Health, One Health, but we don't practice the One Health. That's the problem. So even, the meeting like this, I think in the future, when you do this, we must invite the people from Ministry of Finance or the people deal with, at the state level. There are many other finance department, planning department. They should be here. It's a really important, that part as well. Not only the TB people. So we have to think beyond ourselves. Resources. That's the key. Always when we talk about at the end, even if you look at the Dr. Somia presentation, it's not my criticism. Okay, sorry for that. No. At the last, he mentioned about the resources, right? Constraint. We want to do this, do this, but the problem in low and middle income countries, the resource. But okay, stop everything. No, that's the thing. We have to find the alternate resources, domestic resources. There are many ways. Why don't we put high tax on tobacco? Why don't we put high tax on alcohol? Why don't we put a high tax on sugar and sweetened beverage? And some of the money can be used for public health program or for any the public health intervention. We should create a domestic resources, and there are many opportunities. But it's not easy, I know, but we need to demand now for a domestic resources by putting the high tax on these harmful products. So last but not the least, actually, we should not talk about the numbers. No targets for TB, actually. If we again go for 90%, reduction or 85% reduction, and then it means we are not doing the TB elimination. We are just trying to do the historical TB or TB control. Forget about targets. We have to go for all. Find all, treat all. I think that should be a message. And people always say, oh, India is a very big country. Okay, sorry for this. Of course, it's a big country and you have big resources. And big, everything, the structure, infrastructure, everything is big up to the community level. When you go at the panchayat, of course, if you compare the size of the population, of course, there will be 100,000. I think 200,000, 300,000, 500,000 at the panchayat level maximum, I think. Much less. So if you have to look at there, don't look at the billion population at the national level. Of course, it's difficult when you say the billion population. At the community level, when you go at the village or panchayat level, in their catchment area, the population is, we can find. So we have now new, the innovative technology, all the things we are talking about this, like Parvati is doing the 1,000 villages, they are TB free. It's possible. We have to talk like this. We have to break down all these, the intervention at the community level. So therefore, we need to go for community-based universal screening, not the targeted high-risk group. Maybe it's relevant for high-risk group in high income countries. Of course, there is no problem of TB, but in our setting, we have to go for all. I think with this, I would like to stop my things. Sorry for that. Yeah. Thank you.
Thank you so much, Dr. Tara. In fact, I don't think even if there are questions on the floor, I think he's well answered in this entire very comprehensive session. And yes, it's time to demand that the governments act. So thank you so much. Due to paucity of time, I don't think we'll be able to take questions. And,
thanks. Thank you. Thank you, sir.
Thank you, Anuradha. And in fact, I had distributed some chits of thought of taking out a lottery, but then I was told there are so many casinos in Goa, so no need for a lottery in this room. So we just go on, and we've been told to think and do differently. So one thing different I'm going to do, I've been told that we'll be thrown out of this room at 5:45, I think. So before that, this is not the end, but I'm just thanking each and every one of you equally for being here and for making this happen. This meeting could not have happened without the support of every one of you who is present in the room. So thank you for that. And I'm not going to take any individual names because it applies to each and every one of you. And after this, in fact, we had planned a very interesting session, the session Unplugged, which due to paucity of time, many things have already come up and they have been discussed. But what is, if we have taken anything from today's meet, what has been that take-home message, and how will you act, or will it make you act differently, or what will you do when you go back home? So we would like to hear from every one of you, keeping in mind, small is beautiful. Say it in 1 or 2 sentences, but I would like everyone to speak. What will we do differently? Quickly, please.
Really. So I think the best message was Dr. Bam's message, because he said we need to now not just talk about public health problems, we need to make it the finance department problem, put it on everybody's head. I think that way we can come up with better solutions, quicker solutions, and maybe we need to start asking this question in India here. So that's what I would like to do.
And I second that, because I personally feel, Dr. Baum, what he said is that, yes, you need to get the people who also matter over here. You need to get the leaders, you need to get the government officials. They need to know.
One message is test for all, not for targeted group. Thank you.
No, I second that. I think that's a very interesting thing, because normally we only think vulnerable groups, and if we sort of involve like an entire, like literally like a census, if you do everyone, but I don't, but only thing I don't know is how often can one do that, but it's still an interesting approach, and we can see like how it will work.
A few quick points, Sobha, because in any way you are talking TB now. Is saying that find all TB to stop TB. So if it's you require a massive community mobilization, community engagement activities. Create that environment in the community, create a demand, and the supply side is newer diagnostic tool, medicines, treatment, follow-up, and promote. Ask that question of treatment adherence also. It all follows. Thanks.
Okay, there. So what I have learned is I'm part of the problem and I'm part of the solution as well. So yeah, that's it.
Everyone has to speak, please. You just don't request them, Bianca. Just give them the mic. They have to say something.
For me, starting a moment of test and treat for tuberculosis on the lines of HIV. And I consider this group as a think tank.
So I think while we keep talking about it at a professional level about TB, I think we should also do it at the social level and keep sensitizing people about TB, and whatever knowledge we have, create more awareness.
I think we have to work as if there is no tomorrow, the speed is what matters. And I think all of us have to go invigorated from this session to work faster towards our goals.
Yeah, it was a fantastic sessions, but I think post this, when we're going to be meeting, I would love to meet everyone and see how we can promise to engage ourselves together and see to it that whatever we've learned through the day-to-day is actually put into practice.
No targets, find all, treat all.
I guess continue empowering the community, and also keep on working together, the media and community. Let's not just say that media is another department and we are the public health professionals another department, community is another department. I think we all just need to come together and find a way out. Yeah.
Since I am from radio media, I would like to have the idea of these survivors, interviewing them. And because I really liked, I was touched by the idea that two girls sitting, one could save her husband because of timely testing and appropriate medical intervention, and the other could not. So such, I think, success stories and survivors could make a difference. So I would like to have such telephonic interviews. I would like to request Bobby to share all the mobile numbers so that we form a network. Okay, thank you.
I belong to a group that cleans rivers. It's called Operation Cleanup. So I'm going to go back and do something with that group because we already are there and we work with traditional institutions.
I think the title says it all, multi-stakeholder. I think we need others over here. I think everybody has emphasized that. And find all TB to stop TB. I think that's something that we all have to work on.
Find all TB to stop TB. I think within that, There is a need to focus greater attention on women, I think, because they are the last to eat and the last to avail of any health services. And I think that is somewhere missing today.
I feel that enabling environment for test and treat is very important, and a need to remove the fear which is among people on TB.
हेलो आई थिंक यहाँ पे जो टीबी का जो सर्वाइवर है वो लोग का बात सबसे इम्पोर्टेंट है हम लोगों के लिए, क्योंकि उनके मुंह से उनका एक्सपीरियंस, उनका फाइट, ये हम लोगों को हम लोग नहीं सुन सकते हैं। अभी तक यहाँ आने के पहले मेरी सोच थी कि जो माइग्रेंट वर्कर होती है, जो पुअर पीपल होती है, उनको टीबी अफेक्ट करता है मैल न्यूट्रिशन की वजह से। लेकिन जिस तरह से यहाँ पे सोसाइटी की सभी स्तरों में हमने देखा कि टीबी अफेक्ट कर सकता है और हम लोग उसके बारे में डिस्कस नहीं करते हैं, सोशल स्टिग्मा और समथिंग, कि टीबी इज नॉट लाइक दैट काइंड ऑफ डिजीज कि आप उनको बता सके फ्रीली। तो उनका एक्सपीरियंस सुन के मुझे लग रहा है कि मेरे आसपास के दोस्तों में भी टीबी हो सकती है, तो अगर सिम्टम देखे तो उनको टेस्ट करवाने के लिए बोल सकते हैं। ये मेरे को लगा कि बहुत इम्पोर्टेंट चीज़ है कि मैं मेरी फैमिली में भी टीबी हो सकती है, मेरी फादर मदर को, ये मेरे को समझ आया। दैट्स वाई, थैंक यू।
So we have talked about early diagnosis, जिस पे काफी हमने बात की हुई है। तो इसके अलावा जो है ट्रीटमेंट एज वेल एज जो मेंटल हेल्थ की बात की गई, कहीं ना कहीं वो छूट गई थी। फिजिकल हेल्थ पे वी वर कॉन्सेंट्रेटिंग, बट वी शुड कॉन्सेंट्रेट ऑन मेंटल हेल्थ ऑल्सो। वी शुड प्रोवाइड द काउंसलिंग टू द टीबी वॉरियर्स। जब ट्रीटमेंट स्टार्ट होता है उस टाइम, ड्यूरिंग द ट्रीटमेंट, इवन आफ्टर द ट्रीटमेंट, कि उनको क्या प्रिकॉशंस लेनी चाहिए, बिकॉज उनका माइंडसेट जो होता है कंप्लीटली शैटर्ड होता है। दे हैव अ लॉट ऑफ क्वेश्चन, अ लॉट ऑफ थिंग्स दैट दे डिडंट गेट आंसर फ्रॉम एनीवन। सो वी शुड like focus on this thing also. Thank you.
Hi, I liked what Daksha said. Ask your Prime Minister. I would love to do that. And by Prime Minister, ask the government, ask the authorities from what Dr. Tara said, which is a rights-based approach, demand, which is what has happened with the PLHA. And well, that's my takeaway.
I will focus on community member who are in local TB committee, because the volume and voice must be built from there.
Anyone else? Lata? I think, as Daksha said, that more power to those who are working on ground. And I think they need more support in terms of financial support, in terms of, like those volunteers who are working day-to-day basis on tracking the TB patient. So I think they need more of a, like, I think in these sessions, many spoke about the community health workers who are working on ground. So I think more of, I believe that they are not paid for a long time. So the one demand, which it's very important to terms of thinking about them in more ways, more, if we can do something for them in a better way.
Hi, everyone. My name is Sheetha Chako. Two things I learned from today's session. This is my first experience here. One is that my thinking cap is on now. I'm trying to think of how to reach the self-help groups and the tier 2 and tier 3 cities with the modes of communication. Second, in the 16 years of my career in PR and talking to media, this is the first event I'm seeing where media is here from morning till evening, discussing something so powerful. So much power to all of you.
I second Ramya's thoughts. We have to question the person at the helm, which is Prime Minister. And I'll be frank, because we know that we are not going to end TB by 2025.
And when no less than Prime Minister goes to his constituency and says that we are going to end it by 2025, he is creating problems. He's creating problems because if by chance we declare that TB has ended in our country by 2025 through whatever, and I'll use the word jugglery, then it may affect a lot of funds that come to the program, and it may lead to a lot of other problems. So if we are not able to comprehend this at this point in time, and in 2025, when they declare that India has become TB free, which all of us in this room know will not be truth. And if we are not able to comprehend the importance of this at this point in time, that I believe we will be missing the bus. So we have to question the person at the helm of the affairs. And I mean, without doing that, because media can write as many stories as we want, but then there has to be support from other quarters. You can bash us, you can appreciate us, that's up to you. But there has to be a lot of noise from other quarters as well when our ministers and the Prime Minister go on to say that TB will be eliminated by 2025, like India has already become open defecation free. So that's what I think we need to take care of.
Thank you very much. We have different take-home messages which we have heard from. Sorry.
I'll
Yes,
just
sorry.
keep it short. But my focus would be a lot on drugs and creating accountability for how drugs are bought and disbursed in the community. And I would like to focus on two drugs, bedaquiline and delaminid. And I'll tell you the reason why I'm saying this is because, when you look at drug resistance, then nearly 124,000, around 1.24 lakh patients develop that, in a year. These ranges, you can check the latest numbers. But 60,000 of those multi-drug resistant patients become eligible for bedaquiline. But when we check numbers, then 80% of them do not get them. And this is through the RTI responses. The government in its own admission has said this in court. So, and from 2015 up till 2017, the government had said that 11,000 of those MDR patients had died for the lack of getting that drug, right? So this is how chilling, those numbers are. Only half of them are in annual TB reports. Others, we all have to jointly get by filing RTIs. And this is the line. So if anyone would want to discuss that line with me as to, how do we go about doing that? I don't know how many responses we are going to get, or maybe we need to move court for that again, right? We do not know this, but we have to keep holding the government accountable to keep giving us numbers. Like, I would have the latest numbers till 2021. I don't know what's happening in 22, 23. Things have become more chilling. The effect is so chilling that the numbers from the ministry have stopped flowing to us now, which we were getting 2 years before. And I'm very angry about that. And the second drug is delaminid, right? Now, only 20% of them got bedaquiline. How many got delaminid? Can anyone guess? What is the number of people who have gotten access to delaminid? It was 400 people. It's a joke. Okay. So thousands of them may require that as well. A lot of them are children. And there are emails piling in the health ministry's inbox where the WHO consultant sits saying, my kid needs this drug. We are not getting it here. And a lot of them are dying on the field, right? So we need to also make pharma companies responsible. What is the cost of bedaquiline? It's 24,000 rupees per course that lasts for 6 months. But a patient over the period of 2 years will need 3 to 4 such courses. So it is nearly 1 lakh rupees or more. But at the same time, what is the delaminid cost? It's 90,000 rupees per course. So literally it's like multiple times more, right? Controlled by a Japanese pharma company called Otsuka, right? So these people, we don't have any access. Otsuka had given this to Mylan to produce it in Bangalore in cheaper facilities. That has never happened. The Mylan plant in Bangalore, due to tech transfer issues, is now never produced delaminid. So So we need to also question from the pharma angle as to what is happening there, because the pharma companies are the ones who talk the least, right? And the government is not buying it because clearly, will they want to spend 1 lakh rupees behind a patient to give them the drug that they want, or 25,000 rupees? Clearly, there's no will. There's just a lot of humdrumming. But where are the funds for drugs? I would want to know that. Yeah.
I would just like to add something to what Swapna said. Rightly so. Women are at the receiving end in so many spheres of life. And one positive point is we have more women power in this room than ever before. And I want you to be the change maker. Thank you.
So I think there has been a tremendous take on, and there's a variety of take from each individual that we've just heard. As Molbio, we'll keep continuing doing our bit. And what we wish to take away is that we engage more and more with communities, with all the multi-stakeholders, because we've so far been confined to business and business alone. But we fully understand that it will take a collaborative approach, engaging everybody in the fight towards TB elimination, any other disease elimination in the days to come.
Just my request to the media here. Of course, you have to build a Prime Minister accountability, definitely. But the first request is please also ask the Chief Minister, ask the Minister, State Finance Minister, ask about the TB, the State Home Minister. You know, that's, I think we have to go beyond this, the traditional way that we know that. If there is all TB day, always there is a message from the health minister. Always, if you look at 90 and until now, they haven't changed the wording, only changed the name. Same thing. They will say we are committed, all these things. But can you come up something different story, you know, from the different sector? So my sincere request, please, media, you are around, right? There are many other leaders. Ask the village leaders, panchayat leaders. I think those are, yeah. Also, I say also ask.
Okay, so also is important here. It is important because, of course, asking all of them is necessary. But when message comes from the top that, oh, we are doing so well, 2025 में सब खत्म हो जाएगा. So नीचे के जो लोग हैं वो भी lax हो जाएंगे ना कि हमने तो race जीत लिया, we are almost there. So that is why I thought कि वहाँ पे भी पूछना थोड़ा जरूरी है.
We are also at a veritable risk of, you know, like not vetting numbers, right? So when we are rejecting the WHO annual TB report and saying that India does not believe in the incidence that the WHO is doing through that's mathematical modeling, we are using our own mathematical modeling. Fair enough. But now we need experts like you to explain us what is the difference between these two modeling methods. We want to know. And what are the reasons? And right now incidence has come down by a bit. But what if by 2025, you know, they will make you digest something which is unpalatable to you? Will we wake up then? I don't know.
Thank you so much. Juices are flowing, thoughts are flowing, but there is a time we need to keep to leave the room. But please continue the discussion and conversations at dinner with food. Yeah, so please.
All right, just a wrap up. We unlearn to learn. And now I would like to say, let's not do things like business as usual. I just want to end on one note, like how the Beatles said, come together right now. All right, thank you so much, everybody, for this wonderful. Thank you. Yes, tomorrow, well, we have a dinner tonight. We have a dinner planned for everybody today. On the morning, 8 o'clock, if possible, down at the lobby. And then we are going to the PHC for a visit.
Please, before we leave, just quickly, just Dr. Gilada, please. There is a book, there is a very special book and which Dr. Gilada is gifting to a copy to each one of us. Sir, please explain it to just briefly.
Now, there is a book on blunting of an epidemic. Written by Jayashree Shetty and photographs are by Gopal Shetty. And actually by just documenting last 3-4 decades with me, They were not knowing each other. They got married and then they produced the book on this work. So please carry this book. Thank you. It also has a chapter on Dominic D'Souza of Goa. And you can talk more about the book.
Winnie, where is the dinner? Sorry? The dinner is at the rooftop at 7:30. This is a gala dinner at 7:30 at the rooftop of the up in the hotel.